Good morning, everybody. This is Laura Freed. I'm not going to start the meeting yet because I understand we're still having tech difficulties. The staff has asked me to announce that IT for PEB has said that once the meeting starts, a passcode won't be required, but just in case you need a passcode to get into the meeting, everybody grab a pencil. Passcode 155090. Once again, passcode 155090.
Okay, so Madam Chair, it looks like our YouTube is good to go. So
good.
if you would like to start the meeting, let me know and then we can get started.
Okay, I think what I will do, it's according to my computer 9:08. I think we'll start at 9:10 just to let any stragglers get in.
Sounds great.
Everyone, good morning. I realized I never went to the bathroom before this meeting started, so I'm gonna stop and wait for another minute. If you have to go to the bathroom, now is the time, because now I am going to the bathroom. I'll be back in like 2 minutes. Okay, sorry, everybody. Okay. Good morning, everybody. It is 9:14 a.m. and I'd like to call the meeting of the Public Employees Benefits Program Board to order. Staff, would you call the roll?
Yes. Okay. So Laura Freed,
Here.
Linda Fox,
Here.
Betsy Aiello,
Here.
Don Bailey's excused, Michelle Kelly,
Here.
Jennifer Krupp,
Here.
Tim Lindley,
Here.
David Smith is excused, Marcia Urban,
Here.
Tom Verducci.
Here.
Okay, we have a quorum.
Thank you. Agenda item 2 is public comment. And I know there are going to be a lot of people in the queue for public comment. And board members, we received some written public comment in advance of the meeting, and it was emailed to you. It's also posted on the PEB board meeting materials section of the website. I read all the ones that we got up through last night, and I read some of them this morning, and there are some really heartfelt and thoughtful comments. So if you haven't read them, please do so on another screen while you're participating. And let's see, comments. I think I'll try and limit them to about 4 minutes to let everybody have a chance, because again, I know there are a lot of people waiting, and we started this meeting late to let everybody who wants to comment get on deck to do that. So also, please state your name if you're making public comment. State your name for the record and spell it if it's one of those confusing names that we might get wrong for the minutes. With that, I'll turn it over to PEB staff to do their magic.
Thank you, Madam Chair. Okay, so if you have a public comment, as a reminder, the Zoom phone number is for public comment only. This meeting is being streamed live on YouTube. To listen to the PEB board meeting, please access the YouTube link located on the agenda. I do notice we have quite a few participants that are wanting to share for public comment. So just a reminder, if you've logged into the Zoom meeting, this is for public comment only. For those who have called in during this period for public comment, the last 3 digits of the phone number will be announced and advised that the phone line has been unmuted, at which an audible message from Zoom will say that you are unmuted. After the caller has unmuted themselves, they may proceed with their comments. Because of time considerations, each caller will be limited to 3 minutes. If you don't have public comment, please let us know so that you don't have any public comment at this time. We're going to go ahead and start with Jason Watson. You are unmuted.
My name is Jason Wasden. That's JASON WASDEN. And my public comment is coming from the UNLV Administrative Faculty and the Classified Staff Council. While the UNLV Administrative Faculty Committee and the Classified Staff Council at UNLV understand the desire to keep premiums stable, the proposed changes in benefit structures are draconian and cruel. We cannot express our opposition to the proposed changes in benefits anymore definitively. Many of us experienced our benefits being cut during the recession of 2012, and we are painfully aware that once benefits are cut, they are never restored. We have no reason to believe this proposed cut would be any different. We are frustrated and we are mad that you seem indifferent that these proposed cuts will destroy the health and well-being of the employees of one of the state's largest employers. With the proposed plan design, an individual on the CDHP will pay $2,600 more for their health care until they reach the out-of-pocket maximum. We are already facing a 4.6% furlough reduction in pay for January to June, and we expect possible furloughs in the next biennium. The proposed cuts to our health plan, in addition to the already approved pay cut, will amount to more than a 12% pay cut to an employee's take-home pay. In addition to the increase in out-of-pocket cost, the reduction in the value of the plan received is also proposed to go down. The proposal that PEBP would move from having gold and platinum plans to 3 vastly inferior plans is disheartening and demoralizing. Reducing benefits in this way in the middle of a pandemic is abhorrent. You should be adding to our health benefits, not taking them away. Rather than reducing plan benefits, we argue that plans should be kept whole and that a COVID-19 surcharge in the amount of necessary added premium dollars be applied, with the clear understanding that the surcharge resets when the economy has returned to its pre-pandemic levels. We are asking that this board provide the governor with multiple plans that keep our benefits in place, that create a stable revenue source, and stop balancing the state budget on the expense of state employees. Additionally, we request that the board delay your consideration and vote until your January meeting, when budget savings amounts can be clear, and after the December 3rd report of the Economic Forum further clarifies state revenues. To be quite frank, we are asking the board to consider any other options that do not include reducing plan benefits and increasing out-of-pocket maximums. The administrative and classified staff at our NISHA universities cannot and should not shoulder the burden of our state's economic crisis. Our populations will not weather this storm and will not bounce back. This will cripple our population and thus continue to decimate the economy of the state of Nevada. We implore you to do the right thing. Do not put balancing the budget on the backs of the most underpaid populations at our universities. Thank you for your time and consideration.
Thank you. And Kent Irvin, your line has been unmuted.
Good morning. This is Kent Irvin, ERVIN, representing the Nevada Faculty Alliance, the independent statewide association of NSHE faculty. First, thanks to Executive Director Rich for discussions and for providing information about the proposed benefits cuts. As a state policy, cutting employee benefits to solve a revenue shortfall is short-sighted and wrong. Benefit cuts or premium increases are the most regressive way to tax state employees to fix the budget. Coming on top of probable furloughs, likely no COLA, and an increase in the employee retirement contributions, it is unconscionable that PEB is being asked to make benefit cuts in the midst of the COVID-19 public health emergency when our employees need health care the most. We join our public employee partners in opposing these cuts and hope that the governor and legislature will agree that PEB is the wrong place to cut. That said, we realize that PEB has no choice in responding to the governor's request for 12% budget reserves. We ask that in doing so, you limit the long-term damage to the PEB program in solving a short-term budget problem. Specifically on agenda item 8, the large increases in the deductibles and out-of-pocket maximums in section 8.1 are unacceptable. Large out-of-pocket maximums turn the plan into catastrophic only plans and hurt the members most who are supposed to be helped by insurance, spreading the risk pool to help those with large medical expenses. These need to be reduced to close to the existing CDHP and HMO EPO plans, with the new low deductible plan placed in the middle. Instead of the 20 million of the 36 million savings coming from these plan benefit reductions, it should be limited to much less than that, 10 or 12 million. At a minimum, a reasonably priced middle plan should be in the middle to high gold range in actuarial value. Proposal 8.7 to eliminate long-term disability coverage is completely unacceptable. Without Social Security, state employees who become disabled need a safety net. Nevada has chosen not to participate in Social Security and must provide the long-term disability benefit. Proposal 8.8 to eliminate reimbursement of Medicare B premiums is unacceptable. PEB saves money in claims by requiring Medicare B for eligible employees and should pay for it. Proposal 8.9 to eliminate subsidies for dependents or retirees is unacceptable. Families of already retired employees depend on this. Proposal 8.12, perhaps the worst, is to push non-Medicare retirees into the ACA and Silver State exchange. That is unacceptable. After the legislature finally fixed the orphan problem in 2017, this would create a whole new, larger set of neglected children. We don't even know if ACA will survive the Supreme Court case. All of these proposals just mentioned really carve out some of the most vulnerable populations in PEB and leave them stranded. That leaves the other bad but less bad proposals. We fear it will be necessary in 8.11 to impose a temporary COVID-19 emergency surcharge to premiums to cover a third or more of the mandated reductions. These premium increases should have a definite sunset, be labeled as temporary, and have a trigger to be removed when the economy does come back. Hopefully that's with a vaccine soon. Thank you for your hard work. These are difficult decisions, but we need to limit the damage, the long-term damage to the PEB program as we go forward. Thank you.
Line ending in 003, your line has been unmuted. Line ending in 048, your line has been unmuted. Line ending in 094, your line has been unmuted. Line ending in 101, your line has been unmuted. Donna Healy, your line has been unmuted.
Good morning. My name is Donna Healy, Healy, and I'm here as a UNR classified employee, and I'm also a member and representing the NG Classified Council Executive Board and the Council regarding the need for PEB to determine how to formulate the requested 12% cut. I request that consideration be given to the following. Number one, create all budget changes due to COVID-19 as an emergency temporary COVID-19 surcharge to be authorized for the first year of the biennium only. With the recent increase in health insurance premiums and the 4.6% furlough pay cut, it would be harmful and possibly financially devastating to classified staff if imposed as permanent cuts to benefits and or premium increases. Number two, please keep in mind that any increases in premiums and decreases in coverage would be the most harmful to your lowest paid and sick classified employees with the average pay of around $40,000 per year. Imagine, if you will, facing the challenges of managing a family's or individual's expenses at that income level, especially if having to pay medical costs related to an existing illness. Number three, of all the benefit reductions under consideration, please do not unbundle dental coverage from health coverage. With a restrictive budget, many people will not elect to keep their dental coverage, with dental health being integral to one's overall good health. Not having preventative regular cleanings and exams could be detrimental to overall health and inevitably cost much more than the immediate savings provided to PEB. With that, I thank you for your time and your consideration.
Line ending in 101, you have been unmuted. Line ending in 118, you have been unmuted.
Hello, this is Jose Garcia, Garcia, and I am a 24-year state employee who has actually purchased some retirement time, and I'm getting close to retirement. First of all, thank you for hearing me today. I actually just became aware of some of these changes and just wanted to give you a few comments. I get that we are in a tight situation, that you do have to make some reductions, but I would also like you to understand and know that many of us have made life decisions based on what our benefits are currently. Those of us covering dependents when we retire, those of us younger than the Medicare age, all of those are going to be devastating to our budgets financially. Someone mentioned earlier, devastating. And I just wanted to express that as a 24-year state employee, the benefits have been chipped away at for years since I started back in 1996. I mean, I know times have changed. Health insurance was free when I first started with the state, and since then has gone up considerably. Longevity was eliminated. There's been a number of benefits eliminated. Life insurance was reduced, and now there's a consideration of eliminating it. I would just like all of those things to be taken into consideration when you make these tough decisions. Thank you.
Just a reminder that when your line is unmuted, it's going to tell you that your line has been unmuted and you need to hit *6 in order to talk. Line ending in 237, your line has been unmuted.
Good morning. My name is Marlene Lockard, representing the retired public employees of Nevada. Today's agenda poses difficult questions and decisions you will have to make as a member of the PEB board. It is indeed a very difficult time for our state in trying to preserve critical services, programs, and compensation and benefits for the state's workers. All this while facing ever-increasing negative economic impacts as a result of COVID-19. We know the pain that will ensue at all levels of government will be severe. We understand the directive given to all state agencies to cut their budgets by 12%. We also understand and appreciate the hours of hard work that Laura Rich and her staff have expended to deliver a substantive package to you for your consideration that complies with the governor's order. We appreciate her efforts to include the advocates in preliminary discussions and to keep us apprised of each step. We believe we have a responsibility to offer input on other ways to meet the 12% challenge that would perhaps offer a more successful path to recovery and restoration of benefits. The advocates work daily with their respective constituencies and understand how profoundly these proposed cuts will affect vulnerable populations like our seniors with fixed incomes who rely on that $1 per year service to their HRA account, or life insurance to pay for their ever escalating costs of burial. And the proposal to move early retirees to the state health exchange is so fraught with unintended consequences and hidden costs. It also creates yet another tier of state employees. I personally lived through the hastily approved and incredibly poor implementation of the decision to throw Medicare retirees out of PEB and into an exchange in 2011. What never gets mentioned is how much money Medicare retirees left in PEB and the annual millions of dollars of savings that PEB enjoys every year as a result. I implore you to consider the alternate proposals being submitted to you today. Retirees have contributed mightily to helping the state meet the economic challenges of the past and will continue to work with you, the governor, and the legislature to meet this crisis as well. Thank you very much.
Line ending in 238, your line has been unmuted. Line ending in 282, your line has been unmuted.
Hello?
Hi, Doug, we can hear you.
Mr.
Okay.
Unger, yes, please go ahead. Sorry, Nicole.
Yes, Doug Unger, D-O-U-G-U-N-G-E-R. I'm a member of the UNLV Employee Benefits Advisory Committee and the UNLV chapter president of the Nevada Faculty Alliance. And I'm speaking only for a small group of us because really our constituency is divided between a group that is so vehemently opposed to any of these cuts and remedies that they want to kick it all back to the governor and the governor's finance office and say an emphatic no. And another group of us who understand that we really must come to the table and try to assist the board in making the 12% budget reductions. We wish to express our sincerest gratitude to Executive Officer Laura Rich for working with us and letting us know about these proposed cuts, and to all of you for your serious consideration of possible alternatives for actions on Agenda Item 8, which taken all together can and will radically diminish health and other benefits for state employees for years to come. What we're basically proposing, the group of us, and you've heard from the Vice President of NFA and Kent Irvin and others, is a 3-pathway solution to achieving the 12%. For Agenda Item 8.1, we very strongly recommend not changing the deductibles and out-of-pocket maximums on the plans, and looking at a premium surcharge that will balance out and reach that 20.1 million target that is being proposed in the new plan design. This may require postponing your vote on the new plan design until some future date, perhaps the January meeting, when we will also know more about the condition of the finances in the state, and the State Economic Forum will have reported on December 3rd. Mainly for agenda items 8.2 to 8.12, and in a written comment, I've outlined what we could do for the other third of that is to achieve $10.5 million by hitting a little bit the minimum amounts of those proposed budget reductions. We are vehemently opposed to any cuts to 8.7, 8.8, 8.9, and 8.12, as we consider all of these to be unconscionable and unethical breaches of promises and violations of trust. Eliminating long-term disability coverage in a state system that has opted out of Social Security is too cruel to contemplate. Other provisions will upend entirely retirement plans and existing retirement, causing unanticipated financial distress. And even to consider dumping non-Medicare retirees off into an insurance exchange, the very future of which hovers in doubt because of shifting federal policies, is draconian in the extreme. Please do not consider passing any of these actions. If you do raise premiums on a different plan design and call it a COVID-19 pandemic surcharge, that will allow state advocates to approach the legislature and ask that this be sunsetted first, or the first budget implementation to be removed should the state budget situation improve, which we have every expectation that it will over the next two or 3 years. Compromise means working out differences to accommodate the desires and interests of the many for the benefit of all. We know a just compromise when we see it or hear it, and we hope you see and hear the balance and fairness of this 3-pathway action plan we propose for you to meet the challenging budget demands you must act on today. Thank you again for your consideration. Thank you to Chair Freed and all on the PEB board and staff for your service to our state. Thank you.
Line ending in 304, your line has been unmuted. Line ending in 338, your line has been unmuted.
Good morning, Chair Freed, members of the board. This is Priscilla Maloney with the AFSCME retirees. Can you hear me?
Yes, we can.
Thank you. Chair Freed, I would like to read my statement into the record, and then with permission, I know we normally would submit these ahead of the meeting, but given the crisis that we're in, I would like permission when I'm done to also then submit this to the email address on the agenda as part of the record for today's meeting if that's acceptable to you.
That is A-OK, Ms. Maloney.
All right, well, thank you. November 23rd, 2020, Priscilla Maloney, representing the Nevada Retiree Chapter of Local 4041 AFSCME. To the PEB Board in regards to today's meeting and agenda item number 8, it was announced several years ago by our governor through his finance office, the GFO, that all state agencies, including PEB, would be required to slash budgets in anticipation of a coming budget crisis precipitated by a deep decline in state revenue caused by the public health crisis of the localized effects of the global COVID-19 pandemic. It is our, and this is in parens, the retiree chapter of Local 4041 AFSCME's understanding that this board will be asked today to review cuts to benefits and increases in costs to the PEB members, both active employees and retirees, that are outlined in 11 subcategories under the agenda item 8, and then prioritize them so that PEB staff can submit a revised budget to the GFO as, and this is in quotes, as soon as possible. It isn't clear, I believe, at least to me as a member of the advocacy groups, exactly the time constraints we're under. I know we are under those. Our objections to this process, these cuts, and the underlying basic public personnel fiscal philosophy that these proposals are built on are many. First and foremost, whenever there is a fiscal crisis in Nevada state government, the default, and this is emphasized in bold, is immediately to look to cuts in benefits to both active employee and retiree state provided health care insurance in combination with reductions in pay for active employees through furloughs, pay freezes, and the like. As we are sure you will hear from active employees today, this is a dysfunctional way to govern while maintaining a robust workforce through recruitment and retention. The state workforce in general has not recovered from the cuts in benefits and pay imposed over a decade ago in the 2009 session and beyond. With regards to specifically to agenda item 8, it is important to note the advocacy groups have met, and we thank her. This is not in my written remarks. I should have put more adjectives in here like wonderful and hardworking and tireless Executive Director, Ms. Rich. And there seems to be consensus, just to make the record clear today, that the proposals in subcategory 8.2, 8.3, and 8.4 are not an issue. The AFSCME retirees do oppose the cuts and changes as set out in 8.5, 8.6, 8.7, 8.8, 8.9, as well as 8.12. Subcategories 8.10, unbundling the dental premiums, and 8.11, the premium costs to be factored in by Aon are still being discussed, is our understanding. Finally, the changes as explained to the basic plan designs in Table 8.1 are applicable to both active employees and non-Medicare retirees. It is crucially important to note that non-Medicare retirees are grouped differently. The pre-Medicare retirees, for purposes of this discussion today, are those that are eligible for Medicare when they become 65. The non-Medicare retirees involve several groups, as Nevada, as the employer, was not paying into Medicare for several years after it was first created in 1965. Globally, those retirees have always in the past been defaulted to one of the PEB offerings, as some will never be eligible for either Medicare Part A and B, and some only eligible for Part B, and I put in parentheses agenda items 8.8 and 8.9 for how that will affect those folks. We have asked PEB staff for clarification on the numbers of each of these categories. I note that Ms. Rich has put down that subcategory 8.8 will affect apparently 1,100 members, and 8.9 will affect 2,106 members. But again, breaking it down by which folks are non-Medicare versus pre-Medicare retirees would be helpful for this discussion today. So finally, one member of my asked me retiree comments. I asked him permission for him, he's a little shy, to make his statement in public comment, and he preferred me read it into the record. He says, first, what was the point of making a career out of public service? I never expected to get rich enough to provide my own benefits during active or retirement years. I accepted the pay, and my understanding of my retirement years when I chose this path back in 1972. And now it seems my former employer is asking, why am I not dead yet? Second, as benefits are taken away or reduced, how many employees and retirees simply won't seek services they may need because they can't afford it, like dental or prescription drugs? Retirees who plan, and that's the end of his comments, retirees who planned their entire careers and lives in public service deserve better than these proposals. We understand the urgency, we understand the crisis, and this is the final concluding point, the proposal in 8.12 is beyond the scope of time limits for public comment. There are many aspects of this proposal that are highly uncertain. The Economic Forum has not met yet for the final time this year and will not until December 3rd, 2020. The future of the Affordable Care Act is unknown, and thus the fate of the Silver State Exchange is unknown as well, as the federal case challenging the Affordable Care Act's existence was just argued and submitted to the U.S. Supreme Court on November 10th, 2020. In these circumstances and climate of both a public health and fiscal crisis, haste is not the friend of sound policy. These challenges will need the full attention to details from both Nevada's executive and legislative branch. Thank you very much.
Line ending in 354, you have been unmuted. Line ending in 404, you have been unmuted. Line ending in 490, you have been unmuted. Dustin, you have been unmuted. Ian, your line has been unmuted.
Good morning. For the record, my name is Ian Knight. That's spelled I-A-N-K-N-I-G-H-T. And I am an active state employee, and so is my wife. In consideration of Agenda Item 8 this morning, I want the PED board members to know how vital it is to have input from all state employees. So in addition to whatever recommendations you make today, I want to see a survey go out to all state employees asking them to do the same ranking that you are doing in Agenda Item 8. And I want the results of that survey shared at the same time as your recommendations are shared during budget presentations to the legislature. I also want to see each board member show up to the legislature during the PEB budget hearings and express clearly that PEB should be exempt from the governor's recommended budget reductions because increased premiums or reduced benefits during a pandemic is just plain wrong. I also want to know what each board member has done to stick up for us to urge Congress to pass additional relief for state and local government budgets so these cuts don't have to be made. If the board members have engaged with our representatives and senators in Congress, I want to know the extent of the interaction. If the board members have not reached out, I want to know why not. That is all that I have to say. Thank you for your time.
Line ending in 500, your line has been unmuted. Line ending in 502, your line has been unmuted.
Good morning. Can you hear me?
Yes, we can.
Thank you today for the opportunity to speak with you all. I appreciate the chance. My name is Jerry Beam, B-E-A-M, and I have worked for the state in a supervisory role for 8 years. I currently work for the Office of the Military. Excuse me. I strongly oppose the cuts to our health care benefits. I understand that when a crisis affects an organization, that cuts must be made. I, however, don't feel that this should be in an area that can or should be cut, given the nature of a medical pandemic. Our health insurance is one of the few good things about working for the state. As a supervisor, I already have limited applicants due to 20 to 30% less than market rate wages. If the state would have made serious attempts at bringing up our income to keep up with the rising costs in our society, our health insurance would be more easily acceptable to these types of cuts. For the state to cut benefits to retirees is unconscionable. By shifting the program to a fund instead of directly being responsible is just another way to begin to care less for the employees who have earned the care that they deserve. As the other speakers have pointed out, the state has chipped away at the employee benefits for years, and I have witnessed it in my limited employment with the state. In summation, the healthcare system is the best asset the state has going for getting and keeping employees, but certainly it isn't the pay. Thank you for your time.
Line ending in 642, your line has been unmuted. Line ending in 643, your line has been unmuted. Line ending in 650, your line has been unmuted.
Good morning. Can you hear me?
Yes, we can.
Thank you. For the record, my name is Maria Shellhace. That's S as in Sam, C-H-E-L-L-H-A-S-E. I'm a professor at the College of Southern Nevada. My colleague, Dr. Jet Mitchell, was diagnosed with stage 4 breast cancer and lost her battle in September despite a valiant fight. Some of you might remember Jet as she was a community college representative on the PEP board. Dr. Mitchell was an advocate for faculty and often spoke up about the need to improve quality healthcare options while reducing and maintaining the costs for faculty. As the Faculty Senate Chair at the College of Southern Nevada, I've received many emails and phone calls from faculty who are extremely concerned about the proposed changes. Please consider the following. With a 4.6 furlough in place and the possibility of more cuts in the future, is it responsible to increase rates or change plans now? Is it responsible to reduce the healthcare options and increase benefit costs for retirees and others like Dr. Mitchell who need it most? Cuts in benefits will negatively affect faculty retention and recruiting efforts. I understand that we have a budget crisis on our hands. However, if we do not have our health, we have nothing. Now is not the time to approve changes or make reductions. I urge you all to maintain the cost and benefit options currently offered and to wait to make any hasty decisions. Thank you for listening.
Amina, your line has been unmuted. Line ending in 754, your line has been unmuted. Line ending in 764, your line has been unmuted. Line ending in 884, your line has been unmuted.
Good morning. Can you hear me?
Yes, we can.
Great. My name is Raven Sumner, Sumner, and I am providing this public comment as an active UNLV administrative faculty staff member with 16 years of service. I understand the challenging financial and public health issues encompassing our state. We have weathered economic recession before, but this time we are faced with the impacts of a global pandemic, which has challenged us to new heights. While state employees are facing furloughs, which may very well continue into the next biennium, these dramatic cuts to our access to health care is dangerous and causes further harm to our physical, emotional, and mental health. The cuts to our benefits from the last recession were never, ever restored. Personally, I have outstanding loans that I had to take out for my surgery, my radiation treatments that I also had for my brain tumor and my optical nerve. Every year, my high out-of-pocket expenses for my continued treatments pile up on top of my loans. There are expenses this current insurance does not include, which includes things such as the travel I have to take to UCLA Medical Center and my vision care, which costs me out-of-pocket expenses every year of about $1,500 or more. I implore you to please rethink these cuts and the impact it will have on the hardworking and loyal employees. Thank you.
Line ending in 909, your line has been unmuted. Line ending in 943, your line has been unmuted.
Good morning. Thank you, Madam Chairwoman and Board, for the opportunity to speak. My name is Janelle Woodward. That's JANELLWOODWARD. And I am a state employee, a member of AFSCME Local 4041, and the PEB and PERS Committee member. We have already heard many comments regarding agenda item number 8. This pandemic year has truly impacted everyone from a personal level and from the state budget level. Who could have foreseen such a difficult time and the need for very difficult decisions? From a personal standpoint, I am an advanced breast cancer survivor who was already left with large amounts to pay for my medical treatment secondary to the cuts and changes to our health care plans 2 years ago. Of note, my bills are in collections. As a former user of the Silver State Health Exchange, a move by PEB to this exchange would be detrimental to state employees. These plans are unaffordable and non-sustainable and cover almost nothing. These proposed changes would be devastating to me and to my fellow state employees. Many employees are already in a situation having a difficult time living paycheck to paycheck and adding to this situation by making these cuts or trying to rebuild the reserve when we already have a difficult time making a living is unconscionable. In this year of a major pandemic, I have both continued to work my essential position, and I also spent a week in the hospital, which significantly increased my debt load. Please do not cut our very important medical benefits further than they already have been. Having worked 28 years in healthcare, I understand that we need to find savings. However, as one of the largest employers in the state, we have some of the worst benefits. Look to the hospitals that have very low cost plans and good benefit coverage. They are low because they utilize their own insurance programs. There are many options that could be considered instead of just cutting everything. Please consider further alternatives to provide the governor and do not make employees bear the load of needed costs that we are already facing with our pay cuts. Thank you very much.
And just as a reminder, when I unmute your line, you will be asked to select *6 to unmute your line. Margaret, your line has been unmuted.
Yes, this is Margaretha L. Miller, spelled M-A-R-G-A-R-E-T-H-E, middle initial L, last name Miller, M-I-L-L-E-R. Good morning. I am a retired 30-year state employee, and I've already sent you an email outlining my concerns with several of your agenda items today. First and most concerning is the 8.12, my removal from having major medical coverage to having none because of my age, which is 78, and my income, which is approximately $45,000, and where I live, which is Churchill County. I have looked into my situation and have found out that due to my age of 78, my income of $45,000, that I will not be qualified for any discounts and will have to pay over $1,800 a month to get any major medical plan on any of the exchanges. And I do not qualify for Medicaid, as again, that is income based and I make too much and also I'm kind of old. Most retirees are not 78 years of age. Most retirees qualify for parts A and B. I do not. I have never worked outside the state of Nevada. I consider myself a notch baby of the state of Nevada due to the fact I started working for the state at the age of 17, and I have stayed till retirement 30 years later. The state of Nevada did not start paying into Medicare until December of 1989. I retired with my 30 years at November of 1989. The details are in my email. I also have concerns with the 8.8, the elimination of my Part B subsidy. This is what helps me to be able to afford to have an affordable major medical plan. If you eliminate this, I will be paying over $250 more a month. I am a 78-year-old widow, and I'm already on a reduced income. And if you reduce or eliminate, my income will even be further reduced. The third item I have concerns with is your 8.6, the reduction or elimination of the basic life insurance. Because I'm 78 years old, I have no possibility of getting any more life insurance or even paying for more. I would hope that you will be able to find other avenues to cut instead of gutting the majority of my 30-year retirement benefits at my age of 78. It is the state of Nevada's fault that I and many others like me find themselves in looking at a major reduction in our benefits. I view this as age discrimination and in a form of genocide, as I am unable at my age to earn more income, buy more life insurance, and my major medical coverage, which is part of my 30-year benefits, will be non-existent. The result will be taking away any quality of life for me, especially in this time of coronavirus, the coronavirus pandemic. My suggestion would be that the state of Nevada would step up to the plate and work out some type of payment arrangement with the government or whoever has control over that, that I and others who are similarly affected have an affordable major medical plan. And I really don't know, what the answers to this are. As a 30-year retired state employee, I've been through many budget cuts and many budget planning and that. And so I think it's pretty tough. So I submit that perhaps there's other possibilities that won't drastically affect me, because at my age, I really don't know what I'm going to be able to do. Thank you for your time, and I appreciate it. And I know you have a hard thing to do. I appreciate your time. Thank you.
Line ending in 960, your line has been unmuted.
Good morning, and thank you for allowing me this opportunity to speak. I too am a member of AFSCME Local 4041 and a long-time state employee. I've worked for the state for over a quarter of a century and still am working. When I started with the state, myself and my family, like many others have stated, were covered completely and the deductible was affordable. My dental deductible, for example, when I started, was $100 for a lifetime. Well, my life is not over, but my deductible has changed. Not surprising. I have a friend who works for a small California county and has better health benefits than I do working for the state of Nevada. And it just amazes me, and I don't understand. One of the things that I don't understand also is every time there's a budget deficit, it always falls on the backs of the state employees. And we are already not working at a living wage. And our basic living expenses are not even keeping up with our salaries, because our basic living expenses are increasing faster than our salaries. It is extremely important to keep the Nevada state employees as healthy as possible, especially during this pandemic. We have to keep our state alive, and therefore we have to keep our state employees as well as possible as well. I do thank you for your time, and I understand your situation, because all of us are facing the same in our homes, in our work, and in our country. And I thank you for your time, and enjoy your Thanksgiving.
Line ending in 968, your line has been unmuted.
Good morning. My name is D.T. Allen. I am an employee with the Department of Health and Human Services, and I'm also a member of AFSCME Local 4041. Thank you all for listening to these comments here today from so many of us. With the many uncertainties of COVID as a new infectious disease, and maybe as much as half the people in disagreement as to the severity and even actuality of the virus, I do see your efforts to protect you, but you must see how your proposed changes will almost certainly devastate the very workforce that has been and would continue to provide essential services. I know for me and my family, there are medical needs that we cannot afford to have disrupted. And if they are disrupted, the hardship created will certainly have a negative impact on my ability to work. I imagine you foresee the same for many families. Please consider the viewpoint that with pay more and get less proposals that you're making, you are flirting dangerously with being more of a burden than benefit. I ask that as we provide the services we were all hired to do, that you do the same. We are all being tasked with doing our best under very tight circumstances and conditions. And I respectfully say, I believe that you can do better. Thank you.
Line ending in 987, your line has been unmuted.
Good morning. Can you hear me?
Yes, we can.
Good morning. Can you hear me? Fabulous. Thank you. My name is Cameron Hopkins. I am 28 years old, a state employee with DHHS, and a member of AFSCME Local 4041. I speak to you today in opposition of the proposed cuts to healthcare benefits and the proposed hikes in premiums in the midst of a global pandemic. While some state employees have the opportunity to work remotely, many more do not. Nevada state employees interact with the public on an almost daily basis in ways that cannot be done remotely. CPS workers still need to go into people's homes to protect our children. Aging and disability workers need to see that our elderly are safe, and corrections needs to ensure safety in close quarters environments, amongst many others. Public services see more people during times of economic upheaval when Nevadans need us more than ever. Even with the greatest precautions, state employees put themselves at risk to serve their fellow Nevadans. We have done our job during this pandemic, and we will keep doing our job while our communities need us most. This dedication should not be taken advantage of by the state. We still have medical and dental needs that for several months were unable to be addressed. During this pandemic, dental offices were closed for months. Elective medical procedures were delayed, and even routine physicals were postponed. Cutting these benefits now, when these medical and dental services are so overwhelmed that some people can't get in for months, takes these services away when they are most needed. Public services are already stretched razor thin, and our workloads continue to grow heavier. Hiring freezes mean we're taking on the work of those unfilled positions. We're taking on the stress of the pandemic like everybody else, and additionally taking on the stress of the public we interact with. Stress wreaks short and long-term havoc on the human body in terms of both mental and physical health. Cutting benefits will increase stress on state employees and their families even further, and the increased financial burden will force employees to make impossible choices on salaries still recovering from the last recession. Please don't make our lives harder in the midst of a pandemic. Thank you for your time.
Kevin Rampt, your line has been unmuted.
Hello, can you hear me?
Yes, we can.
All right, good morning, Chairwoman Freed and committee members. My name is Kevin Rampt. I represent AFSCME Local 4041, active state employees. I would first like to thank you and PEB staff for all the hard work during these difficult times. I would also appreciate Laura Rich for reaching out to us as an advocacy group dealing with the hardships of PEB and the revenue issues that PEB is facing. With the challenges that come with surviving a pandemic, state employees still have regular medical needs that they'll clearly be affected by these cuts. The design plan, by cutting just by itself $20 million, this really not being discussed today. This is really going to change the dynamics of how employees utilize their health benefits, or should I say, really no benefits, without having on the back end numerous expenses that they cannot afford. State employees have done their job during this pandemic and will continue to care for not only all the citizens of the state of Nevada, but for their coworkers, and ultimately they have to go back and take care of their families. That's what these benefits are for. These benefits are to ensure that their health and their well-being of them and their families, they have that ability to do so. Without that, they cannot provide the services to the state of Nevada and to the communities around them. As the governor is asking for 12% proposed reductions for his consideration to build his budget for GovRec, healthcare benefits are not the place to cut, as it dramatically harms the employees and their families. We are strongly opposed to the benefit cuts being proposed today. Respectfully, we ask that this board reach out to the governor and tell him that you cannot make this big of a cut. Making a 12% cut in benefits is not realistic, nor is it viable. Further, we are opposed to any increases to premiums to fund the reserves. Millions of dollars was just released from the reserves and sent to the general fund. There has to be other alternatives to fund the reserves. In a normal time, it would be appropriate to build a plan design during this meeting. However, we are in a pandemic and there are numerous unknowns. Is there going to be a federal stimulus? We don't know. We are very hopeful to fund the front lines. What is the projections going to be in December with the economic forum? We don't know. Again, there's a lot of unknowns. The governor is asking you to send a proposal, not to gut the benefits of state employees, but just to merely present a proposal. By voting today, you are etching the plan design that will seriously impact the lives and well-beings of state employees. The family lives are the most, families and state employees ultimately are the most vulnerable. Further, retirees, as it really is just going to take the brunt of this when it comes to the standalone of these cuts. We should not be addressing this at this moment. We really need to look at what the revenues are and then come back and address what's going on with our benefits, our plan design, and everything that relates to a PEB. I implore this board to send a clear message that you cannot gut you cannot cut the governor's 12% request. These cuts should not be on the backs of state employees and not on their health care. State employees know going into the state jobs that they are paid less than city and county employees. They took this job knowing that the benefits would be a part of their overall employment package. Again, the governor is asking for a proposal, not implementation. Finally, you are being asked again by this governor to make this recommendation. I urge this board to really look at what the other alternative options are. Asking the governor for a lower percentage, 12% is not viable. Basing the employer portion on fiscal year 22 is what you guys are really looking at as a standpoint to be similar to what fiscal year 21 when it comes to the employer portion. We cannot assume that that's going to be the case. The employer portion of fiscal year 22 could be different. What happens if that takes place? That can ultimately, the employer portion is going to have a dramatic impact in regards to premiums of state employees. That leads me into a lot of discussion today by some of the individuals speaking earlier. That would be an immediate increase to premiums in regards to the COVID-19 surcharge. You can call it what you want, respectfully, and I respect all of the individuals that spoke about a COVID-19 surcharge. Unfortunately, this would not be a fair across-the-board cut, and again, would be a direct out-of-pocket expense. This could not be applied to all PEB participants, and with the unknown impact to state revenue and unknown what legislators are going to do, the COVID-19 surcharge, as discussed, would not be viable. As state employees, we are facing furloughs, PERS contribution increases. On top of that, employees will be they're required to work 2 or 3 positions to fill the void of positions that are being affected by the hiring freeze during this pandemic. We ask you to suspend any vote on PEB reductions or premium increases until January, when the state will have a better idea of the incoming revenue. PEB's budget will ultimately need a legislative review. With that being said, we thank you for your time and consideration. Thank you.
Nina Marie, your line has been unmuted. Priscilla, your line has been unmuted. Robin, your line has been unmuted. Sarah, your line has been unmuted. Madam Chair, the public comment has been completed.
Thank you. This is Laura Freed. We've been at this already for an hour plus. So what I think I'm going to do is give everyone a 5-minute break to go to the bathroom, get a drink of water, and just in case anybody had trouble unmuting themselves and still wanted to make a comment, let's see, it's 10:24. Let's call it 10:25. Everybody please be back on at 10:30 and I'll double check for any more public comment. So I'll see you all in 5 minutes. Thanks.
On top of that, I would like to add that if you did join the meeting for public comment, that you hang up via Zoom and you join via YouTube. That way we can see who's still in the queue that has current public comment to make.
All right, this is Laura Freed. Good morning again. It is 10:30 and I'll call the meeting back to order, and I'll check once again with PEB staff if there's anybody who had public comment to make who logged in via the YouTube stream and wants to make public comment and had technical difficulties previous to now.
It doesn't look like we have any new numbers, Madam Chair.
Okay, thank you. Then with that, we will move to agenda item 3, PEB board disclosures for board meeting agenda items. And I'll pass it to Deputy Attorney General Mooneyhan.
Thank you, Madam Chair. This agenda item is to allow me to make a disclosure on behalf of all of the PEB board members who are eligible for PEB benefits. Of course, most of the items on today's agenda have an indirect effect on PEB benefits, but in particular, item number 8, which deals with proposed plan changes for the next year, relates directly to PEB benefits that may be available to members, including most of the board. Pursuant to NRS 281A.420, on behalf of those board members who are eligible for PEB benefits, I'm offering this as a general disclosure that they may be voting on items that affect the benefits that are available to them or their family members. I note the law does not preclude them from voting on these items. And I would invite any board member who has any additional disclosure to add to do so now. Thank you.
Board members, if any of you feel that you would be affected more than anybody else by anything on the action agenda, now is the time for disclosures. If not, we will move on to number 4. Okay, so agenda item 4 is the consent agenda, and we have 4.1 through 4.5. I hope you've all reviewed those. And as per usual, I will accept a motion to take all of these items at once in one motion, unless there's a board member who wishes to pull one of these items for discussion. So do any of you wish to talk about anything in item 4?
This is Betsy Aiello. I just have one question on item 4.5 I'd like to ask.
Okay, please go ahead.
I know the audit report is just saying that everything looked good the way they put it together, but I had a question about the 5.6 million, trying to understand loss that is on page 3, or in the board packet, it would be page 130 of 191. And I'm just trying to, and I would like it if someone could explain to me what the 5.6 million loss at the end of the year was, and how that would impact some of the things we're talking now about.
Okay, so I think this is, yes, as you say, this is page 3 of the State Retirees Health and Welfare Benefits Fund, summary of the net position for 2020 of excuse me, minus 5,651,615. Do I have that correct? Okay, Ms. Rich, can you field that one, or do you want to hand it off to Casey Nealon?
Actually, I think Carrie Eaton is able to answer this with possibly the support of Casey Nealon as well.
Thank you, Carrie Eaton for the record. The net position is mostly due to the liabilities of the $11.7 million. And the liabilities are that high because it's just the timing of the RGGI funds that were transferred over the year. So anything that was transferred after June 30th has to be booked as a liability. And so I think it's just mostly the timing of when those revenues came in and were transferred to our main account.
Okay, so it's not really a change in how something's functioning. It's based on when the report was completed, is what I'm hearing. Thank you.
I believe so, but Ms. Olson can correct me if I'm wrong.
No, you're not wrong, Carrie. These financial statements are prepared using full accrual gap standards. And therefore, anything that was received post 6/30 was accounted for as either a receivable or a payable or a liability, sorry. And in this case, that's where that 11.7 million came in. So they're accounting for items that were paid that belong to the fiscal year, but were paid subsequent to June 30.
Okay, board members, any other questions on any of the reports in item 4? I have one question on 4.2. It seems in Health Claim Auditor's report, there were a number of dental claims that had the diagnostic code D1999 for PPE. There was clearly some dental, like a lot of dental billings for personal protective equipment that was not covered. Has this been discussed with the dental network provider on a more global scale?
For the record, Laura Rich, this has not. Mary Catherine, do you have any insight on this?
Yes.
And I know unfortunately Bob Carr, the auditor, is not on today, but I'm thinking Mary Catherine might be able to provide insight.
Yes, this is Mary Catherine Pearson with HealthScope Benefits for the record. This actually, we were able to discuss this with the dental network. So initially this code was listed on their fee schedule as what we call a by report code, or so that it went to a certain type of discount arrangement. They later clarified once the Nancy Spinelli and others were involved, that code should actually not be covered. And so the decision was made to not go back and reprocess claims for members who had already had those claims processed, but to leave those providers as they were. And then going forward, once Diversified Dental provided that clarification, then we put that clarification in place, and then those are no longer covered. They're not member responsibility. I want to make that clear. It is provider responsibility. So it does not add any cost to the individual patient.
Okay, thank you for that clarification. Yeah, I noticed there were 4,000 plus claims identified per Bob Carr's notes, and I would assume that's because some of them were older than a year and the administrative burden of repricing them would be tremendous. So, okay. With that, I will accept a motion from the board to accept all of these reports.
Linda Fox, for the record, I will make that motion.
Thank you, Vice Chair Fox. Do I have a second?
Jennifer Krupp, for the record, I will second.
Thank you. Any discussion on the motion? All right. Hub staff, are we still doing roll call votes because we're on Zoom, or because everybody's on camera? Do you want us to all raise our hands if we say aye and then raise our hands if we say nay? How would you like to handle this?
For the record, Laura Rich, I think in this situation, I think we're safe to probably just
okay.
Probably agenda item number 8 is going to be a different story.
Mm-hmm. Okay, well, with that, all in favor, please raise your hand so we can see you. Great. Any opposed? Okay, motion carries unanimously. Thank you. All right. Moving on to agenda item 5, discussion and possible action to approve a 6-year contract beginning January 1st of 2022 with LSI for an enrollment and eligibility benefits system. Take it away, Ms. Eaton.
Thank you. Carrie Eaton, Chief Financial Officer, for the record. PEB is requesting that the board authorize staff to award a new contract to LSI Consulting to provide eligibility and enrollment benefit management system services in response to the RFP that was released on July 1st, 2020. On August 14, 2020, PEB received 6 proposals. The 6-member evaluation committee that included 2 PEB board members evaluated the proposals from August 15th through September 11th. LSI Consulting received the highest score from that evaluation committee. PEB staff has completed negotiations with the vendor and would like to bring the contract to the December 8th Board of Examiners meeting to allow LSI Consulting a full year to complete the implementation and transition from our current vendor. The effective date of the contract is anticipated to be December 8th upon BOE approval through June 30th, 2027, with an option to extend to June 30th, 2029. Implementation will begin upon BOE approval, while the services and associated fees are expected to begin on January 1st, 2022, after the implementation is complete. The maximum amount of this contract is $6.8 million, and staff is recommending that the board ratify the evaluation committee's recommendation that a contract be approved with LSI Consulting to provide eligibility and enrollment benefits management system services. And I can take any questions.
Board members, any questions on this contract?
This is Laura Rich for the record. I just want to make one correction here. We actually received 3 proposals, not 6. So I just want to make sure that that's corrected for the record.
Sorry about that. There's too many of them. Getting them all mixed up, maybe.
Right.
Chairperson Freed, can I just ask a quick question?
Sure.
So the $6.8 million, is that for the 6 years of the contract, or is that per annum?
This is Carrie Eaton again for the record. That is for the 6 years of the contract.
Thank you.
I have a question. How does the per person per month charge for the new vendor compare to what we pay our current vendor?
This is Carrie Eaton for the record. This is a increase to the per person per month charge. And I can get the exact numbers for you, but we have renegotiated our current contract many times. So our per member per month fee for our current vendor is very low. But we did negotiate out implementation fees and things like that with this vendor as well.
Okay.
While Carrie's looking that up, I do want to add that we actually, PEB put out an RFI earlier this year, and we received several responses on that RFI, and we're expecting industry standard is much higher than what we're currently being charged by our current vendor. So we were expecting higher fees. And I believe that the first 2 years of, and I hesitate to say this, and maybe Laura, you can tell me if this is appropriate, but is it appropriate to talk about the per member per month fee that was negotiated at an open meeting like this, or is it too soon?
Well, I wish I had the purchasing administrator or the team lead for the purchasing officers to tell me that. Where I wish I could answer, and I'd have to look through NRS 333 to see if there was an actual specific prohibition on discussing the fiscal details. But for me, it was thinking about, as I normally do, did we budget for a higher PPPM in our agency request budget? Because of course that plays into our discussion on item 8, and with what, about 70,000 covered lives, we've got to account for the difference between what we're paying currently and what we'll start paying in the middle of FY22 when this contract is set to begin. And can we cover that with what we have now?
So for the record, Laura Rich, the answer to that is yes. We anticipated this. This was the reason that we put out an RFI earlier this year, is to understand what the industry standard was going to be and what the expectation would be when we, if and when we went out for to bid on this. And when we submitted our agency request budget, we definitely took in the responses into consideration, and we did budget accordingly to those responses. So yes, we are, the PMPM is within the budgeted ranges.
Okay, that's reassuring. Board members, more questions about enrollment and eligibility contract?
Yes, Tom Verducci for the record. After going through the RFP process, did we experience any cost savings as a result? That's an appropriate question.
So for the record, Laura Rich, yes, we were able to negotiate a lot of the proposed costs out of the contract. And so I feel pretty good about where this contract has landed, and the opportunities that we have working with this vendor moving forward. So I would say, yes, it is still coming in higher than what we are paying for today. But like I said, it was expected due to the responses in the RFIs that we received earlier this year.
So we're looking at a December 8th Board of Examiner approval. And from there, when will the implementation date be? Am I looking at approximately January 1 of 22?
For the record, Laura Rich, yes, we will be, the organization, the company will start, LSI and with Benefit Focus will be starting their implementation immediately, as soon as it gets approved at the Board of Examiners. This is a big implementation. It's going to be a big project, and even with a year's time frame, we're still cutting it close. And so they're hitting the ground running as soon as we can get this approved at BOE. It will go live on January 1st of 2022. And the reason for that is because we don't want anything to go live during open enrollment. So we want it to go live during a time where we have a few months of working out some of those little kinks that are expected in every big implementation, IT implementation like this. So it will go live on January 1st of 2022.
Thank you.
This is Jennifer Kirk for the record. When does the contract with the current vendor end, and what will the transition look like?
For the record, Laura Rich, the contract ends on December 31st of 2021, and so the new contract would then start the day after that. The transition is, so the new vendor will come in and do what they call a discovery phase. And so they're going to be working with our staff. They're going to be, really getting into our system. There's only so much that they understand through the RFP process, through the negotiations, right? They have to really get into it to understand what exactly needs to be done and what our system does today and what we would like it to do tomorrow. And so that's going to be, likely the first several months of that discovery phase. And then after that, we move towards that implementation. They will be working with the current vendor, obviously, to get the data. And I'm assuming, I'm not an IT person, but I'm assuming that there's a lot more that goes into it other than just transitioning that data. So they will be working very closely with staff, with the current vendor, who is Morneau Chappelle. And I'm assuming there's going to be a lot of effort that will need to be made by current staff here at PEB staff, probably on the Smart 21 system as well. and additionally with the vendor. So it's going to be a big project moving forward that is going to take, I think you've heard me say before, this is going to take a lot of staff time. This is definitely going to be time intensive for our staff, because we have to make sure that they build a system that we can use.
Chairperson Freed, it's Michelle Kelly. I wonder if I can ask a question.
Sure.
Executive Officer Rich, I'm just curious if you could give us a top level summary, I guess, of any enhancements that this contract will bring to the eligibility system. I think you've talked about how your, PEBP as a whole has been unhappy with the current provider. So perhaps you could just kind of address a couple of points about any enhancements that might be built in, and or kind of what provisions they have that were better, I guess, than what we're currently getting.
So my hope, for the record, Laura Rich, my hope in with this new vendor is the biggest thing for me, I think, is reporting. I know in the last 2 weeks I've struggled to, get data that I need, because I can't just pull it myself. I have to. I rely on our vendor to pull that data. I don't have automatic insight into, can I just pull, for example, one of the public comments was, how many of this subgroup of people are those that don't have Part A and Part B? There's currently no way for me to go into the system today and be able to pull that report. So just things like that, just everyday, just things that make our jobs more efficient, I'm hoping will improve. Additionally, on the PEB side, the staff side, there's currently a lot of Band-Aids in place. And so there's a lot of workarounds in our current system that the PEB staff are using. And not only with PEB staff, but as well as the agency reps too. Agency representatives have had some issues with our current system as well. So the data integrity, things like that, I'm hoping will be much improved moving forward. There are a lot of offerings that this vendor can offer us. Unfortunately, we are in a situation where I had to turn a lot of those optional products down, because we're not in a fiscal position where those must be nice to have or would be nice to have are things that we can afford right now. And so hopefully when we do get in a situation where PEB can afford those would be nice to have products, we can move forward and maybe trigger those in our contract as well. So do a contract amendment to include those. But for right now, a lot of those extras are having to wait for obvious reasons.
Okay, thank you.
And one question from me, this is Laura Freed. So the contract would begin January 1st of 2022 and go for 6 years, which means December 31st of 2028. But on the staff report, it says through June 30th, 2027. Am I confused?
Carrie Eaton for the record. 2027, June 30th, 2027 would be 6 years of paying for the service. So even though the contract is technically going to start upon BOE approval, we're not going to start paying until that January 1st, 2022.
Mm-hmm.
It's actually 5.5 years.
Right. That's a little bit shorter than 6 years. Yeah. June 30th, 2027. Okay, just confirming the term date. Okay. With a contract max of $6,849,000. Okay, got it. Okay. So if there are no other questions from the board, I would accept a motion to,
Chairman,
oh, Mr. Lindley, go ahead.
I have a quick question. And I'm a new board member, and one of the things I've heard, and maybe it's just an educational thing, we submitted a budget draft, and the budget draft anticipated a higher cost than the 6.8 million. Is that correct?
For the record, Laura Rich, yes. So every state agency in August has to submit an agency request budget. And so this is where we basically put together a budget and do our best to project costs for the next 2 years.
So this item was budgeted higher than what the current contract offer is?
For the record, Laura Rich, yes. And the reason behind that is we did a request for information in RFI, and the responses that we received, because we've had this vendor for many years. And so we did not know what to expect when we went, if we were to budget for this. At the time, we did not know if this was something that we were going to go out to bid for. And so just in case, we put out an RFI to see what those costs were going to look like so that we would be able to budget accordingly. And so when we put together the budget, we took those responses and adjusted our PMPM, what we included in our PMPM for this cost, to better reflect basically the industry standard of, these responses that we got, the cost proposals that we received from the RFI.
So the budget on section 8, agenda item 8, that is cut to the proposed budget draft?
So it's separate, and this is Laura Ridge for the record. It's different. So the agency request budget that we are referring to in agenda item 8 is really focusing on our subsidies. It's focusing on Reggie and Aegis. And so those are the premiums, the employer premiums that we get from the state. This is more of the operational side of the budget, if that makes sense.
Okay, makes sense. I was curious if the savings of the budget from this contract is factored into the agenda item 8.
So if I may, the way the PEB budget is structured, we have what we have traditionally called administrative load. And so it's all these kinds of vendor contracts, whether it's the enrollment and eligibility system, the health networks in the north and the south, the dental network, the actuarial services, the auditing services, all these things that we buy that everybody in the program, regardless of coverage tier, benefits from. And so the per participant per month cost for each of those contracts is rolled together, to oversimplify it, into the admin load. And so that was the genesis of my first question to the staff. Did we account for this higher PPPM for enrollment and eligibility in agency request? And the answer was yes. So we don't need to adjust the admin load, as we need to adjust the plan design to conform to the governor's finance office mandate for 12% reductions, as we're going to discuss in item 8, but we don't need to adjust admin load. So hope that helps.
That does, thank you.
Okay, with that, if nobody has any more questions, concerns, information, desires, I would accept a motion to authorize the PEB staff to execute a contract for the December BOE for the enrollment and eligibility system contract with a maximum of $6,849,000 for the term of the contract.
Linda Fox, for the record, I will make that motion.
Thank you, Vice Chair Fox. Do I have a second?
Michelle Kelly, for the record, I'll second.
Thank you. PEB staff, would you like us to roll call or would you like us to raise our hands? Oh, Mr. Verducci, question.
No question.
Okay. Well, if there's no discussion on the motion, all those in favor signify by raising your hand so we can see you. Thank you. All those opposed, raise your hand. Okay, motion passes unanimously. Thank you very much, everybody. Agenda item 6, discussion and possible action to approve American Health Holding contract amendment, another contract item, addressing temporary ownership of the toll-free number. Ms. Eaton.
Thank you, Carrie Eaton. For the record, PEB is requesting that the board authorize staff to complete a contract amendment with American Health Holdings to amend the negotiated items and performance guarantees, allowing American Health Holdings to take ownership of the UMCM 1-800 phone number for the duration of their contract. Upon termination of the contract, the phone number would then be released back to the state of Nevada, and a performance guarantee would be added that would require American Health Holdings to pay PEB $100,000 if the phone number is not returned upon termination. This amendment request was brought to the board and denied in September because of concerns that PEB had no recourse if the vendor refused to return the phone number, which is why the performance guarantee is being added. And to put it in more perspective and give more information, currently the State of Nevada Enterprise IT Services Division, or EATS Division, owns this phone number on behalf of PEB and bills the UMCM vendor directly for the monthly charges, whoever our UMCM vendor is. And EATS is being charged 15 cents per minute and passes those charges through to American Health Holdings. With an average of almost 22,000 minutes per month, this phone bill costs American Health Holdings on average of $3,200 per month. American Health Holdings has phone rates in place of 0.0088 cents per minute, which would save them nearly $3,000 per month. And there is a typo in that report. Sorry about that. So while this amendment would not save PEB money directly, we would like to be good partners with American Health Holdings and allow them to save money while keeping the same phone number with no member disruption. And I can take any questions.
Well, Tom Verducci for the record. So it appears this is going to save $3,000 a month or $36,000 a year for American Health Holding. They put together a $100,000 guarantee, and this looks really good. Is there any disadvantage to the state if we were to take action and approve this?
For the record, Laura Rich, Mr. Verducci, I think you and the other board members may recall that this was brought to the board last time around, and there was some concern about there being a risk to the state if the vendor did not return the phone number. And so when we went back to the vendor, they said, that's why they came back and said, you know what, we'll even back this with a $100,000 guarantee. That we will give this phone number back. At this point, I don't see, I see that risk as being eliminated. So I don't see a problem here. I think it saves the vendor some unnecessary fees in phone costs, obviously, and they're significant. And so it's a good idea for us. They've been a good partner, and this is just something that we can do to help them save some money as well.
Well, thank you, Executive Officer Rich. I think that this does look like a very good cost saving for the vendor. They're backing with a $100,000 guarantee, and I think this looks like a very good package. I don't have any objection with it.
Chair Fried, I have a follow-up question.
Please go ahead.
Michelle Kelly for the record. So I just, I'm going to come across pretty hard-nosed here, but I just, why is there no consideration for what PEBP is giving to the vendor? Obviously, this is a contractual matter, and we currently have a contract with the vendor, and I assume that contract includes the arrangements for the 1-800 number. So while I don't object to actually, allowing them to transfer it into their name because of the guarantees, given that item 8, we're talking about decimating health insurance coverage for our employees, I'm just wondering why there's no consideration built in. The vendor's saving, and I understand it's only around $27,000 a year, so we're not going to fix the budget with a consideration, but there's no consideration. So I'm just kind of wondering, I hear that you're saying they're a good partner. We pay them to be a good partner, but I am wondering why there's no shared savings potentially, or especially since we're trying to dig ourselves out of a hole.
Laura Rich for the record. And I'm not too familiar with our EATS phone system. I don't know if maybe Chair Freed is, since she oversees it. But I don't
say I am not, except for the need to upgrade to the digital phone lines to handle all the Dieter UI volume this spring. That I know about, but sorry guys, I can send a quick email.
I don't think that the vendor, and we've had this vendor for about a year, I don't think that the vendor was at all under the assumption that the phone charges through the state were going to be so much higher than what they would receive on their own. Right, so they're essentially, to use this phone number, they have to pay the state, and the state is charging them almost $3,300 a month, whereas they could get the same service for less than $200. And so, when we signed this contract, yes, it was. I think somewhere in that contract, I'd have to pull it, but somewhere in that contract probably says that they agree to use the phone number offered by the PEB program. But I don't think at the time that they had any idea that it was such a difference in pricing. And this is probably something, it's an unnecessary cost to the vendor versus it's not really a cost or a cost savings, if that makes sense.
Well, this is Laura Freed. It's cost savings for them. It's not a cost savings for my EATS budget because thank you, Executive Officer Rich. I have legislatively approved cost pools all over EITS. And yes, they're higher than what you might get on the street because there's overhead built into the rates. And I know that EATS rates are really opaque for a lot of agencies, and that's one of the things I'm trying to work on actually. But so letting American Health Holdings go out, have the EATS, disassociate from EATS and pay for what they can get on the street at much cheaper price actually deprives the EATS telecom budget of some money. So I'm just throwing that out there. I'm not necessarily opposed to this amendment. This would be, just to clarify with PEB staff, this would be a no cost scope adjustment, right? Okay. I'm not necessarily opposed, but it does take away from my agency's revenue stream. Okay, the silence is deafening. How do we feel, board members?
Linda Fox, for the record, I think it makes sense. I think it's cost savings. I think it makes sense. I'm prepared to make that motion if there's nobody else that wants to discuss it.
Okay. You're on
This
fire.
is Betsy. I was
Yeah.
just going to say, I agree. It makes sense. It doesn't look good overall if vendors think the state requires some of the state processes that drive up the overall costs of contracts when they bid. I mean, if you think more globally, I know it might hurt the EATS budget, but if it was in a bigger scope, the 800 number, like with the Medicaid agency where I came from, it could be a significant savings, which would show up in contract bids.
Okay, so Vice Chair Fox has moved approval. Member Aiello, does that work as
That's a second.
That's a second. All right, cool. Thank you. Any discussion? Okay, all those in favor, raise your hand so we can see you in your box. Okay, it looks like motion carries unanimously. Thanks, everybody. All right, now the Executive Officer Report, Agenda Item 7.
Okay, so for the record, Laura Rich. This is Agenda Item 7, the Executive Officer Report. There's just a few things here that I wanted to report on. First of all is the COVID-19 update. PEB has been working with the Governor's Finance Office, or GFO, to ensure that all of the COVID-19 related expenditures of our program are captured and hopefully reimbursed. So from the Coronavirus Relief Fund allocations, as of November 12th, PEB has incurred almost 2.5 million, and I think we actually received that number last week. It was over 2.5 million in COVID-19 related costs. But we are projected to incur approximately 4.7 million by the end of December. So because of that, we actually submitted the 4.7 million number to GFO. And because the CRF funds will expire at the end of the year, that number is included in a work program that is going to be included as part of the December interim finance, or IFC, meeting in December. So let's cross our fingers that we do get some of those funds back to the program. But I do want to just emphasize that that is it. In December, those run out, and anything that the program incurs moving forward, unless there's anything new that happens on a federal level, those are done. And so we will not be getting those reimbursed that we know of in the future to this point. The next item here that I wanted to provide the board an update on is the feasibility study for a public health insurance option. So back during the 2019 legislative session, SCR 10 was passed, directing the legislative committee to study the feasibility, viability, and design of a public healthcare insurance plan offered through the Public Employees Benefits Program to all Nevada residents. So back in August of this year, PEB and also the Silver State Health Insurance Exchange were approached by Manat Health. And that's the organization that was charged with conducting the feasibility study. And since then, both the director of the Silver State Health Insurance Exchange, as well as the Medicaid administrator, and myself have been working with Manat to provide information, data, and feedback on possible options and solutions. So Manat is expected to provide a draft report, and I actually have it and owe them my input by the end of today, I think. And they will be providing their analysis and potential solutions by the end of this month to the Legislative Commission. We will continue to update the board as more information becomes available on this study moving forward. The next one is the solicitations update. there's, as you heard Carrie, there's, you know, a lot of solicitations. This has been taking up time for all PEB staff, not just myself, but a lot of PEB staff. And due to the enormous amount of time that has to be dedicated, not just by PEB staff, but also the evaluators and poor purchasing division, they are inundated as well by us right now. Many of the solicitations that staff was hoping to be able to bring to the board in November is actually not going to be able to be presented until January. So you did hear that the LSI contract, we got that one through, but there are still many of them in the works right now. We're hoping that if we bring these all to the board in January, we can still meet all the necessary contractual deadlines that need to happen so that the implementations can be achieved by open enrollment this year. So as you heard, LSI, we're pleased to announce that we've had successful negotiations with them, and they have partnered with Benefit Focus to offer an integrated enrollment and eligibility system. That one will go live in 2022 for PEB, but through the Smart 21 system that they are also spearheading, that should go live in 2021. And so we're really excited to partner with them, and hopefully this is going to be a big improvement for PEB moving forward. In addition, the purchasing division has issued letters of intent for the medical network, dental network, and HMO contracts. So we are in the process of negotiating each of these so that they can be presented in January, and then subsequently included in the Board of Examiners meeting for final approval in February. The health plan auditor RFP has been finalized and it has been submitted to purchasing, and hopefully that will be released soon. I know I got an email earlier today asking for the AOK for that one to be released. So hopefully that will be released within the next week or so. Overall, you know, I just want to thank staff. This has been a lot of work for PEB staff, not just writing the RFPs, being part of the evaluation committee, being part of the negotiations. We have had to live and breathe these solicitations. My kids actually asked me the other day what the heck an RFP is, because that's all they hear me talk about when I work from home. So this is, you know, this has obviously been something that has taken up a lot of PEB staff time. And I want to thank the entire staff that's been a part of this, because it has been a lot of work. For an operational update, the first thing that we want to talk about is the flu shots. So as we have in previous years, PEB hosted 2 flu shot clinics during the month of October, one in Carson City and one in Las Vegas. Governor Sisolak attended the event in the Carson City location to show his support and stress the importance of flu shots during the pandemic. Although PEB expected a significant decrease in participation, in fact, we weren't really going to do them because everyone's working from home. We went ahead and moved forward with them, and we actually had a very strong showing. So in Carson City, we had almost 300 people show up to get their flu shot, employees. And in Las Vegas, we actually had more than we had last year. So 140, which is about 50% more than what we saw in 2019. So that was big. I want to give a shout out to Nicole Pluta, our education and information officer, who really just, you know, she worked really quickly to get these up and running and work with our vendor partners to make sure that we could put these all in place in, you know, like 2 weeks time. So we were really grateful for her help on this and all the effort that she put into this, into the flu shots. Staffing. Staffing continues to be a challenge. Although PEB received approval to staff several open positions, We had some internal promotions, which then created new vacancies. So then we had to ask for those positions to be to be filled. But so we found it very challenging. A lot of these positions, especially these entry-level positions that we have in, for example, our call center, we've found it very challenging to staff the positions. We did staff an executive level CIO position, which he should be watching here today. It's his first day. So his name is Stephen, and he will be joining the PEB staff. So I'm excited about that. We haven't had a CIO in a couple months. We have chosen not to submit JTS justifications to fill for some positions that we have within the agency that we've determined to not be vital at this time. For example, a front desk position. When our offices are not open, that is a position that is not necessarily necessary. So to date, we have 30 of 34 positions filled internally here at PEB. Conclusion. With all of the upcoming changes to the core plan design and possible reductions to other benefits, PEB expects a very, very busy year. And we will be depending on each and every one of our staff to ensure that PEB's 73,000 staff members receive excellent service, care, and attention moving into this next plan year. So with that, I'll stop here and take any questions from the board members.
This is Betsy. I do have a question. As we heard in public comment, where one of the gentlemen was encouraging us to reach out to the federal level to try to get some more COVID funds. And as you mentioned in your report, we are getting some, but there's no guarantee for anything past the end of December. If the state was to get more COVID funds, that would make a difference in the budget, because that would bring in some money to help backfill that 12%. Or I'm not sure how much medical costs are focused into this, because the budget doesn't really start till next July 1. So I'm curious about that.
So Laura Rich for the record. You know, I think this all depends. It depends on what this, you know, if there is a stimulus bill, what the requirements are of this. So for example, the CARES Act funds right now have very specific requirements. The only money that we are getting back from the CARES Act are specific to COVID-19 related costs. And so those are that's the testing, that is the any kind of care that is received as a result of a COVID-19 diagnosis. So it's very limited. Moving forward, I don't know. I don't know what that stimulus bill is going to look like. Are those requirements going to be specific to only COVID-19 related costs? Yes, that would help, because I expect, as you've seen, that there's a surge, there's a lot of testing, there's a lot of costs associated with COVID-19. Does that play into the global picture of, you know, what our fiscal landscape looks like moving forward? And is that going to save the state out of this, or help the state out of the financial crisis we find ourselves in? You know, I don't know. There is no stimulus bill out there right now, so we don't even know what that's going to look like.
Okay, this is Laura.
This is Jennifer.
Oh, Jennifer, please go ahead.
Regarding the CARES Act funds, is that going to be any claims that you're going to be seeking reimbursement for that are received with a date of service as of like December 31st and prior? Okay. And then how long is the regular claims processing time? When do you expect to have a final number on the volume and the amount of those claims?
For the record, Laura Rich, the claims actually by statute, providers have a year to file those claims. So technically, if, we could receive claims for a service date of, December 20th, 2020, on December 20th of 2021. So yes, that is, and typically that's not what happens. Obviously, providers want to get paid. And so that's not typically the case. But yes, there is a claims lag time, and that's where we're trying to get in as much as we can by the end of the year.
This is Laura Freed. Just out of curiosity, we expect to incur $4.7 million in claims costs by the end of this calendar year. And then we're getting CARES Act reimbursement for those claims costs. How does that compare with the box of 4 boxes that Aon presented to us in the past couple of meetings of expected claims expenses offset by claims suppression? Do you remember? This is just for my curiosity, really, to see how close we came.
So I think we're right in line, but Stephanie from Aon, do you want to just kind of speak on that really quickly? Because I know you've mentioned you've had a couple comments on this.
Yeah, I would say of those boxes, it's kind of coming into just really our average estimate. It's not really on the high or the low side. It's kind of right in the middle. And as you might imagine, if I reran it today, the 4.7 million is probably a different number, especially given we're all in the middle of a pretty big upswing.
Right. That's true. And actually keying off of Stephanie's last comment, PEB staff, have you seen, since we've been spiking in this so-called third wave, have you seen any spikes in claims costs in the last couple of weeks for COVID?
So I get those, I get them weekly. I get a claims, an email basically of what are our claims look like weekly. At the beginning of all this, I would see that the claims were increasing, 20, 25,000 a week. That's up to now easily at 100,000 plus a week. And so yes, we are definitely seeing a spike. However, remember that there's a lag in claims, right? So what is happening today, this surge that's happening today, we probably won't see for a couple months.
Again, this is Laura. Oh, I heard somebody with a question.
I'm sorry, this is Betsy again.
Sure, go ahead.
Based on what I heard Stephanie just say, are we like locked out, or would we be able to run another projection and request more than the 4.7 million?
So that's a good question. Probably something we would have to ask the governor's finance office. They had asked us earlier, I think it was last month, to come up with projections. What do we think that what kind of expenditures are we going to incur by the end of the year? And we had to come up with approximates. We had to run those projections. And so that is what is being submitted in a work program for the December IFC. I don't know if we are able to go back in and make any changes to that. I think that there may be some deadlines that we would have to we'd have to work with GFO on that to see. And I apologize, I have not been intimately involved in this. We've actually had one of our accounting staff has been working with GFO on this directly.
And my gut feel would be it might be worth asking the question, because the governor's office is super aware that there's a surge that people were hoping or not expecting to this extent to occur, but they may have already allocated all the money, so they didn't leave any on the table, but they may also be willing at the last minute. I don't know, but I always think it's probably worth asking if it really will help us out some.
This is Laura Freed again. One more question, if I may, on the Minot study. Based on the draft report, and if you haven't had a chance to read it, I understand preparing for this board meeting was a Herculean task for you all. Are they recommending commingling with non-state, just members of the public with PEB participants? And, or are they, I mean, and if so, I find that curious, given that that would require more subsidy dollars. And the biggest agenda item on this agenda is reducing subsidy dollars. If we struggle to provide a quality plan design to our own members, is it really the right time to recommend to the legislature that we open up PEB in a way that would make state employees and state retirees have to subsidize people who've never worked for the state?
Yes, and for the record, Laura Rich, while I haven't had a chance to read the entire 40-page document, I have had a chance to discuss with Minot directly. They are very aware of the costs that is associated with any of these recommendations or potential recommendations. I don't know if they're exactly making a recommendation. This is something that they're going to have to take back to the Legislative Commission and discuss with possibly Senator Canzaro specifically to see if this is something that is going to really gain any traction moving forward. I think it's still too early in the process to say what it is that they plan on doing or don't plan on doing. I think we're still in that, discovery phase of what, given the expense or potential expense or costs that come with these public options, is this the time to do it? Or is this study going to be used as a potential educational study to maybe take to on a different level and a different path moving forward in maybe another biennium when hopefully the state has recovered economically. I don't know. I think it's still too early to see what they're planning on doing. I think the final recommendation when that comes out will be very interesting to read.
Okay, thank you. Board members, any other questions for the executive officer? Okay. Well, it is 11:33 and the next is a big agenda item. So would you all like to take a bathroom break for a couple of minutes? Okay, I'm seeing nods. All right. So let's come back at 11:40 and we'll undertake agenda item 8. Thank you. Hello again, everyone. It's 11:40. I'll call the meeting back to order. And we will. It's just funny to see how some people's cameras end up. We will undertake agenda item 8. And just for organizational purposes, because this is such a long item with so many facets and so many choices for the board, I think what I will ask the executive officer to do is to, go through the background in the staff report, obviously, and then go through options 8.1. And then if you would go through options 8.1.1 and 8.1.2 received this morning by the board. And I hope, I haven't checked the website, but I assume they've been posted by now, so everybody at home can play along. Great. And then go through 8.2 through 8.12 or 8.2 through the rest of them, I guess I should say. Does that sound feasible? And and board members, if you get lost, if you want me to slow down, if you want to go back over something, please just raise your hand, because this is, like I said, this is a lot to absorb. So with that, I will turn it over to the executive officer.
Okay, for the record, Laura Rich. Deep breath. Yes, this is going to be a very long report. This is not something that any of us wish to present or wanted to present today, but we are in an unfortunate situation. So I'll begin with a little bit of background. So earlier this year, agencies were asked to submit budget reserves of 6% for FY20 and 21. Originally, PEB was exempt from FY20, but we managed to come up with almost $25 million for FY21. We did that mostly by reducing the reserve levels. But then agencies were also asked to submit flat budgets for the 2022 and 2023 biennium. And because of trend, the same dollars don't go as far. So for PEB, a flat budget is actually about a 5% cut. So because of this, we introduced back in July, the July board meeting, the concept of a new plan design and made adjustments to all of the existing plans that we have, or both of the existing plans that we have today. So back in August, PEB submitted a budget that used the proposed plan design and stuck with those flat budget caps. On November 3rd, the governor's finance office released a memo to agencies telling us really what we all expected to hear, that the state was expected to experience a significant revenue loss. And in order to prepare, agencies were being asked to submit 12% budget reserve proposals. For PEB, that 12% is about $72 million for the biennium, or $36 million each year of the biennium. So where does that leave us? Typically, the PEB board meets in November to discuss and approve plan design for the upcoming year. So finalizing the plan design allows staff to prepare for that upcoming open enrollment, and it also allows the actuaries to start building rates to be able to present and approve those rates in March. That's still the goal of the agenda item today. We're still going to discuss and hopefully approve plan year 22 plan design, but we are not here to finalize plan year 23 plan designs. I just wanted to emphasize that we are only finalizing plan year 22 plan design. The other piece of this, however, unlike what we've done in the past, the board must approve what is going to be submitted in the PEB budget, sort of like what we did in July when the PEB board authorized the PEB staff to submit a budget with the new plan concepts. This time, what the board is going to have to do as part of this agenda item is approve the proposed budget reserves for fiscal year 22 and 23. Most agencies had to submit those proposals by last Friday, but because PEB requires board approval, we actually have until tomorrow to submit ours. So what is approved today will be submitted tomorrow to the governor's finance office. While we are asked to submit proposals for 12%, that number could very well change in December when the Economic Forum meets and presents their forecasting. We could easily find ourselves in a situation or in a predicament where we only need 10%, hopefully, or we might need 14%. So the approach here is, in order to have the flexibility and not have to call an emergency board meeting the week of Christmas, is to rank these options that are being presented today from most palatable. And I say that with some hesitation because I don't know if any of these are palatable, to the least. That gives PEB that flexibility to work with GFO and make any last minute budgetary changes. So that's a little bit of the background, but what I do want to say, and I will emphasize in every report, every presentation, and every public presentation that we have moving forward, there is a disclaimer here on the second page. It is important to emphasize that although standard actuarial methodology has been used to develop plan year 22 budget savings options, there are so many variables in the PEB program and in the PEB budget right now that not even the actuaries have this crystal ball, and that this is just a very, very odd year for PEB. Not only do we have the renewal of several major contracts, a lot of them which you guys will be hearing about in January, but we also have the whole COVID-19 variable as well. We do not know how that's going to play out. We do not know, what the surge is going to look like, how it will affect our plan and our program and claims costs. That also leads into trend, right? Trend is going to be, it's going to be hard to predict. This is not a normal year. And so predicting trend is going to be difficult. Then we also have the introduction of a new plan. And anytime that you introduce a new plan, I think some of you were on the board when we introduced the EPO, anytime that you have that new plan, there's unknown utilization. So you really have to account for that as well. And then the legislative session. So we're going into session. We do not know what that's going to look like. What kind of BDRs are going to be heard? What kind of, budget decisions are going to be made? And so that is all, those are all variables that play into the PEB budget. And as one of the largest budgets in the state, this is big. And so I'm going to continue to make this disclaimer over and over and over again so that everyone understands that we do not have a crystal ball, and that there's so many variables out there right now that next year we may be very close or very well off to our predictions. It's hard to say. So with that, I will get into the meat of the report starting at 8.1. But first, I do want to just start out with a few comments. First of all, we all know this is a very, very unfortunate situation. No one wants to cut benefits. This is not what, when I was appointed, I joke with my staff that one of the concerns I had when I was weighing whether I wanted to interview for this position was that I was concerned that we were going to have to raise premium prices. If now looking back, I think, gosh, if that was the least of my worries. We are in a much different situation today, and raising premiums is not the only thing we're looking at today. We've seen the last several years, we've had a lot of gains in PEB and in the program. And so this is just a very, very unfortunate situation. But PEB was handed a directive, and we literally had less than 2 weeks to come up with these options. So I do want to thank all of our partners who were just immediately willing to huddle and come to the table with ideas. Mary Catherine Pearson from HealthScope, Amy Daly from Express Scripts, and an absolute huge thanks to Stephanie Messier from Aon, who has spent many, many sleepless nights plugging away at with these numbers and responding to my many off-the-cuff what-if scenarios that I keep sending her. I know she's dedicated countless hours, many of them at 2:30 in the morning, to helping us to come up with the actuarial analysis that has been necessary for these options. So I want to make sure that that our partners are recognized in all of the work that they've put in, as well as the PEB staff as well. The other thing I want to emphasize is that none of these options are being presented lightly. While the expectation is that board members will and should have questions and shouldn't just rubber stamp what staff is presenting, these options are not being presented without a great deal of thought and careful analysis. I personally would have loved to have been able to send out a survey to get feedback from our members before presenting any of these options, but we didn't have the luxury of time. So, we had not even 2 weeks. We had, I think, 13 days to come up with these options and do all of the analysis. So this has been a lot of work in the making, and there's been a lot of time and effort that has been put into this by all parties. So as Chair Freed mentioned, the report is divided into 2 sections, and the first is the plan design, where we can potentially get the majority of the savings, and the second are the additional items or options using levers that are outside of those plan designs. So the first one is the 8.1. These are the proposed plan designs. Originally, there was one proposed plan design that was being presented in the report. We came back and late last night, and in my case at 4:30 this morning, put together a couple other plan designs as well, along with Stephanie from Aon's help in this. So we kind of scrambled at the last minute based on the public comment that we were getting that was coming in. So the first one, and I'm just going to go over the one that was originally in the report first, is what we're looking at, the plan design. This assumes a 2.5% reduction in headcount due to hiring freezes. So that's something that I want to point out that is very important. This assumes that there's going to be some hiring freezes and some position eliminations throughout the state, and as a result of everyone else's 12% budget reserve proposals as well. As you can see, those 3 plan designs here we modified the CDHP so that it has higher deductibles. The HSA employer contribution is obviously much lower than what it is today. You can see that the actuarial value here is a 78.4% actuarial value versus the 87.3% actuarial value that is in place today. So that plan, the new plan, is it would fall under the metal tier of a high silver plan. The next one is the low deductible with a copay, which is a low gold plan. You see it as an 81.8% actuarial value. It does have some deductibles here, $1,000 and $2,000. However, really the deductible does not apply for most of these services. Most of the services are on a copay level. So you're only hitting the deductible if, for example, you are an inpatient hospital service, or specialty medication, or some of these other services such as imaging and things like that. And then we have our EPO and HMO, which again, that has been modified in such a way to where now there is a small deductible as well. And, but again, it is mostly based on copays versus the co-insurance. And this is a high gold level plan. You can see that the rates here at the bottom are basically the rates that are, we tried to keep the rates flat in this scenario. So they're fairly flat with the exception of the EPO and HMO, which were lowered. And the reason why that is because if you remember in July, the board made the decision that the policy decision that all plans were going to be subsidized equally. So before that, we had, and in fact, in this plan year, the CDHP is actually being subsidized at a much higher level than the EPO today. And so when you equalize those, obviously that EPO and HMO rate drops a bit while the CDHP increases. And so that is the reason for the seemingly lower rates on that EPO and HMO scale right there. So that is the first one. I don't know, Chair, if you want me to stop there and maybe give everyone an opportunity to ask questions before I go into the other two.
Yes, please. Let's do that. Okay, I'm not hearing any questions. So everybody understands that were the board to make the proposed plan year 2022 changes, that would get us 20.1 million of the $36 million for FY22. So 16 million to go to meet the target demanded by the GFO.
Correct.
Okay.
Yes.
All right, then why don't we move on to what you called option B, option C, which I've fondly referred to as 8.1.1 and 8.1.2, and talk about the differences between this and those two.
Okay. So the next option that was introduced this morning was, so this option uses the initial plan design presented at the July 2020 board meeting. So that plan design is a little richer than the one that I just went over now. Those actuarial values you see are a little bit higher, and so the benefit levels are a little bit better in this scenario. But in order to, if you're going to increase the benefits, you've got to make it up somewhere. And so you'll see that the participant premium here is much higher. So we've adjusted those levels so that you can see that in the grid that was included here, it includes the 5 and 10%. So we're only looking at that 5%. And I apologize, I should have actually eliminated the 10%, but I was doing this at 4:30 in the morning, so you have to excuse that. So this is assuming that those 5% levels there. So the 2,000, 4,000 on the modified CDHP, you see that those out-of-pocket maxes are a little bit lower, and you see that there's a $500 HSA contribution versus the $300. So it's a little bit richer plan design on this one. Again, the low deductible with copays, also, a 1,000, 2,000 deductible, and then you'll see the copays are slightly different. And again, on the EPO and HMO, it's slightly different as well on that too. So you'll see that the actuarial values here are slightly richer in these plans than in the one I just presented. However, you can look again at the rates, and you'll see that those rates go up to, from about $43, what it is today, what employees are paying today on the employee only, to $74.65. And those are illustrative rates. just so everyone knows, you know, obviously the rates will change. This is what it would look like if we were to price them today, but we do not price our plans until March, until we have much more experience. So those are just as an example only, and only show what it would look like as if we were pricing them today. This plan design, again, it meets the $20 million in savings. And so we would have to make up that other 16 million in the other options. The next plan design was one that was suggested by the Nevada Faculty Alliance. So they had requested that CDHP deductibles be reduced back to $1,503,750 in HSA funding, and reduce those out-of-pocket maxes back to today's levels of $3,900 and $7,800. They have also asked for the copay plan to be reduced. There were those deductibles to be reduced from $750 or reduced to $750 and $5,000 and $10,000 for those out of pockets, and the EPO go back to that no deductible and reduce the out of pocket maxes to $5,000 and $10,000. This plan design does not evenly distribute the actuarial values. So you see in the other plan options, you've got the actuarial values of the plans are kind of spread out a little bit. It gives people choices. In these scenarios, those actuarial values are very, very similar. They're right in that, 81 percentile, and I don't have the numbers right in front of me, but Stephanie can correct me. Those actuarial values are very, very similar. So you're essentially giving people the same plan design, just, different ways to get there. In these scenarios, again, adjusting the premium so that we can at least get to that $20 million mark to make up for that 16 million that's left over after this. You're looking at premiums that are, fairly high, $108 for the employee only premium. You're going from $43 to $108. So, those rates are definitely going to increase when you make that plan design richer. So with that, I will stop, and we'll stop for questions here.
This is Laura Freed. Just to be clear on option B, you basically want us to disregard the approximately 10% column in CDHP and HMO, right? Okay, so so we are, and those are plan year 2022 illustrative state rates for actives. So it would go from the original staff report, EE only of 4460 to 7465. And on the HMO, 149.47 to 162. And then this appears to be kind of a mix of proposed plan year 22 from the original staff report, and then increasing the HSA contributions for CDHP. Okay. And then
one thing I do want to point out here that I had a note to myself here. So these are plan year 22. The thing that we need to keep in mind is plan year 23, because of trend and because of the way that the subsidies work, we will likely see a $30 to $40 increase in plan year 23 premium. So we need to keep that in mind too, that while this is for plan year 22, these subsidy levels do not change in the second year of the biennium. And so any trend that is experienced within the plan, those costs get shifted entirely onto the member. So we have to keep that in mind, that the plan year 22 increases in premiums are going to be likely higher in 23.
Laura, Laura and Laura, ask a question. This grid, I heard you say that this was based on projections today, and the premiums could be different when run in March. And so that goes back to if the federal government gives some subsidies for COVID, the premiums might be okay, or we may not be able to count on them. So in a negative frame, likely the premiums are going to be higher than what you have here because of the surge in the expectation, even in the 2022 year?
So not necessarily. So again, we're not going to price out the plan until March. What we do in November is we have to establish what is it that plan design looks like. Because then at that point, the actuaries take into account our plan design, policy decisions, et cetera, and they use their actuarial methodology in March to say, okay, this is what you've had in claims, and they look at claims through March, and they're able to say, okay, using our projections, this is what we think your plan is going to cost, and so this is what the participant premium will be, and so that's all going to happen in March. What we're using is claims data. And so right now it's too early in the plan year to be able to comfortably say, this is what your claims experience is going to look like. We need more data. We need more time. And this is why we don't do that until March. Yes, experience and COVID costs will definitely play a part in this, but yeah, we don't know what that's going to look like. And I don't know, Stephanie, if you want to add anything to that.
Yeah, one other thing I wanted to say is outside of COVID, what we've seen so far in plan year 21 through the first quarter is an increase in pharmacy costs, just from some specialty medications that I believe about 6 of your members are now taking. That are very, very high cost drugs to the tune of, you're seeing a trend upwards of 20%. Let's just say in the first quarter. If that 20% maintains throughout the year, we don't typically price for a 20% trend on pharmacy. So if we continue to see that increase in pharmacy costs through the first half of this year and, into the third quarter of plan year 21, that's definitely going to put additional pressure on the rates that we've calculated for you here today. We did take a little bit more of an aggressive stance on trend, trying to be sensitive to the fact that the last time, Nevada was in a fiscal crisis, your participants definitely saw some decreased utilization of the plan, and we were trying to be mindful of that and not put you at an even bigger disadvantage of, getting excess reserves built up because we were overly conservative in rate setting. So I will say that these rates are erring on the side of being somewhat aggressive in trying to project your rates. So I just want everybody to keep that in mind as well.
And I do have another question. So the actual budget cut is in the base subsidy, correct? And that's why the premiums are going up?
Right. So for the record, Laura Rich, it is in the state subsidy. And that is where the bulk of our revenue comes in.
And so then that's where, and I'm just listening to what some of the folks have said, and let's just take that first in number B, or in B, the premium that says 74.65, technically, we could say something like the premium is $54.65 plus a $20 COVID, whatever they were asking for, copay or something, which would stay in place unless the legislature gave us back some more money. Just throwing that out from what I'm seeing here, maybe is the thought.
So this is Laura Fried. So I'm going to ask the board a policy question. The executive officer said something very apt in her presentation. She said, you can either bring subsidy dollars, paraphrasing obviously, Laura, you can bring subsidy dollars out via the plan design or via the rates. Which does the board prefer? What do you think of the bad choice before you? Which do you think is the least bad choice?
It's Michelle Kelly here, for the record. You know, I think obviously none of the choices are good, but I do think that option 1A disproportionately impacts the folks who need it most. And so I would say that what I see when I look at option A, as well as some of the other cuts we're going to get into, is that we're really impacting Nevada's social safety net for our participants, right? I mean, when you increase a maximum out of pocket to $6,000 for an individual or $12,000 for the family, people can't afford that. And yes, I think in the report, Executive Officer Rich does comment that only a few people use the out-of-pocket max, deliberately so, right? But there are also people clearly who have extraordinary medical events going on. And so to increase it so drastically, I think it's around 53% in 1A, is crushing for the small number of people who use it. And for me, I think that for our plan, the idea is to look after people in those catastrophes, in those catastrophic situations as best we can. So my preference, my preference, first of all, is that the board petition the governor and the legislature to either exempt us from these budget cuts or be more realistic, about the budget cuts once they see the depth of the cuts that we're going to be discussing today. Firstly, I think that we have to do all we can, but I do think that we have to spread the pain, if you will, across plan design, across the rates, plan design for both retirees and active employees, but I do think we need to maintain the safety net aspect of our plans. We can't, because if we don't pay some of these things and people can't afford it themselves, they end up on social services one way or another, right? They end up using other state monies to fund some of these claims if they can't afford them themselves. So, and with that, I'll let someone else have a say.
Linda Fox for the record. So if I understood the question, your question, Chair Fried, was if we had to pick one, if we prefer higher rates or decreased benefits. Is that correct?
Yes, that is correct.
Okay. So I would prefer a higher rate, and I liked the proposal that was made in public comment about a COVID surcharge, I think they called it, simply because it could be more simply removed if the time came to do that. And if we discuss doing that, I wonder if we could also discuss doing that on a sliding scale based on income. And I know that's complicated because I proposed that before for insurance. But I wonder if we could just discuss that based on a pay rate. Maybe it's like an hour of pay per month, something like that, if we are going to discuss a surcharge. Thank you.
Okay. Anyone else want to weigh in on the essential question of, do you find subsidy savings in the plan design or in the rates by shifting the cost of the rates more to the participants?
Well, this is Betsy, and I tend to agree with what the two folks have said, that it's probably better to have the little bit higher premium, because when people are in high medical need, it's very hard for them. But I also realize I'm saying this from someone that could flow that in my income, and I worry about some of the single mothers. So I guess that's where Linda Fox is at, that are in some of the lower pay grades. But I'm not sure, again, how you could possibly do a sliding scale, but.
Yeah, that's really complicated. Yeah, and I mean, although I appreciate the thought, because I think Vice Chair Fox has hit on one of the problems with a COVID surcharge that functions as a flat tax on employees and early retirees. Because right now, I mean, this 8.1 ABC here just deals with actives and early retirees, non-Medicare retirees. We haven't even gotten to Medicare retirees yet. So, you know, what at least the premiums you pay based on the coverage tier selected have some basis in actuarial experience of the people in that coverage tier, whereas a flat surcharge is regressive. So that's my feeling on that. But what I'm hearing so far is that option B or option C, if the objective is to wring out $20 million in subsidies, option B or option C is more palatable.
So this may be way out there too, but I just figure we should talk everything out. What if we looked at whether the person wanted to choose it, like someone would choose the CDHP that was in the original plan that has a smaller premium, but it had, so it's like adding more plan options, but they decide they don't want to have the upfront and they'll take that less rich CDHP, or someone says, I'd rather pay the more upfront. I don't know whether that would work or not either. Just throwing, it's going from 3 plans now to maybe more plans than that. And I'm probably getting way too complex, because that requires computer programming and eligibility and tracking. And so.
So it's Michelle Kelly here. Sorry.
Oh, go ahead. I was just going to ask you, related to Betsy's question, if we'd be able to measure like the potential savings to the budget. Had we done that? And I guess to throw in my my preference, I would certainly say, you know, again, none of these options are good. You know, we know that we've all done, like, the board is, PEB has done the best that they can, and PEB staff has done the best that they can with a very unfortunate situation that we have to look at. But I would say that I would be in favor of slightly higher participant premiums versus less rich benefit design or cuts to benefits, simply because I think the impact to the individual employee paycheck each month would be a little bit less. One thing to consider is that, you know, premiums are paid pre-tax. So when an employee gets their paycheck, a difference of, you know, $44 versus $74 is not going to impact them nearly as much as an additional $1,000 in out-of-pocket copay or out-of-pocket deductibles that they're going to have to meet, which are also going to be, unless they have the health savings plans, it's going to be an after-tax cost for them.
So it's Michelle Kelly here, and I know you've, Chairperson Freed, you asked for a more general take from people. I actually have a couple of specific questions about, not about any of the proposals, but about each of the proposals. That is, I wonder, and I'm sorry because this is only my second meeting, but I'm interested in what Aon and PEB staff use the actuarial value to do in their design. I understand what the actuarial value is, but I'm kind of curious about how they use that to determine design. So that's one question. And then the second question is something that Executive Officer Rich commented on in her report. And that was that back in the July meeting, the board made a policy decision to change the way the subsidy for the EPO and HMO as in, I guess that was increasing it so that each of the subsidies were equal. And what we're seeing here is that that did result in significant decreases to that EPO HMO plan. So I'm just wondering if what that would look like but for that policy decision. Because where I'm going is that the actuarial value, I know you've referred to them as silver or low silver, gold, low gold. And so I understand you're trying to line them up with the private or the health exchange. But I guess from my perspective, if we don't have a base plan anymore, then shouldn't they all have the same actuarial value and the difference be in premium? So that's really a general question. It's not about any of the specific options. I'm just trying to educate myself, I guess.
So I can probably explain the actuarial value piece of it, but I think the actuary might be better at explaining it. Stephanie, do you kind of want to explain actuarial value and how it works?
Yeah, so in terms of why you would have 3 different plans and not put their actuarial value the same, the point of offering 3 different plans is to really give folks choice. If you offered 3 different plans with the same actuarial value, it would be very hard to do because actuarial value is very heavily weighted to the deductible, the out-of-pocket max, and the co-insurance threshold. So in order to offer 3 different plans with the same actuarial value, you would have to have those values be very similar to each other. The reason that people offer plans with different actuarial values is that it's then letting the employee decide, do I want to pay more or less in my paycheck to pay conversely the opposite when I need services? So for the folks that are paying less out of their paychecks, they know that if something happens or if they need to go, let's say, to the emergency room or to the inpatient hospital, they're going to be paying more than someone who is paying more at time of their paycheck. So like the folks in the HMO plan, they pay higher knowing that every time they go to the doctor, it's a copay. I don't have to wonder, is it going to be a $200 bill? Is it going to be a $300 bill? I know it's going to be my copay, which is, $25 to $30. Similarly, on the inpatient hospital, it's a set amount, it's a very stable number. It's a very predictable number. So they pay more for that. They pay a premium today to get that stability. So what we were trying to do by offering the 3 new plans is to offer, again, a more diverse choice. We had put the AVs at equal distance apart. So we're offering that new plan halfway between the CDHP and the EPO / HMO today to really give people choice and say, okay, I want to pay a little bit more than I was paying on the CDHP plan, but that middle plan now gives me the ability to go to my doctor for $30. And I know when my kid gets sick, I don't have to worry about my CDHP, have to hit my deductible first, right before my insurance technically kicks in. Instead, I could just go get my kid to the doctor for $30. And so that was kind of the point of introducing that middle plan. And I hope I answered your question on the actuarial value piece of it. But let me know and I can elaborate more.
No, I think you did. So just extrapolating on that. So if you were able to come up with a rating for the premiums, what you're saying is each of these the actuarial value is 100%. It's just where you're paying it, front or back.
Yeah, exactly. So our point was with also making that change in July, that over time, when PEB had originally introduced the CDHP with the HMO alongside of it, it was very clear that their intent was the difference that you're paying in your paycheck, you get back over the course of a year by how much less you pay utilizing services. However, because that wasn't monitored over time and the prices of the HMO was strictly tied to the renewals that PEB was receiving from the vendors as a fully insured product, the gap grew to the point where a single employee was paying about 400% of what they should have been paying in terms of what they were saving during the year for services. So we really wanted to correct that situation that had gotten to a very disproportionate gap over a 10-year period, but kind of resetting PEB to a more actuarial standard structure and getting it to a point where, again, now the differences that folks are paying is in a more equitable place to what they are conversely saving or spending during the course of a year as they seek services.
Thank you.
Okay.
Hello, Chair.
Yeah.
Yeah, I wanted to chime in on your question. I'm an active employee, I guess representing active employees. Well, I am representing active employees. And one thing I considered is, to answer your question, is I'm a fan of lower initial premiums because we are already I'm expecting furloughs, which will directly impact my take-home pay. And looking at the rates shown, I'm the breadwinner of the family, and my whole family is on the CDHP plan. And option A has a projected rate of 272. Option B is 343, and option C, I would say, for the employee plus family is a lot higher than option A. And as far as the choices we make today are temporary or could be changed in a year from now. My wife works from home. I work from home. As far as getting sick and utilizing services, I can tell you that it's gone down significantly. I do know some people in the medical field where they are seeing less patients because they're not in school. There's less sickness being spread. We are actively maintaining social distancing, wearing our masks in public. And now with the governor's new 3-week pause, there's more action being taken to reduce transmission, not only of coronavirus, but of sickness in general, which would reduce our participation in utilizing services from primary care providers to specialists. The last thing I want to see is my take-home pay go down even further. And that's why I do like option A for the CDHP. So at this point, that's kind of my opinion and my position. One question I do have is are we able to combine aspects of option A with aspects of option B and potentially aspects of option C?
So for the record, Laura Rich, I think you have to be more specific because obviously everything's a lever here. You move this up, this goes down, and vice versa, right? So there's levers. So I guess we would need to know what specifically you're looking at.
Option A, I like the CDHP proposal. Option B, I like the HMO proposal.
So I think it goes back to what Stephanie mentioned is you have to look at this globally, right? You're presenting options that need to be, if they're too close, then it's basically the same option. In actuarial value, it's basically the same option. So you want to give people different options. And let me look at option B. What exactly are you looking at in the HMO that in option B that you would prefer to see differently?
Option B, the HMO actuarial value is projected to be 87.2 for the HMO. Option A, the CDHP actuarial value is 78.4 projected. The deductible increases by $500. It's an even split between CDHP and HMO participants. The out-of-pocket maximum favors HMO at $5,000 versus CDHP at $6,000. The co-insurance favors the HMO at 15% versus 20%. And of course, it goes down. The biggest benefit is both a reduction in premium for the HMO, because currently the HMO employee is at 171, it still goes down to 162. And the family is at 689 going down to 551. I'm rounding here, of course. But the CDHP, it goes up just slightly with a family reduction from 301 to 272, but the increase between the employee only, employee spouse, and employee plus children is all within $10 a month, which is about $60 a year. And that impacts my paycheck less than raising rates by a sizable factor.
Stephanie, do you want to chime in here?
Yeah, I do just want to point out that if you enrich one of the plans, because we also made the decision in July to co-underwrite together the EPO with the CDHP, as Laura mentioned, it's going to tilt things. So the CDHP will inherently go up. So you can't pull the premium dollars from one option and one plan design and directly put it on top of another. Because again, the way the pooling works together, it is going to shift things a little bit differently. It's not a one-to-one change. The other reason we were trying to keep the out-of-pocket maximum constant among the different plans for each of the different options is because, again, we're trying to really look out for the employee by saying we're going to offer you at a minimum, regardless of which plan you pick, the same maximum coverage, right? At most, we want you to pay either $5,000 in one of the options or $6,000 in another option. We don't want you to have inherently missed picking the plan and something bad happens that year. And I believe prior board member Mitchell, given her situation, had mentioned that she just looks for the lowest out-of-pocket maximum because she knows that she's going to hit it, right? And so the purpose of trying to give the same out-of-pocket maximum, regardless of which plan, is to really to protect that employees that don't understand healthcare as well. And is more equitable in terms of protecting employees the same level, regardless of which plan they pick. So I just wanted to mention there was some logic behind the decisions on the out-of-pocket maximums from one option to another.
Well, that's, I just wanted to express that was my answer to Chairwoman, pardon me.
I appreciate that. I think I hear something of a consensus, although I want to say I understand and share your reluctance, everybody, around option B, to kind of, because it takes sort of the middle way of increasing premiums for 22 and bumping up the deductibles and out-of-pocket max, but not in a way that is quite so drastic as option A. Is that a fair statement to make? I'm doing this kind of in discrete chunks because I'm trying to keep the discussion focused on one thing and one chunk of subsidy at a time. So number one, is that a fair statement? Number two, the other thing I would note is that if the governor's finance office, in consultation with the governor's office, says, no, we don't want to do that to PEB, I think this is the 8.1 is the way to give something back. And I think what they would give back there is deductibles and out-of-pocket max if they wanted to spare PEBs a subsidy cut.
This is Betsy. I do have one last question. So when we're talking about the option B, we're looking, according to Laura, at the 5% level. And is that giving us the same amount or close to the same amount off of the 36 million that the other grid is?
Yes. Okay. Option 8.1, A, B, and C are all designed to basically yield $20 million in subsidy savings, just using different levers to do it.
Okay, thank you.
Okay.
Yes, Tom Verducci for the record. I wanted to answer Chair Fried's question that I would not prefer plan design changes. I'd really like to see the changes in a temporary fashion with higher rates, and I would like, I'd like to see a sunset provision as well to see if we're in better shape to restore benefits. I don't want to see anything permanent or any elimination of benefits on a permanent basis. I think that if we could get through with a surcharge and have it sunset at some point, that hopefully in the future we can get back to the exact same benefits or even better benefits that we have today. I just really hate reducing benefits and just the impact that it has on so many people. Whatever we could do to restore them and get through this crisis on a temporary basis is what I would prefer.
Okay, thank you, Mr. Verducci.
Chairman, can I add to?
Sure.
I do remember I started state service in 2013, and I do remember reviewing the health benefits plan for my wife and I looked through my old documents, and I do know that the individual deductible back in 2013 was about $1,900 with an out-of-pocket individual max of $3,900. And today they're at $1,500, and I do know that during the public comment section, they say, you know, benefits get reduced and they don't go back. But just on my 7 years of state service, they have gone down, although I do understand that's not pre-recession rates, but they do change in reflection of the current economic status. Another example would have been co-insurance. Co-insurance was 25% back when I started, and now it's down to 20%. So I do like the idea of a sunset. Love that idea because it doesn't hog tie us to permanent changes. That's all.
Okay, thank you. All right. Board members, I think I'm going to ask you to choose one of these three to put forth, and then go on to the other 16 million in subsidy reductions. And I hear that most board members would prefer to do as little to the plan design as possible and make it up in the higher premiums. And make a policy statement to the governor's finance office that we would really like to see this, see the subsidy levels return to what they were before we entered this fiscal crisis. And I can well sense the board's reluctance to make a motion or talk more about it. But we are unfortunately not in the position of deferring the decision because our next board meeting is in January. And January is when the governor's recommended budget is released to the legislature. So if the board does not decide, the governor's finance office will decide for you. And you may very well not like what you get.
I just have one quick clarifying question, please. Because these are only specific to plan year 22, as Laura had indicated when she was giving her, Laura Rich, the executive director, had indicated when she was giving her kind of overview of these three options, but in plan year 23, we can still expect to see an additional $30 to $40 on each of these premiums, right?
Right. So Laura Rich for the record. Yes. So the way trend works is the way the PEB program works is the legislature approves a subsidy level in the first year of the biennium. That subsidy level then, depending on what trend is on the second year, the participants get to absorb that entire amount because there is no way to go back to agencies and essentially say, you know, we need more money. And so it gets kicked back to participants. So expecting that there is going to be a certain amount of trend in that second year, those subsidy or those premiums will be expected to go up in plan year 23. So if you're looking at $74.65 for an employee only, today they're paying $43, about $43. This is going to go up to, you know, almost $75. In plan year 23, it could go up, you know, potentially by another $30.
I have a question. So so could we take, this is a slightly new plan design, like we said in the B. So we are giving back with some of the plan design. But could we, if we took that plan design, could we say the premiums are the same as this year plus XX surcharge, which would be the difference? So the one that's $74.65, if it's 43 now, that's $31. I'm just rounding it. So we would say the premium is $43 and whatever, plus a $31 COVID surcharge. So you're getting the same amount of money, but it feels like it's not as much the premium raising. It would honor some of the public comments, get to the same place. Just throwing that out as an option. I don't know.
This is Laura Freed. I'm confused. So the surcharge, what in that instance is the difference between a surcharge and just raising the rate?
There is no difference in the final outcome, but I think what I heard from the public comment was people were more comfortable paying that added money in a surcharge because the surcharge didn't seem like it might last as long.
Oh, but I mean, but that's a rhetorical device, is it not?
It is.
Okay.
But that's still what I thought I read in all the public comments from everyone was they felt that they knew that more money was going to have to be paid, but they were more comfortable with it being called a surcharge, unless I miss what they said.
Okay, I think maybe your understanding of it is different than mine, because what I was reading in the public comments was that everybody pays the same surcharge. And that's where I characterize it as a flat tax, as opposed to just increasing the premium based on coverage tier.
This is Laura Rich. Can I just add something to the COVID surcharge that I think is important to emphasize? A year from now, I'm crossing my fingers, COVID-19 will be hopefully a thing of the past. We'll have a vaccine, and it will be something that doesn't dominate our lives like, it does today. We will be imposing this surcharge for the very long foreseeable future, potentially. I think PEB is going to have a hard time spinning that and selling that. After COVID is said and done and gone, people are going to be asking, why is it that PEB is imposing a COVID surcharge? We have a vaccine. Oh, and if there is potentially a stimulus package that gets passed, they're going to ask, well, why is it that PEB is imposing a COVID-19 surcharge when the feds have released this, stimulus package? Why are we forking out the cost for this while the state is bringing in revenue from, the federal government? And so these are all, potential communication challenges that we're going to have by calling it a COVID-19 surcharge.
Yes, Tom Verducci for the record. So I think if we had a sunset provision where if everything was readdressed 1 year later and maybe we come out of COVID And also the legislature in the next plan year could make a decision to increase subsidies and funding. And I do think if it expires, we're forced to readdress it and see if we're mandated to continue with the higher premiums, or if it sunsets, it goes away a year later and we get right back to where we were.
It's Michelle here. I have a question about option B and also just a comment. So in previous years, Executive Officer Rich, hasn't the legislature actually approved health insurance subsidy increases in the second year of the biennium to cover inflation? And isn't that something we could request this year, even if it's just a small increase? You know, if we've got to take the full 12 this year, obviously we'll be passing that on. But if we can somehow build in that cost of living, the increase for the subsidy in the second biennium, that would be great, right? But specifically, my question regarding option B, I'm getting into the detail, so I'm very sorry about this, but I'm comparing the modified CDHP with the low deductible PPO, and just purely using the rate for employee only. I subtracted the $74.65 from the $102.92. The difference in premium per month is $28.27. If you multiply that out by 12, the difference in premium for the whole year for the copay plan is $340. And PEB on the high deductible plan, you're giving $500 into the HRA. I'm having a hard time seeing how the average employee wouldn't go to the low deductible high PPO. There doesn't seem to be, the copay plan seems to be extraordinarily cheap, I guess is what I'm saying, compared to the CDHP, which has been gutted in the proposal, right?
So let me chime in on the first part of your question, and then Stephanie, I think you can probably address her second question. So yes, to answer your question, the legislature does they do approve a subsidy in year 1 and a subsidy in year 2. However, if the trend is different in that second year, if there's circumstances that that PEB hasn't accounted for, that is 100% picked up by the employee, because there is no mechanism in place to go back and ask the legislature to increase that subsidy in the second plan year. I know that we have worked with GFO, and Ms. Eaton might want to chime in as well, but we have worked with GFO to try to even out these increases a little bit and possibly apply more or less in year 1 and more in year 2 to make up for that difference. So we're trying to even it out as much as we can. But again, with these significant cuts, we're talking $72 million. It's really difficult to not have major impacts, whether it is in premiums or benefits. You can't get away from it one way or the other. So Carrie, do you want to add to anything that I just said?
No, you really hit it spot on. We did try to, just shift a little bit more of the subsidy to the second year, just, in anticipation of that increase in trend and to even out the hurt to the people paying more when trend does increase.
And Stephanie, do you want to maybe take that second part of the question?
Can we repeat it? I apologize. It's been a few minutes and I want to make sure I remembered it correctly.
Yeah, I'm just, what I was just pointing out is that if you do the math purely on rates, the low deductible PPO is a total of $160 for employee only. The low deductible PPO on an annual basis is only $160 more expensive than the consumer driven high deductible plan. And for that $160, I'm sorry?
Under which option? I just want to make sure I'm following the right page.
Oh, I'm sorry. I'm looking at option B.
Okay.
And so what I've done is I just kind of took the difference in the premiums. I subtracted the $500 that the HSA provides for the net difference of $160 for all of those copays. So I'm just a little confused about, and that's spread over 12 months and you get the copay. So I guess I'm confused about how these have been priced. And I understand that the premiums are, will change, but they're accurate, I guess, up to kind of the claims data up to date, right? So why would the actuarial value be so much, the actuarial value, why is, I just fail to see how everyone wouldn't switch into the low deductible PPO plan, I guess, on this, if it's only employee only, if it's only going to cost you $160, but you get predictability when you go to the doctor.
Well, I think it depends. I think some folks that are in that employee plus family tier that do not pay $343 today, but tomorrow, if you pick option B, they do have to pay $343. They may not have that additional $70 to tier up into the copay, the new copay plan at $410, right? So each individual family, if you're making 30 grand a year or 40 grand a year, any kind of change that's being made on that participant premium is already probably a burden to those folks, right? So I think you're going to see a lot of people sticking with the CDHP plan and not moving into the copay plan. Now, we designed the copay plan with the hopes that people would take a hard look at it, right? Like, we do feel like it's a good plan, and that's why we're proposing it. We want those folks to be able to have that predictability and be able to go to see the doctor, at a copay. Same thing with getting their prescriptions filled at a copay. But it does come with a little bit of an increase in cost. Because again, the plan is paying the same regardless of which plan people pick, and you see that in the base subsidy amount. So then the cost then comes out on top in terms of the participant premium.
I guess I'm just curious about, shouldn't there be some risk factor built into the CDHP?
There is.
So employees are incurring all that risk for employee only $160 a year.
They're actually getting a benefit. It's assuming the people that are less expensive are in that plan. So they're actually getting a benefit of being lower risk folks.
So can I put some context to this maybe? So for example, let's say that there's a young couple, they're, 25 years old. They are, in entry level positions in the state. They're young. Most of the time when you're, 25 years old, you are not necessarily, you don't have chronic conditions, you're not incurring high costs in healthcare. But at the same time, and healthcare is really not too important to you because you don't receive care very often. But at the same time, it's you're 25 and broke. You don't have the ability to, to pay, $150 a month for something that you don't necessarily utilize. And so a lot of these people on the CDHP are A-okay with that benefit because what they're paying out of pocket monthly is very, very low. And they are assuming that they are not going to be using healthcare as often as many others would. And then you get into the low deductible copay plan. That's kind of a middle option. So let's say that there's possibly a family with children who have to go to the doctor quite frequently. So if you're a family with children, anytime you go to the doctor, you're paying out of pocket because chances are you have not met your deductible, you have not met your out-of-pocket max. So what that low deductible plan offers is the ability for that family to, you know, take their sick child who has an ear infection, and they can do that for $30 versus having to pay the entire cost of an office visit. This copay option does offer that choice. And then you've got the EPO and HMO. Those are people who usually have more chronic conditions. They want to rely on those copays, on the expected premiums, out-of-pocket premiums that they know that they're going to pay, and they will be then, you know, they know what to expect. They know what their healthcare is going to cost. Now, obviously, this is just an example. This only covers, you know, just these are examples that I'm using for each, you know, type of person or type of experience. There's obviously people with very chronic conditions who are okay with being on the CDHP. They are okay with, they want to contribute to the HSA. But that's just kind of to put some context into why people would choose one over the other.
I guess I'm just troubled because I think in July, when the board passed their policy of subsidizing each of the plans at the same rate, I don't think anyone anticipated the plan then being asked to save such huge amounts. And so when I think what I've heard from employees, and when I look at kind of the designs, it feels like the budget is being made whole on the back of the CDHP. And I guess so, you know, I mean, and in some ways the design as it is, I feel like is a self-fulfilling philosophy where you're kind of going to drive, you'll have modified CDHP where people are either defaulted, you know, and they're looking for the lower rate. But I do think, but it concerns me that there's not a base plan anymore, you know, and whereby if you subsidize the base plan at a slightly higher rate, obviously that impacts the premiums for employees, which comes back to some of Tim's comments. But so it just, I think the unintended consequences of a policy change in July in a vacuum, and now the 12% that's needed to be saved are kind of at loggerheads almost to me. It just feels, because it's all changed, right? The actuarial values, everything's changed to kind of fit in the 12% cap, and then also that the subsidy being the same across all three plans. So that's my concern.
Same here. I just wanted to thank Laura for that context because, yeah, I am the CDHP plan, and I may eventually go to the copay plan as my family grows and wind up in the HMO plan as I get even older or more experienced, pardon.
The only other question I have is an easy one, and it won't take long. But so just the detail between calling it just your monthly premium and the COVID surcharge, could we run into issues with the taxability or the pre-taxability of a surcharge on health insurance, if we call it something like that?
This is Laura Rich. That's actually a very good question. I mean, it all comes down to semantics. I think it's all how the plan is built, but that's probably a question that we would want to run through compliance and possibly through legal as well, just to make sure that that would be feasible, because you're right. It has to, in order for it to be pre-tax, it has to meet certain definitions. So
yeah, this is Betsy. That's a great point. I was just responding to public comment, but that's a really good point.
So based on Member Kelly's comments, is there any appetite to reverse our policy decision about the plan design from July and just have, as we do now, of CDHP and an EPO/HMO?
Thanks for that curveball.
Well, and just to reiterate, like I thought one of the policy decisions Executive Officer Rich said was made in July was how the subsidy was applied. The subsidy would be equal across all three plans. So I wasn't sure if that was actually wrapped up with the low deductible or the regular PPO plan, or whether they're two separate levers, I guess.
So Chair Fried, I just need to go back and if we're looking at really going back just to CDHP and the HMO and EPO, there's honestly no way that we can submit a budget tomorrow, because we'd have to go back, we would have to go back and
completely understand that it would
the analysis
blow the workbook apart. I get it. I was just trying to I think the answer to Member Kelly's question is the application of the subsidy equally rolled into this, and I think I'm almost sure the answer is yes. And I was trying to address her concern that we might be inadvertently causing some sort of adverse selection away from the CDHP.
Probably would be an open meeting law issue too, because the policy change for that isn't really on the agenda.
Fair point. Fair point. Okay. So that kind of brings us back to this 8.1 as the way to get most of the subsidy reductions that we are asked to submit. You know, being forced to choose the least worst option. Do you like A, B, or C better? I have heard general least discomfort with B.
Tim here, I'm a fan of option A, just because it
You're a fan of option A, okay.
impacts my wallet a lot less.
Okay.
So it's Michelle Kelly here. So so I guess obviously I think that I prefer option C. However, I am conscious that we still have to we still have to look at all of the other items that are about, $12 million, right? Or that are another $20 million, $16 million. So, I think that based on what I hope happens out of that, then I think option B might be the place to start today. That's where I would support option B.
Yeah, and this is Laura Rich. I just also want to say one of the options, option 8.10 unbundles dental, which will add yet another premium to an already higher premium if we move to option B. So it's definitely something that has to be taken into account.
Linda Fox, for the record, should we rank these to get through this first item? Should we rank A, B, and C?
We've done ranked choice voting in the past.
I think that might be simplest.
All right, so I think I'll have to ask the staff to get their score sheets out, and then I can then do a roll call as we have done in the past, and then each member can state their 1, 2, 3 preference for A, B, or C, and we'll see how we arrive at consensus that way.
And this is Betsy. I'm just wondering, and maybe would it behoove us to talk some of the others through ahead of time? Because one of the other options is to adjust premiums down below. And so if there's a bunch of things down below we don't want to take, then maybe we would lean more to the plan on option A, but with an adjusted premium from that. Just wondering if we need to, because
Right.
like it is levers that play.
Right. I'm going to throw that to the executive officer to see. I mean, I think it's 8.2 through like 8.8 is fairly discrete savings measures, but you're absolutely right that 8.10 does. And then in 8.11, increases in premiums savings varies. So how does that, I mean, how does that play into 8.1?
So yeah, I mean, I think that maybe going through a lot of these other options and discussing those first might be helpful before voting on this first part.
Okay, then take it away with 8.2.
Okay. So, I mean, I'll just start out with the first, oh, go ahead.
Before we move on, can I just request a quick like 5-minute break?
Absolutely. It's 1:06. I'll see you guys at 1:10. Hello again, everyone. It's 1:12. Let's call the meeting back to order and go back to 8.2 and so forth.
Okay, so for the record, Laura Rich, I'm going to start out with saying that the first three here are fairly benign options. The rest of them, not so much, but at least we do have a few here that are benign. The first one is 8.2, which is addressing out-of-network bill charges. What we're doing here is today on the CDHP, when we have an out-of-network charge, what we do is Fair Health has historically been considered basically the claims payment market solution for the pricing of these non-contracted providers. They maintain a database of billed charges by service code and zip code, and we pay them essentially off of that. This is referred to as the Fair Health usual and customary charge. What we are proposing here is moving to a reference-based pricing Medicare model where we use Medicare to essentially control the pricing and establish a price point in a geographic location. And so what we're doing here is proposing that we move to basically, instead of using Fair Health standards as the usual and customary charge, is moving to 140% Medicare model. So what we do is we would pay for these services at 140% of what Medicare pays today. So it's a fairly standard method of payment. It's something that providers are very used to and comfortable with and understand. And that this will bring in approximately almost $2 million, $1.9 million on that one. So I will stop and see if there's any questions on that one.
This is Jennifer Krupp. Excuse me. That 1.9 million, is that claims payments that would be reduced, or is this a contract that we would be terminating? I was a little confused on that.
So they're not contracts. So essentially for out-of-network bill charges, so when someone goes out of network, it means that there is no provider contract in place. We have no contract in place. They are outside of that network. So there is no contract in place. So we have to pay them somehow. And so what is a fair price to pay? Right now we use that usual and customary charge. Instead, what we are moving to is a Medicare reference-based pricing model of that 140% of Medicare. So if Medicare pays X, PEB will pay in our plan rules. Our plan's rules will change so that it'll say that PEB will pay X times 140%. So it's 140% of Medicare, which is a reference-based pricing model that people are moving to, that plans are moving to nationwide.
This is Laura Freed. One question. So this affects out-of-network claims, obviously for actives and non-Medicare retirees, right?
Yes. So sorry. So this is yes, anyone on the PEB, on any of the PEB plans. Mm-hmm.
Thank you.
So Laura, it's Michelle Kelly for the record. Do we have employees and retirees in Nevada who live so rurally they don't have access to a network? And if so, do you know approximately how many and how those communities are going to fare with a reduction, essentially because the employee ends up having to pay that cost, right? Or the provider has to eat it. So I'm just wondering like how it impacts our rural folk.
So the rural folks, unfortunately, they're going to be impacted, but not so much because of the network. It's so obviously our network is an in-state network. It's provider based. So, and that's something that is a challenge in Nevada, not just in our plan, but in healthcare in general, right? So you get up to the rurals and there's a shortage of providers. There's a shortage of especially specialists and things like that. So whether they have access, yes, they have access, but maybe not within 5 miles, maybe not within 10 miles, right? So there's that is a challenge within our healthcare system, not necessarily on a PEB level. Does that make sense?
Yes, thank you.
Okay.
Laura, can I add something there?
Yep.
This is Mary Catherine Pearson for the record. Just to clarify as well, this reasonable and customary piece will not really have any impact on the people who are in the rural areas. But, you know, the providers who are there, and to Laura's point, there are not a lot of them. Those providers typically participate in the network. This is really, there's out of network utilization sort of spread all over. So whether it's in Southern Nevada, whether it's in Northern Nevada, whether it's folks who are out of state, it's fairly all over. But this is also something that we're really seeing across our book of business. So it's a change that a lot of people are making. And we've also seen it in some situations really encourage providers to move into a network because there's more of a reason to do so versus staying at that higher reasonable and customary level that's coming through Fair Health.
Thank you, that was helpful.
Mm-hmm.
This is Tom Verducci. I think 8.2 is a reasonable cost-cutting measure, and we saved 1.9 million, and that ranked #1. And I do think that the out-of-network billing is very acceptable, and I'm in favor of adopting that one.
I would second Tom's position as well.
I agree with it.
Okay, Tom Verducci, can I turn that into a motion?
Sure.
Well, so
I feel like you and I had the same thought at the same time. Please go ahead.
So I think what we need to do here eventually is rank them. Not so much emotion needed for each one of them. I think that there needs to be a ranking of what is most palatable to least palatable of these options.
Okay, Tom Verducci, that was a #1 rank on my grid sheet. So 8.2, I've ranked that one #1, that is most palatable.
Chair Freed, did we want to raise our hands perhaps?
Well, I guess in this, going back to the discussion we were just having about sort of ranked choice voting on 8.1, that's, I guess we can pull out the score sheet again and have everybody tell the staff their rankings on 8.1 through 8.10. But I mean, I would prefer, honestly, from a legal standpoint, that the board take action on all of them. And we can do that all at once, or we can do that separately. But I mean, to help staff in case the governor's finance office, in consultation with the governor's office, wants to put some of it back. I mean, I'm hearing a lot more consternation on 8.1 and the plan design and the premiums than we might hear on, well, at least a few of these things. So, okay, so let's do that. Let's have the executive officer and the staff go through 8.1 through 8.10, and then we can hear the rankings from everybody, and then we can vote on them. Sound good? Okay, let's do that.
Okay, so moving on to 8.3, some of you may recall that in Plan Year 19, PEB implemented Smart 90 to the CDHP on a voluntary basis. And then in Plan Year 20, it became mandatory. For those of you who do not know what the Smart 90 program is or need a refresher, Basically, Smart 90 improves drug pricing on the 90-day maintenance medications through that program. And what it does is essentially it narrows the pharmacy network to only Smart 90 participating pharmacies. The two major ones that are excluded from this network are CVS and Walgreens. When we did this on a voluntary basis on the EPA or on the CDHP, there were obviously complaints here and there, but for the most part, I think that that transition was made fairly easily, especially since we did it on a voluntary basis the first year and then mandatory the second year. Essentially, what it does is it mandates that 90-day prescriptions be filled in through a participating pharmacy. What we're proposing here is to add this to the EPO and low deductible plan as well. And that should bring in approximately $500,000 in savings through this program alone. And I'll stop there for questions. Okay. So 8.4 is very similar to this. Similar to Smart 90, the Express Advantage Network moves it to the 30-day prescriptions for both members and, 30-day prescriptions of narrowing of that pharmacy to fill those 30-day prescriptions, not just the 90-day prescriptions as in Smart 90, but also the 30-day prescriptions. The difference here with this option versus the Smart 90 is that with Smart 90, we mandate it, and there's the program or the plan does not pick up the cost of the medication if it is filled outside of one of these pharmacies. However, in this situation, the Advantage Network, using that Express Advantage Network, if you use it, great. If you do not, you pay a $10 fee, essentially. And this is the proposal here is to be adding it to the CDHP, EPO, and low deductible plan. So in these two options, this does affect the actives pre-Medicare retirees on the CDHP and EPO and low deductible plan as well. So it excludes any Medicare exchange retirees. Any questions on that one? Okay. Next one is 8.5. This is a reduction to the Medicare health reimbursement arrangement contribution. This affects Medicare exchange retirees. These are the only group of people who receive a Medicare health reimbursement or Medicare health reimbursement arrangement contribution. Right now, that contribution is $13 per year of service, up to $260. So you top out at 20 years of service. What we are doing here is proposing reducing that from, and there's two options, from $13 per year of service down to $12, or from $13 per year of service down to $11. The difference there is down to 12 saves the plan $1.7 million, down to 11 saves the plan $3.4 million. Any questions on that one?
Yes, I have a question. This is Laura Freed. How many Medicare retirees spend $2,000, because $13 per year of service times 12 months times 15 years, the base subsidy is $2,340 a year. How many people spend that from their HRA on their Medicare premiums? And if we were to reduce it to $2,160, which is $12 times 12 months times 15 years of service, how many people spend that out of their HRA, if we know?
We could certainly do that analysis. I know that back in, if you remember, back in April, we capped the HRAs because there were a lot of members who were not using their HRA at all, whether it is because they did not need to use it, whether it's because they don't know it even exists. It's still a mystery to me as to why some of these retirees are not using it at all. Now, there are retirees who use their HRA on premiums. You've got your Medicare Part B premium. You have, if they've enrolled in our dental plan, they can pay for that premium as well. And then there's also obviously out-of-pocket costs that they can incur on their Medicare plan. And so while it is, it's definitely a very beneficial contribution, there is a certain percentage of the population who, as you heard back in April, doesn't use it at all. And then there's, many Medicare Exchange retirees who are on zero premium plans as well. And so really that, they're not using it to the degree that they could be using it, or that they have a better benefit than what they need. Now, I'm sure there's, on the flip side, there's people who probably use it every single month and use it for, out-of-pocket costs or any premiums that they have. So we could do that analysis. I don't know, Carrie, is that something that you can do just on the fly while we're talking?
I can try to see what I've received from Towers Watson as far as utilization, but I may need Towers Watson's input to give definitive, useful information, but I will look.
Any other questions? Nope. Okay. So 8.6 is the reduction or elimination of basic life insurance, the basic life insurance benefit. This affects all PEB members. Currently, we've got actives who are receiving $25,000 in basic life insurance benefit, and retirees who are receiving $12,500. So the options here are to reduce it or eliminate it. Reducing it to $20,000 and $10,000 brings you down to about $1.3 million in savings. Reducing it to 10 and 5 brings about $4 million in savings, and completely eliminating it brings about $7 million in savings. I do want to say here that the average burial, I looked that up the other day, is about $7,000. And so this life insurance benefit, it's a basic life insurance benefit. We do offer voluntary life as well through our voluntary platform. There's plenty of people that have a voluntary buy-up life insurance option. But this is here, this basic benefit it's not a very rich benefit. So that being said, covering the cost of a burial, I think it's important. It's important to be able to at least do that and to keep that benefit. So even, reducing it to that option 2 makes sense. Eliminating it might be, it might be one of the more extreme options. But I just wanted to put that out there that, I did look that up, and an average burial is about $7,000. Obviously, that changes with location and, other variables as well. So the next one is the elimination of the long-term disability benefit. And I'm sorry, I should have paused there. Is there any questions on the life insurance before I move on?
Sam, here, just a point of reference, because I did mention I looked up the benefits back in 2013 when I started. At that time, the employee retiree benefit was $10,000, $5,000. And knowing that it was that amount, I did go private and secure my own life insurance benefit.
Yes, Tom Verducci for the record. I don't really like the idea of eliminating any benefits. I mean, I really don't even like the idea of reducing it, but I think, elimination should really come off the table. I don't really see us being asked to eliminate benefits. We're trying to get through a catastrophe here. And once we go into elimination, we're looking at plan design changes. I do agree that it's, barely enough for burial. One of the problems we face, we are managing a health insurance program. We have some ancillary products that are tied into it that affects the pricing, life insurance, long-term disability. But I'm very much against creating any kind of catastrophe for anybody. And creating a catastrophe, we're going against our mission statement, which is not to create a catastrophe, especially when we're looking at the retired elderly group that are probably getting hit the hardest in terms of their income levels. So, my thought is to really avoid any kind of elimination.
Maura Sherbin for the record. I agree. I think that at least guaranteeing someone that they can be buried, or at $5,000 maybe, have to kick in some extra money. But I think that that's important, and eliminating is just not something that I would like to do. I myself have no children, so I don't need life insurance. But this would guarantee that my family wouldn't have to pony up to pay my funeral.
And it's Michelle Kelly here. Just the last point in support of not eliminating. If it's great that, that when Tim was hired, he realized that the life insurance wasn't a lot and he elected voluntary. Of course, being a new hire is an opportunity where you get guaranteed coverage. But if we eliminate life insurance, there's many people out there who would not qualify for health reasons for picking up life insurance or couldn't afford the premium for the insurance they could get. And so the elimination of the life insurance could create a lot of issues. One, of course, being that they can't be buried, but it's important to note that many people would not be able to replicate this insurance themselves.
Tim here, if I can clarify, I'm definitely against eliminating it. Definitely. I was just a point of reference, from when I started in state service.
Yeah, I realized that. I was holding you up as the trophy boy. That's good.
Okay, so if there's no more questions on that, I'll move to 8.7, which is the elimination of the long-term disability benefit. This benefit only will affect active employees. Obviously, retirees would not be eligible for this benefit anyway. The benefit is designed to help protect against a loss of income in the event of a disability that results in the ability to work for an extended period of time. If you look at the utilization here, you had 21 claims in plan year 20 and 25 claims in plan year 19. We have a total number of active claims of 117. There's two things here that I want to emphasize. One, this would be made available, I've spoken to the standard, this could be made available as a voluntary option through the voluntary platform for employees to purchase separately. And two, should this be eliminated, any of the active claims today would not be affected whatsoever. So I just wanted to make sure that those two things are highlighted. And I'll stop there for questions. I know this is
I have a couple of questions, comments. As mentioned in some of the public comment, state employees aren't eligible for Social Security disability. And if you work anywhere else, you are eligible for Social Security disability. So you do have some income. I'm not sure though, if our disability is a richer plan than Social Security, as if it's paying more, because some of these others, we did have reduction options versus just total elimination, as we heard. So I don't know if ours is richer, if it could be a potential savings if we brought it in line with Social Security, but because Social Security isn't an option, it may only be a few people, thank goodness, families that have to have this, but it can devastate the families that do.
Betsy, Laura did mention that the 117 active claims would not be affected. Is that correct, Laura?
That is
Yes,
correct.
but if you were to become disabled tomorrow and you weren't an active claim and we eliminated this, you wouldn't have Social Security disability income or this disability income. My background is an occupational therapist. I worked 20 years in inpatient physical rehabilitation. So I did see how many families, and at least the majority of families did have Social Security disability, and the state employees don't. So I don't, but that's kind of my personal background. And so that's why I was wondering if we're paying a richer benefit, because I'm concerned for those young families that may have something happen.
I agree with you, Betsy. So I guess the question is, can we get away with not eliminating it, but keeping it in line with Social Security?
So I do have, for the record, Laura Rich, I do have Kurt Kemp. Hopefully he is on the line. He represents the Standard who offers this product. Kurt, are you available to kind of discuss this option? I know that at the last minute you had sent a few things that some options that were not lined out in the board report due to timing. Again, we had 13 days to come up with this. So Kurt, do you happen to be on?
I am. Hi. So thanks, Kurt Kemp, for the record. Nice seeing all of you. I know this is a tough meeting. So thanks for including me, and sorry for my voice. So regarding Social Security, that's really a moving target in the sense of, depending on years you qualify, dependent, that kind of thing. I would say in general, the plan that the state provides is probably more generous than what Social Security offers. Traditionally, a group plan will offset, a Social Security. So if a member is awarded down the road Social Security, the group plan would offset that amount. Your benefits 60% of ability earnings up to $7,500. So it's a good plan, especially since your average wage earner, as I heard earlier, is $40,000, which equates to about a $2,000 monthly benefit. So yeah, so that's kind of my response regarding Social Security. So yes, is it possible to design the plan where it's a little bit more even with a potential Social Security buyout? Sure, we can definitely look at that and provide some options. As Laura had mentioned, we also provided a few options, and I'm looking it up here. As far as ways to continue to offer the plan, but pare down the benefits. And there's a lot of ways to look at this. You can, you have a 60% plan, so you could change that to 50% and pay 10% less. That will, it's kind of like what Laura said earlier about levers. Premium is based on levers with an LTD plan, so everything has a cost associated to the plan design element. So one option we provided was reducing the 60% benefit to 50%, lowering the maximum from 7,500 to 5,000, continuing to have your 180-day benefit waiting period. And your current benefit duration goes through age 65, and that does allow some payout beyond 65 if you were to become disabled toward your retirement years. But again, this is an active benefit, but that would result in an estimated savings of about 1.5 million by making that plan change. And again, you can look at this a lot of different ways. So I just provided a few. Another option, the same 50 to 5 180-day benefit waiting period, but change the benefit duration from a benefit that would pay out to age 65 and make it a 5-year duration. So most people will come back to work within that 5 years, but the potential of someone who becomes has a major illness or becomes disabled and it's not something they can come back from, that could affect those employees, but it would capture most people who traditionally do want to come back to work. No one really wants to sit at home and be disabled. A couple of other options: keep the 60% benefit to 7,500, and you can reduce the benefit duration to 2 years. And the 5-year duration with 50% plan, that would save an estimated $2 million of annual premium. Okay, and then that last option where you keep the 60% to 7,500 and reduce the benefit duration, meaning we stop paying claims after that 2 years, that results in about a $1.8 million savings. You can really slice and dice this a number of different ways, and keep I'd say the majority of the PEB population pretty whole as far as depending on what their income is. It would affect by decreasing the maximum, you're going to be hurting your higher wage earners. By reducing the benefit percentage, you're going to affect more of the normal PEB employee. So any questions on that?
Tim here. Thank you very much for that, Mr. Kemp.
Sure.
I do know that, again, PERS has a disability retirement, but people in their beginning years wouldn't, even if they'd been over 5 years, it would be a very small benefit unless they had worked a fair amount of years before they became disabled.
And just for the information for the rest of the committee, it's Michelle Kelly from the Nevada System of Higher Education. Faculty at the Nevada system are not necessarily in PERS. The majority do not have access to Nevada PERS. They are in a defined contribution retirement plan, and that has no such disability retirement component built into it. So the long-term disability insurance is vitally important to the Nevada System of Higher Education employees.
This is Laura Freed. I have one question about utilization as opposed to active claims. In the item, it says utilization was 25 in plan year 19 and 21, and then active claims is 117. So if all those were closed, we would have a utilization for 21 of 117.
Right. So there's 117 active claims. So those are people that, could have been 8 years ago, triggered this benefit and are still receiving this benefit.
I see. Got it. Thank you.
Mr. Kemp, Tim here. Our benefits is 60%, and you mentioned reducing to 50%. What is the typical market for percentage payout for benefit?
That is a very difficult question to answer. It depends on what type of, if you're a state employer, if you're a county, a city, and the standard does have a very large percentage of municipalities and covering them from an LTD perspective. I would argue that it's not uncommon to have a lesser plan design. I think this is a good benefit, from my experience. In the private sector, even higher benefits, but again, you're dealing with, some executives that make a lot of money, right? So they tend to steer the benefits toward the higher wage earners. So I definitely see voluntary plans out in the market as well, with some municipalities. I know you're not the only public entity to be exploring all of these options, so you're not alone. I don't know if that makes you feel any better, but we're dealing with this across the nation. And so I think everything's on the table. But you do have in my opinion, a rich benefit. And keep in mind, this benefit is taxable. Okay, so because it's sponsored by PEB, it's taxable as well. So the benefit, the maximum's there, and then by the time the benefit, once approved, it will be taxed. But I would argue that I think the plan is a very good plan. It covers, I'd say, most of your higher wage earners as well, and definitely covers the majority of your population. So, if you were to change the plan, I think it would capture most PEB employees. But again, it's a matter of being able to decide, which lever you want to pull, right? If you want to decrease the benefit percentage on everyone, you want to look at just the max. Benefit duration sounds horrible, but honestly, most people do return to work within 5 years. But there are people that won't, right? So if you make the change, again, those employees probably aren't working for PEB anymore. They're directly with us from a claim standpoint, but it could affect so.
Mr. Kemp, Laura had mentioned it was something that we could offer that people could buy in themselves. With you saying that the average salary was around 40,000, are you able to give us what a premium would be that someone bought in themselves? And is that just like with life insurance, does it go up with age, the premium?
So the way we traditionally, like right now, the benefits paid on a per employee per month basis. Typically with voluntary, we like to age rate it. And the reason that is that we want to get participation in the plan. So if you get a level set of premium, we can expect it'll offset the claims. And so we want to position the plan to be successful so we don't have any rate fluctuations because it's employee money, right? So we have not priced out the plan yet because we need to get demographics and make sure we have the most accurate salary information. I was using the $40,000 from an earlier example. So I don't have pricing for you. With age banded rates, the older you are, you will move in every 5 or 10 years into a higher rate in order to, because ideally the older you get, the likelier you are to become disabled, unfortunately. And I'm moving into that category. I've moved into that category myself. So the idea is to get the younger population to want to enroll in a plan like this, the rates are going to be lower. And then as you get older, the rates will fluctuate. And it's kind of similar to the way the voluntary life is structured, where there's moving age bands. And so I would have to go back and kind of, I've asked for some, estimated costs to give you an idea of what it could cost a member. But again, it really depends on what age bracket you would fall in. So it's kind of a moving target. So I can work toward that for you, but unfortunately I don't have that today.
It's Michelle Kelly Just a follow-up question on that then, Mr. Kent. So, so potentially when we first go out with this and it's age rated, if you don't get the younger employees signing up because they can't afford the premium, then how often do you reassess the rates and increase the rates aside from the age banded table? Because what I'm hearing is if we don't get our young people to sign up, the people who did sign up are going to just continue paying more and more and more and more, right, to make sure that you guys are covering your claims cost.
So the idea with age banded is, again, yes, you can, especially during a time like this, right, when you're dealing with people trying to decide what they want to spend their money on. So our actuaries would come up with what percentage we feel would probably enroll in the voluntary LTD. We would try to structure it based on a participation requirement. So say we'd like to have 20% of the PEB population enroll, and we do an effective communication. We work with your new benefit partner, and we really talk about the need for long-term disability, right? And so we will base it on certain targets, and the cost will be, the way we'll structure it is the cost will move up as you get older, And that's a pretty standard type of plan for voluntary LTD. So you're capturing more premium from the older employees in kind of a natural way. And so we're not banking on a bunch of younger employees to take it, but we want to make it palatable enough to where, you know, when I was 25, I'm not going to get disabled. There's no way, right? I don't need this. So we want to make it cost effective enough where it's something they may want to buy. It's not worth, but again, it's important, right? And so that's the mentality behind it. From a rate impact standpoint, it's a group contract. So it'll be based on, say, we quote it and give you 3 or 4 years, and it's locked in at that point. And then we'll look at the experience at that renewal period, and then work with Laura and her team to decide, you know, this is how it's running. And then we will look at everything as a whole to make sure that the biggest thing we don't want to do is raise employee cost. Okay, so that's, as an insurer, that's one thing. It's much easier to ask you guys, hey, you're running really poorly, and this is PEB funded money. It's you guys can make the decision on that, versus if an employee, if you're going to raise their rates, that means you probably didn't price it accurately, you didn't communicate it accurately, or it is just running poorly, and then you're going to have to go tell the members that, hey, by the way, sorry, your plan is running bad, and so we want to avoid that at all costs. So we'd work to make it to communicate it well. So again, it's not perfect, but we do guarantee it for a certain renewal period, similar to what we do with basic life, long-term disability, you know, the employer-sponsored coverages. So that's a long-winded answer to that question. I'm sorry.
Thank you.
Freed, this is Nancy Spinelli. Do you mind if I ask a question of Kurt? In regards, if this would be a group as a voluntary long-term disability package, and it would be a group contract, would it be guarantee issue for those employees?
So we would probably want to make it guarantee issue. There would be a pre-existing condition provision in there to kind of protect the plan from someone who, you know, we want people to buy insurance, and this is a hard one. We want them to buy insurance for something that may happen in the future, right? And so we definitely want to try to avoid having to go through evidence of insurability up front, because anytime you put that hurdle in somebody, how many of you like to answer the medical care? Right. So we want to offer it in a way that we will EOI, but there is that pre-existing exclusion limitation. So you have a 312 in there. So a new hire that gets the benefit right now, we can look back in the first 3 months before their employment to say we're getting treatment for a certain condition, or if they, you know, they just had a stroke and this disability is specific to that stroke. So there are protections in the plan that will help that. But yeah, I would envision us wanting to do a GI offer because I think it'll just make it more difficult.
Similar to when we implemented the short-term disability. We did that for during the initial enrollment. It was a guarantee issue. So we look at that. Okay, thank you.
Mr. Ken, just it's Michelle Kelly for the record again. I'm just switching gears and thinking about the idea of capping or capping the amount of time a person can be paid through this product. So say for employers that you work with who cap it at 2 or 5 years, what happens to those employees or participants, I guess, at that point, because they're probably not employees anymore? What happens to those individuals once the benefit stops?
So basically, they would no longer get the benefit. And for those companies we work with that have this, that are eligible for Social Security, we typically help them achieve that if they're, you know, eligible for Social Security. So that is definitely, you know, with your employee population that you have to consider, but benefits would stop.
Okay, thank you.
Yep.
All right. And this is Laura Fried. I'm not hearing many more questions about 8.7, so we should move on to 8.8.
Okay, so for the record, Laura Rich, 8.8 is the elimination of the Part B subsidy. Right now, retirees who are covered under the PEB plan, so those are those pre-Medicare retirees, this is who this affects, they're required to purchase Medicare Part B. PEB provides a Part B premium to offset this cost. And right now, about 1,100 members are currently receiving that $135.50 premium credit. Eliminating that premium credit, but still requiring those pre-Medicare retirees to purchase that Part B will save the plan about $1.7 million. So I'll stop there. No questions on that one. Okay. So next one, 8.9, is eliminating retiree dependent subsidies. This also affects those pre-Medicare retirees. So these are retirees who are not on the exchange, who are on the PEB plans. Under this option, PEB will continue to offer retiree dependent coverage. However, those dependents will not be subsidized by the plan. Right now, we have the dependent coverage count is 2,106. However, that is for 1,500 retirees. So it's 1,500 retirees covering 2,100 dependents. And that will save the plan $4.5 million. The next one is the unbundling of dental premium. What we're doing here is the current scenario today and how it has been in the PEB plan is that dental is embedded. Dental is a part of your medical premium. Those people that participate on the PEB plan, with the exception of the Medicare exchange retirees who can purchase dental separately, do not have the option today. It comes as a bundled option, medical and dental. What we're doing here, and sorry, let me back up. This affects the actives and pre-Medicare retirees on the PEB plan. What we are proposing here is to essentially unbundle dental. And what we would do is allow participants to opt out of dental. But if you do elect to stay into dental, we would impose essentially a dental surcharge for this. So at the rate of $5 for an employee only, $10 for an employee plus spouse or children, and then $15 for an employee plus family, that would bring us about $4.2 million in savings. Now there's a little asterisk here because if 8.9 is chosen and prioritized before this option, then that reduces it to 2.6. As I mentioned earlier, if we choose a plan design that has higher premiums, this is tacking on another premium on top of that. So that's very important to highlight in this scenario. The next one is 8.11, and that is premium increases. So this varies. Let's say that we choose an option, whether it's A, B, or C, and it gets us to that $20 million mark. And then we choose a variety of options out of all these, but we've only gotten to 30 million out of the 36 million. At that point, we can, again, it goes back to, is what's more important, benefits or premiums? You're either going to reduce benefits or you're going to increase premiums. So in the scenario that we choose several of these options, but the board is adamantly opposed to the remainder of the options. And let's say we're at 30 million and we need to get to that 36 million. The remaining 6 million will then have to be factored into the rates. And we have Stephanie from Aon here who can probably give us a good idea of what that would look like depending on where we land. So that is that's definitely something that we have to choose from if these options don't want to be, if the board chooses to not get to that $16 million mark on these options. The last one is the possible transition of non-Medicare retirees to the Silver State Health Insurance Exchange. So this option, obviously, it didn't fit into my little box here. So I have a couple pages on this. And additionally, I also have representatives from the Silver State Health Insurance Exchange, Heather Corbulic, the director, and Jamie Sawyer from the Health Insurance Exchange to answer any questions should their expertise be needed. But similar to actions that PEB took in 2011 as the result of the recession, this option will require retirees that are either not of Medicare age or do not qualify for Medicare to purchase coverage through Nevada's individual marketplace, the Silver State Health Insurance Exchange, otherwise known as Nevada HealthLink. Because retiree, it's no secret, retiree healthcare is expensive. Many public sector employers are starting to move towards not offering healthcare to retirees, or at least not subsidizing healthcare to retirees. In fact, during the 76 2011 legislative session, the decision was made that employees hired after January 1st, 2012 would no longer be able to receive a retiree benefit subsidy. So in many instances, those employers that do provide retiree benefits have transitioned to providing retirees with financial assistance in the form of an HRA. Retirees can then seek and purchase their own healthcare coverage using that HRA to offset the cost of premiums and or out-of-pocket costs. And leveraging the Silver State Health Insurance Exchange will help reduce PEB's costs while continuing to subsidize retirees with funding determined by their years of service. So there's obviously advantages and disadvantages to this, and I'll kind of cover a little of both here. Some of the advantages: retirees will have more access to more plan options. On the exchange, there's a lot more plan options than the 2 we have available on PEB today. Also, lower income retirees, so those that are under the 400% federal poverty level, which is also referred to as FPL, may qualify for federal subsidies on the exchange and have access to cheaper premiums and reduced out-of-pocket expenses than what they currently receive through PEB. So in the case of someone that is, let's say, in the 250 percentile FPL, not only do they have reduced premiums, but they also have reduced out-of-pocket expenses through federal subsidies as well. Sometimes, in many cases, those subsidies will be more advantageous than the subsidies that PEB would offer. Additionally, the exchange can offer the services of brokers and navigators to help retirees located in Nevada to transition. So we would be working very, very closely with the exchange to use those resources and to make sure that the 4,900 or so pre-Medicare retirees that fall into this bucket would receive the assistance necessary to make this transition. The option also provides flexibility to the state to reduce or raise subsidies based on economic conditions. So to go into the disadvantages, we all know that the ACA has been challenged repeatedly. I think even up to 2 weeks ago, it was sitting on the steps of the Supreme Court. It has been upheld, but it is being continuously challenged. So there's always that, the risk that the ACA could go away. It's been around since the exchange we went live. I was there at the time. It was 2013, and we are now in 2020. So it's managed to remain alive for about 7 years now, even through all of the challenges. But there's always that chance. Also, although retirees in Clark and Nye County will experience less of an increase, premiums will likely increase for most retirees living in Nevada due to the high cost of care and the rules, especially, and the age banding on the exchange. those living in the rurals with higher income, so those over that 450 or 400% FPL, will be hit. Their premiums and out-of-pocket costs will increase. Unfortunately, the impact is unknown for retirees residing outside of Nevada because every exchange is different. Every exchange offers different plans, different premiums, and so we'd have to go through and do an analysis of state by state. This will definitely require a very significant undertaking by PEB. It's going to involve massive communication, a lot of planning, a lot of coordination with the exchange staff as well. This is almost impossible to roll out in plan year 22. There's just no time. There's just no way that this is feasible to do in plan year 22. So this would be a plan year 23 option. And as I will go into details later, this will require legislative changes. So I went through and we put together the makeup of these non-Medicare retirees and kind of went through and provided some information that I think is valuable in looking at this option. So you can see we went through, and out of the 4,900-ish members, you can see the makeup of the retirees and where they sit as far as age. The majority of the 65 plus, I'll tell you, they're probably on the plan because they are what we call anchors. So these are folks who have already reached Medicare age, but they have a dependent who is not of Medicare age. And so they will be they are allowed to stay on the plan until their dependent reaches Medicare age. So for example, if a retiree, the primary retiree turns 65, but their spouse is 62, they will be able to stay on the plan until their spouse turns 65. And so that's where you see a lot of these 65 plus. There's a small portion of this, as you heard in public comment, of those people who will never be Medicare eligible. So those are people that never paid into Medicare who will be on the PEB plan forever and ever. If you look at the federal poverty level chart, this is the 2020 federal poverty level chart. On page 6, you'll see that 250% FPL is about 31,000 for a household of 1, 42,000 for a household of 2. So what I wanted to do was I was interested to see what exactly are PEB retirees making, because that really tells us where these people sit and whether they would be eligible for subsidies or not. And so the first thing I did was I asked PERS, are you able to provide me information on state of Nevada specific aggregate salaries for retirees? And unfortunately, PERS has a lot of confidentiality limitations where they are not allowed to release anything, specifically on employer specific salary data, even if it's aggregate. So I was not able to get anything from PERS. So I went to the next best source, which is the Nevada Department of Administration, and asked for Central Payroll to provide just some general information on retirees. So they were able to provide me with the last 5 years of retirees. So when the income of salary, ending salary of a retiree. So what did that person make when they retired? And it was only retirees, not terminated employees, just retirees. And so I went through and I had 5 years of records on that, and I was able to find the median income for the salaries that were provided to me by the Department of Administration. Now, that median income was $40,419 for the last 5 years. That is assuming that there's a lot of assumptions into this. And so I want to make sure that I emphasize this is not scientific data of any sort, but it is at least helpful data. That assumption is that when a person retired, that they retired under their highest 3 years, that was their highest salary, that one of the 3 years highest salary. While there's people who may decide that, I've reached my highest salary, I'm going to spend my last 3 years being a mail clerk at a reduced salary until I hit my 30 years. That's typically not the case. And then on top of that, we don't know those people that the median salary was $40,000, but we don't know if these people had 5 years of service, 20 years of service, or 30 years of service. So under the assumption that the median salary is $40,000, and that's the income at a 75% PERS benefit, you're looking at, and 30 years, 75% at 30 years, you're looking at a average retiree salary of about $30,000. Again, not scientific, but it's the data that we have to go from. If you look at that FPL, if you're in a household size of one single person retiree, you're at that 250% FPL. You would definitely receive very substantial subsidies through the exchange, not only so the subsidies, premium subsidies, but out-of-pocket subsidies as well, out-of-pocket expense subsidies. Moving up again, to a household of two, it goes from there. So those that are earning lower incomes would definitely benefit from this. Again, as noted above, legislative changes would need to be necessary for this option to be implemented. Although, again, I keep going back, we have 13 days to come up with the analysis for all of this. We have not had the opportunity to vet this thoroughly through legal. However, there's two clear changes to statute that need to be identified. The first one has to do with the commingling of the risk pool. So if you don't have a risk pool of pre-Medicare retirees, you no longer need to commingle them. So that would need to be addressed. And the second one is the statute that addresses how PEB subsidizes retirees. In this situation, we would actually be proposing to subsidize retirees at a higher level because of the higher premiums on the exchange. So retirees would definitely get, there would be a different subsidy proposal, and you'll see this is just the current and proposed non-Medicare years of state retiree subsidies. It's just a proposal that we have come up with, essentially subsidizing those pre-Medicare retirees at higher rates. And on the last page here on page 8, I've provided an example of where this could be beneficial and where it is obviously not advantageous. So a 56-year-old retiree with 20 years of service who is over the 400% FPL, obviously, and not receiving any subsidies, in Clark County today, someone living in Clark County would pay a PEB premium of $54.28, the pre-Medicare retiree. Should they move to the exchange, their subsidy or their premium would actually be zero. And the reason for that is because the PEB subsidy would be higher than what that premium would be on the exchange. In Carson City, the same does not hold true. You see that today they pay $54.28, and the premium for a comparable plan would be $315.78. In Reno, it goes from $54.28 to $163.35. And then again, you've heard me say over and over that the rules are they're expensive. This is where the high cost of care is. And you see it right here, where in Elko on the exchange, that premium would go up to $537 for someone who did not qualify for any federal subsidies. So I will stop right there. I'm sure there's going to be a lot of questions. I'll stop right there.
This is Laura Freed. That is a lot, and it is a lot of work just to get $12.6 million in subsidy dollars. I'm just going to say it. I don't think this is a great option. I mean, I don't support it. The reason I say that is because, well, let me back up. The board finds itself, in a situation where in 8.1, we've got 3 choices to save approximately $20 million in subsidies. If we took 8.1, one of those, and 8.12, well, that would get you there. But there is so much in the way of implementation, and there are so many uncertainties that I have a hard time supporting this, which forces us back into the position of a patchwork of things, 8.1 plus some combination of 8.2 through 8.10. Those are my thoughts, but if board members have questions about the details of the health insurance exchange, fire away.
Tom Verducci for the record. I wanted to point out, I think 8.12 is absolutely horrible. I don't think it's doable. We don't know what's going to happen with the Affordable Care Act, and I just think that one is the worst on the entire list. I mean, listening through this, what I see as the best options would be option B, 8.2, 8.3, 8.4, and then 8.5 option 1, 8.6 option 1, 8.10, and perhaps it'd be a slight surcharge if we didn't get quite to the number. Just my initial thoughts here.
And it's Michelle Kelly here. I'm with you, Tom. I think that you've kind of encapsulated my thoughts as well. So saying that, I do actually have some questions around I just wanted to kind of get some, fill in a couple of gaps in my knowledge. So Executive Officer Rich, when you talk about transitioning kind of the non-Medicare retirees, can you clarify for me, are you talking about just the age, like the people who haven't yet become Medicare eligible? Are you also including in that the people who will never become Medicare Part A eligible? And then just a follow-up question, and I guess I'm really, and I hear Chairperson Freed saying that, this sounds like a non-starter with most of us, but I also am challenged after seeing some of the public comment. I'm really challenged with reconciling the decision to provide data on a 56-year-old retiree versus when, I think PERS allows for 10 years of service and 60, and then they're on until 65. So pricing out a person who's 56 years old feels like it's cherry picking. So can you perhaps respond to that as well?
So
and to be clear, I'm cherry picking a nice premium that you could show some benefit versus a 63-year-old. I don't know.
So this does, you are correct. This does encompass the pre-Medicare retirees who are on the PEB plan and who are on, who will never either have not reached the age of 65, who will at one time become Medicare eligible. But then there's that small group of people who are on the PEB plan forever and ever because they have never paid into Medicare. And so those people for sure would fall into this bucket as well because they are still considered that pre-Medicare retiree population. It does not exclude those. Why we chose the 56-year-old, I don't know if it was, intentionally cherry picking. It was more to, if you look at the age bucket there, from 56 to 65, most of those people are within that range. And so I think that's what the thought process was behind that.
Tim here, if I may comment. The negatives tend to outweigh the positives in this example. Requires legislative changes, significant undertaking by PEB, and it wouldn't even show any benefit until plan year 23. And when plan year 23 rolls around in a year from now, when we reevaluate, all this may not even be necessary.
This is Laura. Thank you for those comments. Board members, I mean, I started it off and I didn't mean to unduly influence you, but I think I hear loud and clear that moving the non-Medicare retirees to Silver State Health Insurance Exchange is a non-starter.
Michelle Kelly, I agree.
Don't all scream at once. Thank you, Member Kelly. Okay, so again, we revert to one of the plan designs in 8.1, or plan design balanced by increases to premiums. Excuse me, some combination of the sort of one-off changes, because I think the other thing that I think it bears mentioning here is that we can't get this savings again if we move to the 140% Medicare model, for instance, Smart 90 for the EPO. Unfortunately, some of those are one-time savings, but we will patch it together the best way we can.
This is Betsy. I do have a question. If when we're ranking, there are some, just as I already heard Tom, I think it was Tom said, that would be something that I would not want to do that currently says eliminate. So I wouldn't even want to rank them as number 10, 12, whatever, unless they could be a reduction instead of an elimination. And so I don't know in our numbers if some we just say, I say no, or we say, I'm okay if PEB does this, if they can come up with X or something. I'm not sure.
So okay, so if I hear you correctly, you want to take elimination of some of these things off the table as an option and just say reduce at one level or reduce at another level.
Yeah, like I would say, I would not want to prioritize the elimination of the long-term disability benefit at all in any of my numbers. But if we say went from 60 to 50%, if that made a difference that really we could maybe do this without an additional premium increase, then that would be something different. But then we're sending PEB so many different options. I don't know how that would work. But for me, that would be a killer to totally eliminate it. So I don't know how you want us to proceed.
Well, okay. I think, well, first I want to talk about ranking, because the staff recommendation on page 8 of the staff report is approved plan year 2022 proposed plan benefit design as illustrated in section 8.1. And we've already talked through 8.1 A, B, and C. So one of those would be staff's recommendation. Correct me if I'm wrong. Rank options 8.2 to 8.10, let's say, in order of preference from most to least desirable for plan year 22 as necessary to meet budgetary goals established by GFO for 22. And then 3, approve staff to implement budget reserve options in order of preference. So when you rank something number 1, what I mean by that is that's the thing I think imposes the least pain, not the thing that I think imposes the most pain. So least pain, second least pain, third least pain, and down the line. just so we're clear. And if you want to all agree, and I don't think we need to take a motion on this, that you don't want to eliminate any one benefit from 8.2 through 8.10, we can agree to that and then just deal with reductions and hope that we get there. I'm seeing some nods. Any affirmative feelings about that? Okay. All right, so let's do that. So that would take care of 8.6 option 3, that's off the table. Okay. And then that would ultimately take 8.7 off the table, because I don't think we have, frankly, the time for PEB to analyze the fiscal impact of equalizing the LTD benefit with Social Security disability income. I mean, we had a nice long conversation with Mr. Kemp, but I felt like the sum total of that was it would require more study. PEB staff, correct me if I'm wrong about that.
So the standard did provide us with some options as far as what those estimated annual savings are. And I do have that in front of me to lower that long-term disability. Now, Stephanie, I know that there's a component in this that would be factored into, you know, whether that would be realized completely or not. I don't know if you want to weigh in on this. And I know, Stephanie, you don't have it in front of you, so I don't know if you can weigh in on it or not.
Yeah, I mean, I would need to see it in order to know if we can loop it in.
Yeah, this was Betsy. I think I probably agree with you. To equalize it with Social Security is out of the question. There's just not enough time. But a couple of the things he proposed, like going from 60% to 50%, because he did say we currently had a rich benefit. He said, or 5 years or 2 years. I might still have a problem with that, but I think there were some options, and maybe Stephanie needs to relook at them. But there were some potential options that maybe could be prioritized down lower, that if some money was still needed, you know, I don't know.
Okay.
He said 10% with the 60 to 50, which isn't a lot of money, but it's the same amount as one of the pharmacy plans was.
So yeah, so bringing it down to, and Stephanie, I just sent this to you, but bringing it down to 50% and continuing to keep the age 65 duration is about 1.5 million in savings.
Executive Officer Rich, do you have did the standard provide the figure for if instead of reducing it to 50%, we keep it at 60, but cap it at 5,000 or 6,000?
Let's see, I'm looking. And Kurt, if you want to jump in here, I'm happy to allow you to do that. I'm looking at it myself here.
Hi, Kurt Kemp for the record. I have not provided that. Again, there's so many options you can provide, but while we're chatting, let me see if I can get my underwriter to give me that. And I'll see if I can get that done quickly. But 60% to 5,000, right? That was the request.
60% to 5,000, and Laura, you said 1.5 million in subsidy savings?
So 50% to 5,000 and keeping the age benefit to 65 is 1.5 million.
Okay. Well, Mr. Kemp, we're probably going to take up some time doing our individual rankings anyway, so I think you have a few minutes.
Okay. Wish me luck. Thank you.
All righty then. I would suggest that PEB staff, do you have your score sheets out? I would suggest we just simply go in alphabetical order. I don't want to make anybody, I don't want to ask for volunteers because nobody would ever volunteer for ranking budget cuts for fun. So whenever you are ready, again, I'm asking members to provide a ranking of number 1 for least pain and suffering down to most pain and suffering for 8.2 through 8.10.
Excuse me, this is Linda Fox. So are we going to include 8.7 or we're not going to vote on that? I know that's the one he's looking at right now.
Right. I think if you wished to rank, I think we could skip it for now. We could omit it till maybe Mr. Kemp returns with some more info. But knowing that if we had 50% age 65 at $1.5 million in subsidy savings, and staff feels pretty confident with that, staff and Aon, we could leave that to the end, and then you can insert that in your own ranking.
Chair, do we want to start out with maybe plan design first? I don't know if that's.
I think that would be fine if we went back to plan design. I'm just trying to make this easy in bite-sized chunks. So now that we've been through everything, we can turn back to 8.1 and talk again about A, B, and C.
Chair,
yes, Mr. Verducci.
Yes, in looking these over, I like option B. I think it's going to cause the least amount of pain, the least amount of damage. I don't like any of them, but if I had to choose A, B, or C, my choice goes towards B.
Okay, is that a motion?
Well, I don't know if you're going to take these all together. I mean, this is a very uncomfortable meeting. I like discussing increasing benefits and reducing costs, but if I look at my notes here, if I could summarize it real quick, I like B, and then I like 8.2. I don't want to say I like it, but this is the way I'd go. 8.2, 8.3, 8.4, then 8.5, option 1, 8.6, option 1, 8.10, and we're looking into reducing as opposed to eliminating on 8.7. Maybe that gets us there. And if we have to jump into 8.11, I'm hoping it's a very small nominal COVID surcharge. That's my initial thoughts from hearing testimony so far.
Staff, did you get all that, or should he repeat that?
Would you like me to read it back?
Yeah, why don't you read it back slower?
Okay, thank you. Option B, I think it's the least damage of option A, B, and C. And then I think everybody concurred from what I heard that 8.2, 8.3, and 8.4 were acceptable cost cutting measures. Then 8.5, option 1, I'm not real crazy about that, but I know it's give and take with both the retirees and the actives. 8.6-1, excuse me, that's a life insurance. And then 8.10, which is the dental. To readdress 8.7, if there could be a reduction as opposed to an elimination. And if there's a slight shortfall on 8.11, which could be called a COVID surcharge. That's what I think is the least painful, and none of this is enjoyable to me at all today here. Cause any disruption for any Nevada citizen, but been mandated to do this, so that appears to be the rational choice from what I could gather at this stage.
And this is Laura Rich. You can see that Stephanie from Aon is, she's shared her screen here. So she's showing the rates, and she's showing the first one is 8.1A and the difference with 8.1B, which is on the bottom. And so these are the rates that includes if you choose these options.
Okay.
So she's essentially plugging in those options, and it is showing what the rates would be in option A and B.
I gotcha.
Thank you very much for showing this.
Yep, I figure it helps to see it in black and white.
Keep in mind too that I think with 8.10, Stephanie, did you add the 5, 10, 15 onto the participant premium? Does that include?
So in that instance, these are rates with dental. If people did not select the dental, you can subtract the 5, 10, and 15 accordingly to get the non-dental medical rate.
This is Laura Freed. I have a question. I don't think Mr. Verducci's ranking got us to 36 million. So is the difference then made up in increasing the premiums?
Yes, you're correct. Both of these will save the plan 36 million. It's just, as you might imagine, it's moving to the premium.
Okay, gotcha.
So this is Betsy. So what looked like 70, the employee only premium was going to be 74 is now 123 because it needed additional premium to get to the 36. Is that correct?
Yes, that's correct. I've selected 8.2, 8.3, 8.4, 8.5 at $12, 8.6 at that first option, 20K and 10K, and 8.10. And at the end of the day, you were still short enough that I had to change the premium to 124 to save the plan $36 million.
Marcia Urban for the record. What would happen if we went with option B in 8.6?
This moment.
Ms. Urban, that is a great question. I was just going to pose myself. Thank you.
Great minds.
Uh-oh, Stephanie, did we lose your screen?
Just a second. I'm recalculating in Excel, and then I'll have to copy and paste it back to Word. Just a moment. Okay. So this is, again, A and B, but using the life insurance at 10K and 5K. I believe that was the question. Is that correct?
Yes, that was the
Yes.
the hypothetical, yes.
Yeah.
Is this including the long-term disability going down to 5,000 cap at 50%?
No, it does not.
Okay. I don't know if other people would be open to that or not.
Betsy, Tim here. I'm open to the 50% 5,000 cap till age 65.
That's what because I'd like to see the premium going down, but I hate getting a million different scenarios where we get all confused, but.
It's Michelle here. Can I just clarify regarding the cap, the $5,000? That's benefits paid, not maximum compensation, right? So it's not $5,000 compensations looked at. So the maximum payout is $2,500 a month. Rather, the maximum payout is $5,000 a month.
Correct.
Can we see what would happen too if we changed option 8.5 to option 2? And then I'm just going to say that I'm really more in favor of looking at all of these at option A for the plan design, simply because in plan year 23 and beyond, there is a very high probability that rates won't continue to go up. And so if we change the participant premium, say for the CDHP, to 117, but then it goes up for an employee only, but then it goes up another $30 to $40 for plan year 23 because of the subsidies, it's really going to make the insurance prohibitive, even if we have a lower or better benefit design.
Okay, so for 8.5, you would like to see it at the $11, and you want to leave the life insurance at the 10 and the 5? Or do you want me to put that back to 20?
Yeah, no, keep it at the 10 and the 5. So option for both 8.5 and 8.6, where we had options, take them both to option 2, please.
Okay, just a moment.
Tom Verducci here. I don't know if it's okay if I chime in here, but looking at the life insurance, going from 25, let's just say with the actives to 20, that just seems much more palatable than going from 25 to 10. I mean, that's a pretty big drop. I was more comfortable with 1, and that would be my input as far as the life insurance. Just such a big drop.
Thank you, Mr. Verducci. One of the things I want to note for historical context is that back in the Great Recession days of 2011, the life insurance benefit was also reduced as a budget cutting measure, but after the recession passed, it was put back. So that's how we got back to 25,000 actives, 12,000 retirees. So it's one of those things that we could reduce for a biennium and then put back. Or it's one of those things that we could say if the GFO wanted to put something back into the budget, it is one thing we could say that would be the first thing to put back. So board members, think about that.
Chairman Tim here, just chiming in. I think we can all agree that 8.2, 8.3, and 8.4 are okay.
Yes, that seems to be the emerging consensus. So I think we don't need to worry about 8.2, 8.3, and 8.4 in terms of ranking. I think you're right. Our discussion points are 8.5, 8.6, and whether we want to go with some reduction in 8.7. I actually don't even hear a lot of dissension about 8.10. Members, correct me if I'm wrong.
I agree with that.
Okay, all
More
right.
Sherburne for the record.
So just for Stephanie's, we're solid on 8.2, 8.3, 8.4, and 8.10.
More Sherburne for the record. On that 810, if that was unbundled, if you were only the E only, you pay an additional $5 a month, and then you would get the normal 4 cleanings, the basic extra, whatever you're getting now. Is that how I understand it?
Yes, and to be clear, this number here, the $62, means you elected dental. So that $5 right now is included. I didn't have a chance to build that, separate column. It'd be $57 if you chose not to do dental, but yes, the plan design remains the same as it is today. It's simply that you're paying a dental premium now of $5. So 5 of this $62 is for dental.
And Stephanie, is that option B right there?
On the bottom.
That we're calling, we have 8.1A, B.
Yes.
I'm
so
kind of lost
8.1A,
here.
I
This is
agree.
what I hoped wouldn't happen, that we'd get all bollocksed up on A and B.
So this is Laura Rich for the record. So 2 things. We have Capitol reporters who they're transcribing this meeting. And so they're asking, please, if people will state their name before they speak. And second, Madam Chair.
And I am sorry as the chair that I have not followed that, nor have I enforced it. Please forgive me, Capitol reporters.
And second, Madam Chair, they're also requesting a quick break.
All right, then in that case, it's 2:50. I will see everyone at 3 o'clock. I apologize. You guys just ping me when you need a break.
Thank you.
I need to pee.
gave me earlier. And all right, so we've got so option B. We save 20.1, right? Go down the less. So 1.9, 500. Reimbursement arrangement, 1.7, is that where we're at? 8.5 at 11. Okay, let's try 3.4. 3.4. Okay. And then they've got 4.0. And then we're doing 1.5. Right. And then 4.2. So 20.1 plus 1 plus This is Laura Freed. It is 3 o'clock. So let's call the meeting back to order. And thank you, Stephanie Messier from Aon, for making your presentation bigger. Apparently the people watching on YouTube very much appreciate that. All right, so let's go ahead. So board members, as you can see, oh, it's even bigger now, thank you. As you can see, we have, if you take 8.1A, the plan design originally in the packet, and add in 8.2, 8.3, 8.4, 8.5 at $11 per month per year of service, 8.6 at the life insurance of 10,000 actives, 5,000 retirees, and then 8.10 incorporating the dental premium in the rate. That's what you get. And on the bottom is option B with all of those other things the same. So,
Chairperson Freed, it's Michelle Kelly here. I just have a question about the rates, or what's presented on the screen right now. And I think it's for Executive Officer Rich. You've indicated in an earlier email that to save the full 36 million per year that we needed, it would cost a surcharge of around $100 per month per member, per employee. So I guess when we're trying to reconcile the numbers that are appearing, if we're only kind of short around the 5 million that needs to be made up, so option B, if you use the pricing provided in that addendum 8.1, incorporate all the other items that you've got listed out here, it looks like we're only short about 5 million, which should be around $14 a month surcharge versus what we're seeing. So I think Stephanie's doing something with the tiering or something. Maybe she could talk to that. Just seems to like that basically the rates appear to have gone up more than we would have expected them to, using the figures that are provided in the agenda item.
This is Laura Rich. I think, Michelle, the number you were, and I'm going to apologize ahead of time because we've thrown around so many numbers that I can't remember what's been quoted and what it was quoting, because sometimes, you know, it was the current plan design. Sometimes it's the one of the 3 plan designs here that are presented here. So I can't remember what that was specifically referring to.
Well, my understanding is it's just referring to if we did no plan, like if we did no plan design changes and we reached the $36 million of savings purely through premium increases, if you will, that increase, it would have been around $100 a month for the employee for us to save the 36 million. But it seems like even after we've entered all of the kind of the different reductions to benefit, that the rates have still gone up more than that would look like.
Okay, so if we do no plan design changes whatsoever, that $36 million number goes up to, I believe, Stephanie can correct me if I'm wrong, but I think it was somewhere between 44 to 45 million.
Yeah, I thought it was around 44 million. This is Stephanie Messier.
Marcia Urban for the record. Stephanie, is that Plan B and Plan C that you have up there?
This is Stephanie again for the record. No, this is Plan A, which was in the original board packet. So in green, this is the one being presented for the first time at this meeting. The blue section at the bottom is the design that was presented at the July board meeting, which I believe Ms. Rich had labeled as option B in the addendum. I do not have option C up here, which is to go all the way back to the one that would need $44 million of savings because of the current designs being richer.
Okay, Marcia Urban for the record. On that one that was in the original packet, it had 4460 as the rate. In the red, well, that had the increase in the OOPs and stuff. That had
Yep.
4460. So is this I mean, I'm kind of lost. I'm sorry.
Yep. So in the packet, that was only to save 20 million. And it was recognizing that you needed to make choices in 8.2 through, I believe, 8.12, I think is the last one, in order to get to that additional 16. So because of the choices 8.2, 8.3, 8.4, 8.5 at $11, 8.6 at the 10 and the 5, and 8.10 didn't get you all the way to 16. The rest of it comes on to the participant premium in order to still get to a $36 million savings. So that's why these numbers are different than the 46. The 46 was only saving $20 million. And I mean only, but obviously, unfortunately, the task ahead of us today is $36 million, and this is the number that gets to 36 million.
Okay, Marcia,
in response,
I understand now. Thank you.
Yep. You're welcome. In response to the tiering, no, I am not toggling anything on tiering. These are the exact same spreadsheets. I have an option tab where I simply flip yes or no, or I flip it from 13 to 12 or 11. So the only two difference between those spreadsheets is the plan designs that underlie the base underwriting for each of these, and the rest of it's flowing through, and I have to toggle those options just yes or no based on what you all are telling me you're voting on or would like to see. I'm not doing anything with tiers. And so I think that the $100 figure you're talking about there, the reason you're only seeing it at $70, right? Today we pay about 44 for the, and then it's going up to 114. So it's not the full 100. So it is getting spread across the tiers, but I'm not changing anything from option A to option B in terms of plan design. All of the structure of the rates is remaining the same. I'm simply changing which plan designs I'm picking from. So those are the exact same spreadsheets, just with different starting points for plan designs, if that makes sense.
I have a quick question. Because these numbers that, Stephanie, that you have up include the dental premium in them, even though we're discussing unbundling the dental premium. On the board packet that we received with option A, do those premiums include the dental premium if it's unbundled as well?
No, so I believe in the packet, again, it was just trying to show what that option itself represents, which is a $20 million savings. And then when we're talking about the dental, I'm showing here what the rates are with that dental surcharge. So again, if we were actually to be producing rates today, there would be a separate table saying I'm electing medical only. So my participant premium, if the board decides to go with option A, would be $57.49. If I was a family and I was not electing dental, it would be $307.31. If I'm choosing dental, that's the rate you're seeing here is the rate shown with the dental amount on it. So certainly the rates could go down if the person chose not to elect dental going forward. Just for ease of not showing you 700 numbers on one page, I'm just showing you the rates. And these rates are the ones with the dental loaded right now because you have said yes to 810 in this current illustration of numbers.
Okay, so my question though is in the option A, like for the CDHP plan, the high deductible plan, the proposed rate's $44.60. Does that include the unbundling of the dental premium? So it would be it'd be like $1 higher, right?
Right. So what was shown in the board packet was literally only looking at a reduced head count and a plan design change. So it didn't say yes or no to anything else, and it only saved the plan $20 million. So again, there was another $16 million of savings that had to come somewhere, and if there's not enough of these other options selected, the difference goes to the participant premium, which is why you're seeing a difference from that 46 to 62.
Thank you.
This is Laura Freed. One more reminder, please identify yourself for the benefit of the reporter. That was Jennifer Krupp having a conversation with Stephanie Messier of Aon.
Thank you
This
for
is
the record.
This is Betsy. I have a question. In regards to the dental premium, we're adding into the savings, the money that people would pay us if they bought in the dental premium. Do we have claim savings if for those that we think might not? And is that how we're getting the total savings, or is it just based on income?
This is Stephanie Messier for the record. So what we're doing here with this savings estimate is we're doing a more conservative approach. We're saying everyone wants to stay on the dental plan. So this is how much those surcharges helps to reduce PEB costs, because they're now getting $5, for example, for every single person who has dental. There would be additional savings to the plan potentially when claims go down. However, if everyone leaves the plan who never uses it, then obviously those folks are now out of the plan, and the plan is actually being rated too low, because the people that are left on a per person per month basis will be spending more than they do today. So there's an additional change that will be happening, yes, if we unbundle the dental and claims change. However, based on your utilization of your plan today, it is fairly heavily utilized. So we feel pretty comfortable that your costs won't go up further. We just didn't want to get overly aggressive and say there's another $2 to $3 million of claim savings. There very well may be by folks leaving the plan. We just didn't want to bank on it, if that makes sense. So what you're seeing right now in terms of savings is really just that additional surcharge that the participants are selecting when they select dental.
Tim here. Can I make a general statement?
Mr. Lindley, is that you?
Correct. Just want other board members to realize that as an active employee, we see what comes out of our paycheck, and option B effectively doubles every active employee's participant premium. And I don't doubt that we would hear a lot of employees commenting on the increase in premium.
It's Michelle Kelly here. I have just a question about the rates as we're seeing up there for Stephanie, I think. I'm just wondering, so when you, and just looking at employee only in the CDHP, just we don't have enough time for me to go through them all, so I'll just keep it simple for you. When I look at the papers that we got, Addendum A, Option B, and I look at the illustrative premium there, it was $74.65. This is Option B. So then, given the premium that I'm seeing on the screen of $114.64, that's a difference of around $40 for the different benefits here. If I understand this page correctly, if I go up to the rates that are indicating 1A, which was in the prime board packet, the illustrative rates there were $44.60. So pulling out, changing the benefit design was already incorporated to that, and then changing kind of the pieces around it. When I do the math, what I'm seeing is a difference of $17.89. So why, when we're removing, or when you're plugging in all of the same actions, whether it be plan design A or plan design B, because the rates already included that plan design change, why is there a difference in how that rate's coming out? Shouldn't they both be $17.89 if that's the cost of the different benefits shown that have been reduced? Is that clear? I'm sorry, it's a bit convoluted. I'm just wondering, why shouldn't the difference in premium for items 8.2, 8.3, 8.4, 8.5, shouldn't that be the same whether you've gone with plan design A or B, the change in cost?
is Stephanie. I'm apologize. It's very hard for me to follow your 1789 and where you're starting and where you're ending. If you want, I can get into my spreadsheets and we could start going through those. I guess it's up to you as to where you want to go in order to make this
Well, I want to
palatable for
make it
everybody
simple,
to
but
follow along.
I guess the numbers aren't working for me. So if you take the agenda, the actual information provided in item number 8, and you look at option, I guess we're calling it option 1A, which is exactly what kind of the executive officer presented in the report, right? Looking at the modified CDHP, which had all of kind of the benefit reduction proposals, the approximate employee-only rate for the CDHP is $44.60 in that document, right? So then we've gone and we've looked at items 8.2, 8.3, 8.4, 8.5, 8.6, and 8.10, and you've incorporated those savings, which obviously weren't enough to capture the full 36, but you've incorporated the rest of the savings through a premium increase. So that's why I'm seeing a $62.49 on Plan 1A, right? So that's a difference from what was in the agenda to what's been presented of $17.89. So there's an increase to make up for keeping LTD, for keeping some of these peripheral benefits, keeping retiree health insurance. But when you do the same math on the plan design option B, the rate, indicative rate was $74.65, and now I'm seeing $114.64 as the employee only rate. So that's a difference in 40 for the same benefits, for the same reduction in benefits, because it includes the 8.2, 8.3, 8.4 savings and makes up for the shortfall. But I guess what I'm asking is, why is the shortfall different depending on whether it's plan design 1A or 1B?
So one thing that definitely changed from when Laura had posted the packet to when we were able to create the numbers on Sunday evening was that she was getting information from the GSO, I believe, on the headcount reduction. So we did make that change. We no longer feel good about the 2.5% number, which is what you saw in the packet for option A. It included a 2.5% headcount reduction. We moved that back to 2. Again, we're worried about banking on numbers that won't come to fruition once everyone resubmits their budget with their updated headcount. A lot of folks are not saying that they're going to reduce staff. So we have changed that number. So that 4460 in the board packet is likely not 4460 with the 2% headcount change. This one does include it now because I want it to be apples to apples to show you. I don't want to artificially influence one or the other. So again, everything behind the scenes on these two is exactly the same, except for the plan design are different from their actuarial values.
This is Betsy. I think another way of putting her question is, why wouldn't the rate on 8.1B not be $92 or $93 with those?
So this is Laura. I think what we're missing here is that the assumption in the board report is that the board is choosing the entire 16 million on top of the proposal here. So you're choosing a plan and you're choosing 16 million. But in this scenario, the board has not chosen 16 million. You're short of that 16 million. So that number is being added into the rates. And that is why you see a higher premium, because we have not achieved the entire 16 million.
Laura, this is Betsy. I think what she's saying is, though, more is being added into Plan 8.1B than is being added into 8.1A with that assumption.
That's what it appears to be.
All I can tell you is that the functionality is identical. These options are being priced identical for the 8.2, 8.3, 8.4, 8.5, 8.6, and 8.10. The rest of the difference I have to solve for via changing the state subsidies in order to get the one cell to equal $36 million. And in order to do that, I have to change the state subsidy for Aegis and for Reggie. And then these are the rates that result from that.
This is Laura Freed. Now that we've chewed on this for a few minutes, I'd like to return to the LTD benefit reduction possibility and see if Mr. Kemp has had time to consult with his underwriter and give us some possible additional savings. I don't see him. This is Laura Freed again. I don't see him turning on his video or unmuting. So that remains an outstanding item, I think.
Hi, sorry about that. This is Kurt Kemp with the Standard for the record. So I was able to get a hold of my underwriter. So thanks for your patience. Unfortunately, most of the savings in the plan is coming by that benefit reduction from 60% to 50%. Simply changing that maximum from 7,500 to 5,000 only really only drives about 20,000 in savings. The rate's about 5 cents less per employee per month, and that's because almost all PEB members are falling under that $5,000 max. So there weren't enough people over that 5,000 to help bring that cost down. So I hope that helps.
Thank you. This is Laura Freed. Thank you. That does help. I appreciate your consultation. So, board members, I think there is not, with that new information, it sounds like there's not a great feeling to pursue 8.7. Is that a correct understanding of the sense of the board?
Chair Freed, quick clarification. Mr. Kemp said it was just a reduction from 60% 7,500 to 60% 5,000. How about 50% 5,000 to age 65? I think we said it was 1.5 million.
This is Kurt Kemp for the record. Yes, an estimated 1.5 million to change the plan to 50% up to $5,000 maximum, 180-day benefit waiting period to age 65 benefit.
Thank you. Chair Freed, this is Tim. I would say to do that.
You would, okay. All right. PEB board, PEB staff and Aon staff. Can you take a moment to put that into your spreadsheets and tell us the effect on the rates, or is that a longer term undertaking?
So was that 1.5 million? It is a little bit longer because it was pre-programmed to remove or to keep.
Okay. Okay. I was sort of afraid of that.
Marcia, for the record, what if you just did the 8.8, just to give us a ballpark? If you put in 8.8, that's 1.7 million. So it would just give us a ballpark for it.
Oh, okay. That's a good idea. This is Laura Freed. That's a nice idea as a proxy.
This is Stephanie Messier. That's much easier.
Tim here. Thank you, Marcia.
So while Stephanie is doing that, this is Laura Rich. I just want to state that, there has been no recommendation from staff on these options, option A, B, or C on 8.1. Obviously it's a choice, right? It's, again, I went back to, you either choose higher premiums or better benefits, or with lower premiums, or I'm sorry, the other way around, lower benefits with better premiums, or vice versa. And so, none of these options are great, but I want to say that we're not preferring one or the other. Stephanie is merely plugging in numbers. And so she has it set up so that if you plug in numbers, this is what it shows. So, we're not trying to sway the decision or the board with these options by, making one look more palatable than the other. This is merely math. And, we know that whatever's chosen is not going to be a good option regardless.
It's Michelle Kelly here. Thanks for that, Executive Officer Rich. I guess my concern is that I can't, so as we worked through kind of I'm going to call them peripheral, but I don't really like that term because it makes them seem unimportant. But as we work through agenda items 8.2 through 8.12, we looks like we made significant savings, and there was probably only around $1.1 million left outstanding. And so then to see the premiums increase at such a large rate, I guess I'm having issues processing that change based on kind of the information we were given earlier. And so I don't mean to question anyone's integrity or your intent, but once again, you said the math isn't working for me, and I just don't understand why. Sometimes it's because I prefer the detail, but it seems like, given that we almost made the full 36 million in savings without having to increase premiums, that the premium, even with option B, where we saw an illustrative premium, it seems like the rates have gone up a lot based on what we thought and based on the numbers we've had before. And so that's the only reason I keep questioning. It's not because it's more because I'm looking for an error in the spreadsheet. It's not about the human person, but the rates just seem to, as I say, have gone up exponentially to make up for maybe a 1.1 million shortfall in the savings. That's what I can't reconcile.
So, and remember that Stephanie did mention, and it was a last minute decision to change this because of the information that we're receiving from the governor's finance office. That headcount number does have a significant impact as well. Keeping that at 2.5%, we could do that, but I just don't feel comfortable. I don't feel comfortable that we're going to reduce that number by 2.5%. I am actually optimistic with 2% still. So it's just something that we have to keep in mind, that there's other variables at play here as well.
So, but just a point of clarification on that. So reducing headcount to a benefit plan is bad, right? Because it's a smaller pool. Okay, so from going from 2.5 to a 2% headcount reduction should have actually benefited the rates, not created more increase.
This is Stephanie Messier. So we're doing a simple $299 million needs to go down by 36 million. So when you reduce headcount, and we give on average $700 per active employee per month, any employee you get rid of is $700 a month savings. That is the difference. So right now, reduced headcount does help, because PEB is not being asked to reduce how much it pays per person. It's asked to be reduced a very set figure of $36 million a year.
This is Laura Freed. I want to talk a little bit just for the board's edification about the active employee, actually both active employee group insurance subsidy AGIS and the retired employee group insurance subsidy REGI. AGIS is charged on filled positions. So if agencies all across the bureaucracy have submitted on Friday night, including my own, budget reductions that would entail keeping positions vacant, in which case PEB would not get the AGIS subsidy, or eliminating positions or even laying people off, again, not getting the AGIS subsidy. REGI, in contrast, is charged on gross payroll. Well, if gross payroll goes down, then the REGI subsidy pool to provide to retired employees group insurance also goes down. So the 2.5% reduction in headcount, I think that was active headcount, that the executive officer got from the GFO, I think may in fact be a little conservative based on things that I've heard through the grapevine. So board members, bear that in mind. When we keep positions vacant to save money, we hurt the AGIS subsidy.
So can I ask a next step question? So once we're done with today's meeting and, you know, the recommendation goes forward, when it comes back, I mean, can we continue to have input into the plan design, or what we decide here today is it? Because my understanding is it's just a budget recommendation. So, PEBP will, you know, the legislature will do what they'll do, but does the board itself, once we know, for example, what's happening with the state fiscal situation in December and the various milestones that we have coming up that talk about revenue, and then perhaps the final decision on what the revenue looks like, do we get more input on plan design, or is it your intent that this is it? And that the next time we talk about this will just be to determine rates?
Laura, you unmuted yourself, so I was giving you the chance, but I'm happy to answer.
I know, I felt like there was a standoff, like who's going to speak first? This is, I feel like this is both a board process question and a budget process question, and I feel like I'm more qualified to answer the budget process question. So I'll start with that. The unfortunate thing is that the budget process runs on one track and the board schedule runs on another track. And so we are at the point right now where the agency request was due on September 1st, and PEB already turned that in. So what they have, and that's been made public, that gets made public on October 15th. And so that's final, really, and no changes can be made to that. So now we are in the development process for the governor's recommended budget. As I said earlier in the meeting, the board's next meeting is in January, and however, the budget as recommended by the governor for the next 2 years has to be finished before then. So the input, I mean, these reductions are scenarios, as the governor's finance office put it in its memo, that they will consider when putting together the governor's recommended budget. Are they guaranteed to take them? No. As both the board members and public comment has noted, the economic forum might put the governor's finance office in an even bigger bind, or it might not. And so does the board have input on plan design? Not specifically in the budget process. The executive officer will certainly be consulted behind the scenes as GovRec remains under development. But so from a budget process perspective, this is ultimately the last stop. From a plan design perspective, It's not based because, of course, the board has the traditional March rates meeting upcoming, and that's where I'll hand it off to Laura Rich to talk about the PEB board track of this.
So this is Laura Rich. It's not only the PEB board track, but there's also the PEB staff track in open enrollment. As you know, we have a very limited window where we can make plan design decisions and have the actuaries be able to come to the March board meeting and present those rates in March. If we are making plan design decisions in January, it's ultimately going to conflict with what has been submitted in the governor's recommended budget. And so, we're put in a really difficult situation here. As the executive officer, I have to defend what is in the governor's recommended budget. And so making those plan design changes that are conflicting with what has been included in that recommended budget is it puts me in a very awkward spot. Additionally, we have to work towards open enrollment. And so that window of opportunity between March and open enrollment is very, very busy for PEB staff. We not only have to load rates into the system, we've got to test them, we have to make sure that the system is working correctly, we have to update plan benefit guides, we have to update master plan documents, the website, all kinds of communications that are going out to members. There is a lot of work that goes into, we are in scramble mode after the March board meeting, essentially. And so unfortunately, it comes down to timing, and like Chair Fried said, there's different tracks, and unfortunately they're not on the, they're not parallel or perpendicular or whatever however you want to use that metaphor. It's definitely it's a scramble when we make any plan design decisions after November.
This is Stephanie Messier. I did just want to report that it looks like option B in the addendum sent this morning was not set to a $20 million savings. It was set only to, it looks like, $5 million. We didn't carry it through to the final step as we were trying to hurry and get that out this morning. So that's why you're seeing that different in your math is not hanging. So again, I apologize. The rest of the spreadsheet is hanging, right? We're flipping the same yes and no's with your options, but when we copy and pasted the rates this morning, it was only saving the plan, it looks like actually $6 million. So there was $14 million that still needed to be saved by changing the Aegis and Reggie amount to get to the full amount of savings needed. And it looks like we sent out the wrong one this morning to Ms. Rich. So the rates we're showing now are the correct rates as we're toggling these options to make option 1A and 1B on a similar basis. What was included in the addendum this morning was only a $6 million savings, not a $20 million.
Stephanie, we can't see, this is Laura Rich, we can't see your screen. I think you need to.
Yeah, I'll switch it to the Excel so you can see. Yeah, here you can see the numbers are similar. Again, this is Stephanie Messier to what was sent out this morning, but the savings, this red number here, I don't know if you can see it, is the key that we're trying to get to 36 million. And right now, with all the options set to no and being as the plan is today, with the designs in July, the rates are this, similar to what you saw in the board packet in your addendum. But this is the key number that we're looking at, and that's $6 million. That's not set to 20. which is what it should have been in order to be included in that addendum to be on a similar apples to apples basis with the other designs.
I appreciate you going back and looking at that. That makes a lot more sense, I think.
Yes, I apologize. It is hard to follow numbers live and on the screen. So thank you for your patience.
This is Laura Freed. Thank you, Stephanie. So is it possible to go back to your 8.1A and 8.1B table, knowing what we know now?
Yes, this one is still valid. So this is based on your choices that we've most recently discussed,
okay.
And the two differences.
This is Laura Freed. Did we put in 8.8 as a proxy for the 1.5 for 8.7?
Yes.
Okay, great, thank you.
I'll double check it though, just to be sure.
Okay.
Yes, that's correct. They're both in there now with the proxy on the Part B subsidy thing. Yes, just to model the impact of the augmented LTD. Stephanie Mentier for the record.
Laura Freed for the record, thank you. Okay. Board members, can you all see that? So 8.1A with all of those choices, employee only coverage becomes 5804 per month. Employee plus family becomes 31203. Again, that's a ballpark figure based on many assumptions, but close. And then in plan design B, employee only 111 per month and employee plus family 437.80. So we have brought ourselves back to the essential choice now between plan design A or plan 8.1A or plan design 8.1B. I've heard Mr. Lindley say he prefers A. I heard Mr. Verducci say he prefers B. And I don't think I've heard definitive statements from other members. So I will ask for that.
This is Jennifer Krupp for the record. I prefer plan design A.
Linda Fox for the record, I also prefer A.
Okay.
It's Michelle Kelly here. know, we've talked about no good options, but I believe Plan Design B is better for my constituents.
This is Laura Freed. Thank you.
This is Marcia Urban for the record. My constituents said they didn't want to lose the benefit, so I would go with Plan B.
Laura Freed for the record. Betsy Ayello, I'm sorry to put you on the spot.
Yeah, I was going to say that I hate to give up the benefits, but I'm just a little worried about the young families in the program, the level of the lowest premium per month. But overall, I think Plan Design B is better for max out of pocket. So I think I'll go with that.
And this is Laura Freed again. Let's see if I have this. Laura Rich, have you kept count of that? I have two, but I want to cross check my numbers. You guys know how bad I am at this.
Laura Rich, I have 3 A's and 4 B's.
I have Betsy Ayello for B, Marcia Urban for B, Michelle Kelly for B, Tom Verducci for B, for a total of 4. And then under A, I have Tim Lindley and Linda Fox and Jennifer Krupp. So 4 B's and 3 A's. That
I guess, Chairperson Freed, I'd just like to put one thing out there, and I know there's a time crunch and all the rest of it, but I did just want to perhaps request that the vote be delayed until early December. My concern is that just because of the numbers kind of changing from, I think, what we were working on with our constituents, it would be great to go back to them and actually get some feedback before finalizing. Sorry, Laura.
This is Laura Freed. You know, the problem with that is that GFO is already waiting on this. The rest of us had to turn in our budget reductions, which was great fun for us directors, last Friday evening. And as soon as this memo dropped, the executive officer was on the phone to me brainstorming options. So she has been working on this since early November 3rd, I believe is when just looking at my calendar, when it dropped, and it's now November 23rd. So she's been working on this basically for 20 days, as has the vendor. And actually we had to go to the GFO and say, we can't make that deadline because there's a board meeting after your deadline. And so she got a special extension that everybody else didn't get. And so to extend this until December, first of all, puts pressure on the GFO, who has to do things build a budget in a very methodical and scheduled way. And I think causes PEB staff to have to get us all together again, which is pretty difficult to do. So I'm frankly not receptive to that. We unfortunately all are appointed by the governor. I don't say it's unfortunate the governor appointed me. We are all appointed by the governor, and unfortunately we get appointed to do hard things in this kind of a fiscal climate. It would be great if we got to be PEB board members in a time of increasing revenues, and all we had to do was enrich the plan design. but we don't get that. That is not our lot in life. And so I'm frankly unwilling to do that right now. We have to make a choice, and it has to be an unpleasant, least worst choice.
May I please ask a clarifying question? This is Jennifer Krupp for the record, but I'm looking back because we've had 4 votes for Plan B and then 3 for Plan A. And I'm looking at the differences really, and what Stephanie Messier had put up was that for the CDHP plan, it would take for the, one employee only enrollment up to $110 a month. And looking at the benefit design that was sent in Addendum 8.1 as well as the board packet, really the only differences that I'm seeing is, an out-of-pocket max of $5,000 and $10,000 for option B versus $6,000 and $12,000 for option A. And then a difference of $200 for the HSA account. So the HSA contribution would go to $500 in option B versus $300 in option A. So correct me if I'm wrong, but I'm not seeing a difference in, almost $40 for that difference in benefits.
So this is Laura Rich for the record. And sorry, I'm sure Stephanie's on the same page as I am right now, going from one option to the other. And the board is seeing these 3 options. We've actually seen like 38 other ones. And so it's we're trying to keep them all straight. So I think let me compare the 2 here. Trying to bring them, believe we did something to the HMO as well. Let's see, Stephanie, did we add, it looks like we added the deductible, no, just the out of pocket on that one. I think we did a few other things with the HMO and the co-pays.
Yeah, I think the biggest changes were like for the inpatient hospital and for ER visits, like applying deductible in addition to a copay based on talks with HPN.
This is Betsy. Listening to Jennifer, because I was so on the fence. Maybe I want to go the other way. I'm sorry I sound that back and forth, because I am really worried about some of the pre-Medicare retirees and the families with the younger workers with the higher premiums. And I think I just didn't get enough time really to see all of these. So I'm sorry, maybe I should switch, and I hate to be so wishy-washy, but I'm looking at the other one again. Because with the added from 300 to 500, that does decrease what the premium would be, but not by 40 a month, because that does give people more money. And then it is just the max out of pocket that's the difference in the cheapest of the plans. So I think I'd like to switch. I'm sorry. It's just one of these where it's hard to know it. We wish we could go out and poll the people.
So Betsy, this is Laura Rich. You're switching then to A.
Yes, I'm sorry. I'd like to switch to A based on Jennifer's input, and I just looked myself to see the differences. So I'm just worried about such big, I know everybody is.
All right, this is Laura Freed. So that brings us to 4 A's and 2 B's by my count. Laura Rich, is that what you have? Okay. So with that, I think we have reached a decision, a very unpleasant decision that nobody likes, that nobody wants to suggest. And I think I need to underscore here that the governor's finance office and the governor's office are aware of how ugly this is. And I believe that they are watching and they have heard some, if not all, of these deliberations. And, you know, it's always possible that they could choose to make up a budget shortfall with furloughs or pay cuts or something else that doesn't hit benefits as, and I'm not saying they will, I don't have any inside information. But I do believe that they understand what a contentious and sensitive issue health benefits are for employees. That I can say. So,
Madam Chair, not to make this worse, but in case we are asked to, we've gotten to the 16 million. In case we are asked to, let's say we need 14% instead of 12%, rather than calling a board meeting in December during the holidays, it might be good for the board to make a decision too as to what if we are asked to make that, 13, 14, 15, who knows what that number is going to be. Do we want to just look at increasing premiums? And if that is the option, then I think it needs to be spelled out so that it gives us that flexibility.
This is Betsy. I'm just throwing out the option of, again, 8.8 and 8.9 that were the elimination. Is there like dropping them by 25% instead of totally eliminating? I don't know if that's an option or if it's just nickel and dimes and wouldn't really help you.
So this is Laura Rich. I guess, Betsy, that all depends on how far into that elimination the board is willing to go. If it's 10%, then it's really nickel and diming it. If it's, 50%, maybe that's something that, we can look into, especially if it's 8.9.
It's Michelle Kelly here. I think that given the extent of the cuts so far and the things that we haven't, that we have not prioritized, I would prefer to come back in a special meeting. I don't believe the 3 items that we have not prioritized should be considered. So, whether it be premiums or other plan design, I'm not prepared to prioritize 8.7, 8.8 or 8.9 at all today.
Marsh Sherburne for the record, I agree.
all right. Executive Officer Rich, I think much to your chagrin, I think if the Public Employees Benefits Program is asked to make something more than 12%, we may have to shoehorn in a December emergency meeting, and that's okay. We'll just see what happens at the Economic Forum, and let us go with what we have today and hope that that is the only thing that they ask of PEB. With that, I'll see if I can make this motion to make sure that it is clear on the record. I move that the PEB board, in order to meet the lower targets established by the governor's finance office, direct the PEB staff to amend the budget such that we go with option 8.1.A in terms of plan design, and include as additional savings measures 8.2, 8.3, 8.4, 8.5 option 2, 8.6 option 2, 8.7 reduce the LTD benefit to 50%, 5,000 max up to age 65 with a waiting period, and 8.10, and anything that does not then reach the 16 million is made up in the premiums. Thank you, Stephanie.
You're free. Stephanie needs to jump in here because I think she a small error.
Okay.
Yeah, this will teach me, Stephanie Messy for the record, to try to show numbers on the fly without peer review. This is why we don't do this. So during the meeting, I had flipped one of them to 23, trying to show what we would see in 23 with an extra year of trend. So as you might imagine, that makes another additional difference. So before you vote and move forward on A versus B, I wanted to take this opportunity to interrupt. These are now both on year 22. And I apologize.
All right, this is Laura Freed again. Okay, let's go back to the drawing board then. All right, board members, take a look at this. Does anybody wish to change their feeling now based on this?
Tim here. Knowing that rates will potentially increase, I'm going to maintain my decision for option A, 8.1A.
Okay. This is Laura Freed. I'm not hearing anybody change their feeling on this one. So again, let me try and see if I can state the motion correctly for posterity. I move to present budget reduction scenario involving plan design changes as reflected in 8.1.A, including the savings measures in 8.2, 8.3, 8.4, 8.5, option 2, 8.6, option 2, 8.7 to reduce the long-term disability benefit but not eliminate it, and 8.10 unbundling of dental premium. And to the extent that that does not get the board to its $36 million subsidy reduction target, make up the reductions in the participant share of the total premium. Do I have a second on that motion? And does it make sense to you all?
Tim here. I second the motion.
All right, thank you. You've heard the motion. It's been seconded. Is there any discussion on this motion? Okay. Hearing none, I will ask Ms. Rich or her staff to do a roll call vote so that this is clear for the record again.
Nicole, are you able to do a roll call vote, please?
Yes, I can go ahead and do that roll call.
Okay.
Linda Fox?
Aye.
Linda Fox,
You didn't hear me? I vote yes.
Betsy Iao,
Yes.
Michelle Kelly,
No.
Jennifer Krupp,
Yes.
Tim Winley,
Yes.
Marcia Urban,
Yes.
Tom Verducci.
Yes.
For the record, is the with all the 8.2 and the rest of them, isn't that 16.4 million there?
This is Laura Freed. I believe you are correct that 8.2 through 8.10 is more than 16 million. And I'd have to do the arithmetic real fast, but I believe you're right.
Marcia Urban, for the record. So that's been reflected on the on Stephanie's A and B plans here, right?
This is Laura Freed. I'm not sure I understand your question. Because since
for the record, is that 1.5 that we had, is that now in the plans? A and B, I know when we changed it, we ballparked it at 1.7, but is it now correct in there at 1.5?
This is Laura Freed. I think it is still in there at 1.7 as a substitute for the 1.5. So there might be some small adjustment of a few $100,000 there.
Okay.
And this is Stephanie Messier for the record. So the one thing about that line item is because it's a Part D savings and the LTD is just an addition to the active rates, you're not going to see it reflected correctly. So it changed your overall savings to 36 million because of where the three different buckets are. But the way we had it modeled right here, it's not going to flow through to the active side, which is where it really would be reflected in actuality when you change the LTD. If I would flip the LTD toggle right now, it would do it correctly, but not by the right amount because you're not talking about eliminating the LTD.
So Stephanie, these rates, based on what your explanation just now, these rates will actually go down if that was the only influencing factor.
The change in LTD is your question? This is Stephanie Messier. Yes, that's correct. So when I toggle the LTD to yes, you will notice the state active rates will go down because it's a savings on the state active employees, whereas the retiree rate would not change, nor obviously would the Medicare exchange amount change.
All right, this is Laura Freed. Any other final questions?
Tim here. So as an active employee, the goal is, the next step would be to try to increase the subsidy if we wanted to lower our premiums. Is that correct? I will be an active member. The next step.
Okay. All right, unless Ms. Rich has something else, I think that brings us to the end of agenda item 8.
The only thing that I want to make sure that it is on the record is on the dental option. I want to make sure that it's on the record that it is an opt out, you cannot opt into dental without being on the medical plan. So dental is not just a, $5 gets you dental. So I just want to make sure that's on the record that that's not on, that's not going to be a plan benefit design change.
It's Michelle Kelly here. At the risk of blowing this whole thing up or being shut down, why, I guess when I see the rates, why would we even separate dental out? The rates we were looking at were dental intact, right? Dental there. And it was $58 per employee. If dental is important, so I'm just wondering, does the board still want to separate it out as a separate premium if we're not going to be doing COVID subsidies or anything exotic like that? Is the point still valid? No one wants to take it? Okay.
I'm not even sure how to answer it. Sorry, this is Laura Free for the record. I'm not even sure how to answer it. Using the $58 hypothetical premium, and I were to opt out, I pay $55. And so the savings is generated by the estimated, correct me if I'm wrong, please, PEB staff, the actuarially estimated number of people who would opt out of the dental cost.
Opt into the dental cost, I believe, is the correct. So we're charging that extra $5, $10, or $15 for the record, Laura Rich. We're charging the $5, $10, $15, and so essentially that is where you get that extra savings.
All right. This is Laura Freed. I think, thank you for putting the that on the record, Ms. Rich. I think we should move to agenda item 9, public comment. And so I will let PEB staff take it over.
Okay, and for public comment, there's a slide that I'm about to share. On the slide, it says how to enter public comment, what phone number you need to dial, as well as the meeting ID number. If you do have public comment, please be sure to state your first and last name for the record. Just as a reminder, when I unmute your line, you'll be asked to select *6 to unmute your line. Again, for those who call during public comment, I will state the last 3 digits of your phone number, and I will advise you that your phone line has been unmuted. Kent Irvin, your line has been unmuted.
Hello, this is Kent Irvin, K-E-N-T-E-R-V-I-N, Nevada Faculty Alliance. It's been a very long day and I don't have prepared remarks. I'd like to thank everyone for going through this process and that at least we avoided some of the worst cuts, elimination of benefits for various groups and retirees. However, as you know, we're not in a good place with the plan design or the premiums for that matter. And I fear if these are selected by the governors in the governor's recommended budget, that particularly the plan design changes will be very hard to reverse in the future. I had more hope that we could possibly work on the state funding amounts to increase the employer contributions. But anyway, I appreciate everyone doing all this hard work. I do have to put on the record that it was very disturbing that decisions are being made without taking the time to get the numbers right. I know that's very difficult. I don't fault the numbers being wrong, but it's a matter of not having the time to take a break to get the numbers right. And so that's very disappointing. Thank you very much.
Line ending in 003, your line has been unmuted. Line ending in 404, your line has been unmuted. Line ending in 947, your line has been unmuted. Line ending in 987, your line has been unmuted. Doug, your line has been unmuted.
Am I on Zoom or?
You are on Zoom. You are on the public comment.
Yes. Okay. Sorry, I've got a feedback loop going on here. Excuse me.
Hey, Doug, can you mute your computer? It sounds like we're having some feedback. Your YouTube.
Yeah, I'm sorry. There was a feedback loop going on here. This is Doug Unger, UNGER. I'm a member of the UNLV Employee Benefits Advisory Committee, chapter president of NFA, also chapter past council faculty senate chair, and I've been attending PEB board meetings for 9 years. I originally got involved in advocating for restoring our benefits from the last recession because I knew an administrative assistant, because of high out-of-pocket medical costs, actually lived in her car at our university for more than 3 months. And I've known many others who have suffered greatly because of the high deductibles and high out-of-pocket maximums. There are a couple of things that came out at the meeting today which were misrepresentations about the CDHP plan. One was that it was said that mainly only younger people who don't really need it are using it, and that is not true. The old adage in Southern Nevada is if the ambulance picks you up, don't tell them to take you to the hospital, tell them to take you to McCarran Airport, because you get better treatment out of state than in state. I have personal experience with this with my wife, who suffered from a condition from which she would have died if she had not gone out of state, because there was no medical provider in Nevada who could do the specialized surgery that she needed. And if we had not been on the CDHP plan, I shudder to think how we would have ever been able to pay the costs. And fortunately, we had it. Even though we were out of pocket $18,000, not the $3,900. This has been a really terrible meeting after 9 years of advocacy to restore benefits, to see what's happened now. I want to inform the PEB board that this is unacceptable. That despite all your good work and all your goodwill, what the governor has asked you to do with our health benefits is unacceptable and will be unacceptable to faculty and staff of the Nevada system of higher education. I see no other option now left for us than to do what we have been talking about doing for years, but have avoided pushing doing. And that is right now to commit ourselves as a system with our independent board of regents to try to separate ourselves out from the public employee benefits program. We've researched plans. We can get far better plans with our constituency group than is being offered by PEB at this time. PEB should seriously consider and should seriously inform the governor's office that we will begin to push to separate ourselves out. The reason is that we can get a better plan, but there are also other reasons. We can develop our UNLV Medical School clinical practice, UNR can develop its clinical practice, and we will all be better off. I'm very sorry to tell the board this, but the governor needs to know he will wear this. He will wear what he's doing to our healthcare benefits like he won't wear the furlough or any other cut that we're going to suffer. After 9 years of working to restore benefits, to see what has happened in this meeting, to see them stripped so down to a C- medical plan that we will not be able to hire on. We won't be able to hire quality faculty for our university with this health plan. It just won't work. So I'll get with Michelle Kelly. Thank you very much for your advocacy on this board and all the members of the board for your good work. I know it was very unpleasant and I appreciate everybody's work, but this is just basically unacceptable. And I'm hearing from members right now, my email's lit up. We'll just have to work now to try to separate ourselves out from PEB. And that's all I've got to say. Thank you very much.
Line ending in 111, your line has been unmuted.
Hello, this is Sean Franklin Sewell for the record, and I'm the chair of the UNLV Employee Benefits Advisory Committee. I have several things to bring up in public comment. The first thing is that I want to echo what Doug said, that only young people with the least expensive health care on the CDHP is a misstatement. Many people who are on specialty medications choose the CDHP because the coinsurance is 10% more on the other plans. Secondly, by choosing option A today, you have cost employees on the CDHP $3,170. Those are people who are employee-only coverage, and that is in benefit cuts and additional premiums. Third, Chair Freed referenced our surcharge idea as a simple rhetorical device. I would like to point out that it might be a rhetorical device, but it's one with real consequences for our future benefits and premiums. By calling it a surcharge, that means the possibility that it would be removed is held out there. Let's see. Fourth, I find it objectionable, to say the least, that the numbers changed today from what we received in the report. The amount of attrition, if you will, went from 2.5% to 2%. Other numbers changed. The spreadsheets were all incorrect. I believe that the meeting should have been halted, and that either a break should have happened while the numbers got correct, while documents were represented, and then we could all look at them. Or the meeting should have been moved or adjourned until December in order for that to happen. I understand that the governor's finance office wouldn't allow that, but maybe this meeting should have been scheduled earlier once we knew what was going to happen, to give staff and advocates enough time. And finally, I also have a major problem with the chair not allowing public comment before the vote on agenda item 8. For the past 3 to 4 years, that has been the practice in these meetings. And we were told that that would likely happen again today. It did not. So I do want to thank all of you for your work. I know this has been hard. I do want to thank Laura Rich for her help with all of this. And I also want to thank Michelle Kelly for her advocacy for INSHE during her first meeting with the Public Employees Benefits Board. Thank you very much.
Line ending in 118, you have been unmuted.
For the record, this is Jose Garcia. First, I wanted to thank the board for all your work today. I know there wasn't any chance of a good outcome, and that's certainly not your fault. I, too, I am disappointed with what has happened today. As I said earlier in the day, or earlier this morning, the benefits have been stripped away year after year for one reason or another. Some things we got back, a lot of things we did not. Right now is a really bad time to be stripping away benefits. You know, the furloughs that are coming, it's just not good. And while there was no good option, again, I thank you guys. You did the best you could with the data and resources that you were given. So thank you for your time, and thank you for hearing me.
Brian, your phone has been unmuted. Kevin Ramp, your line has been unmuted.
I'm sorry, can you hear me?
Yes, we can. Thank you.
So good afternoon, Chairwoman Freed and committee members. Again, my name is Kevin Ramp, representing AFSCME Local 4041 active state employees. I'd first like to thank everyone for your hard work during these difficult times. More could be done, clearly, in this situation. State employees are extremely disappointed with the cuts approved today. There will be numerous unintended consequences based off of the various increases to potential increases at this point to the premium rates, and then the dramatic cuts to the benefit package overall. There's clearly going to be that unintended consequences that we would hope that this board would come back when they find out the possible revenues, what that's going to look like, and make a determining factor based off of that revenue stream. We hope an emergency board meeting could be called in December to address some of these plan design issues. State employees live paycheck to paycheck. We all know this. There's time and time again, we have nothing but state employees moving out of the state, calling us and letting us know that they need to adjust the health care plan. We're talking in the last 10 years, even longer. And that was when the times were good. Now times are bad. Now they have extremely difficult choices to make. Put food on the table, pay their bills, or get health care. Very, very disappointing. We understand this is very difficult times, but I would have hoped that respectfully, every single board member would have contacted the governor's office and said personally that the 12% is not viable, not sustainable, and something that the governor's office should reconsider and ask for a lower percentage to work with, something that we could have all lived with. And respectfully, that's not what happened today. I do ask going forward, if there is an opportunity to do an emergency board meeting in December, to do an adjust plan design based off of new revenues, potential stimulus package, or whatever else could be done, that would be taken into consideration. Because again, we want to ensure that benefits are the last thing we cut, not the first. I appreciate your time and thank you.
Margaret, your line has been unmuted.
Yes, this is Margaret Miller, and I'm not really 100% sure what happened today or what actually was decided, but as a retiree that is not eligible for Medicare in any form, I'm not really sure what this is going to actually do to me or the people that are in the same position I am. How many other changes? It sounded to me like you were taking away some of the subsidy, and if you take the subsidy away, I know you've got to raise rates. I get that. I just don't understand, I guess. But you were talking about eliminating, and I don't know, the Part B subsidy, and I'm not sure exactly where you ended up with on that. So are you cutting that back, or is that going to stay the same? I worked 30 years for you guys, and you only give me credit or a subsidy for 20 years. So to start off, I am 10 years in the hole with the subsidies. So, and I was listening to find out where we were going on the premiums. And like I said, I'm still not very sure how all that came out. I know they're going to be going up. How much they go up, I don't know. I figured I was are you still putting us on the exchange or what? I figured if you raise them too much, I won't be able to even afford insurance either. So it's really tough. I understand that but I think the governor's office should not be trying to balance the budget and the shortfall that we have going on. And a lot of it is not through their things. It's just something that happened with the COVID. But you still should not, my opinion has always been, even when I was a state employee, an active employee, that you should not be balancing the budget for the state on the backs of not only the state employees, but now you're doing it on the backs of the state retirees. And we're people at our age, because I'm 78, we're people that have not got the option to go out and earn a living, buy insurance, and we live on a restricted income anyhow, and I'm a widow. So, but I thank you for everything that you've tried to do, and I know it's a hard thing to do. So hopefully some good news will come out of this at some point in time. Thank you very much. Appreciate it.
Brian, your line has been unmuted.
Good afternoon, Chair Fried. I'd like to thank you and the members of the board and the staff of PEB for all your hard work. I know it was very difficult to make all those cuts that had to be made, but having been employed in the state as a budget person for a long time before I retired, I know that a lot of times you are faced with difficult decisions. And so I do appreciate how much time and effort you put into this. And I especially appreciate how you protected the state retirees with your actions today. We were, looking at some of the options that you had on your agenda for the state retirees. Left a real pit in my stomach, but I think you really did the best you could to keep retirees with coverage. So again, I'd like to thank you for all your efforts.
Line ending in 441, you have been unmuted. I know this particular member was having a hard time. So just a reminder to hit *6 to be unmuted.
Hello, my name is Alejandra Livingston, and on and off I've been watching the board meeting today, but because of work I really could not pay full attention. And I wanted to let you know that I submitted some comments in writing just because in the morning when I signed in, for some reason I was not called to testify. And I am not fully aware of what is the process for designing the plan and making a final decision on it. I wish I had more time to look into. I got home on Friday night and I received an email from AFSCME, of which I am a member, and I am a state employee for 24 years. And I have a background in business and economics and public policy. And the one thing, in addition to the comment that I submitted, that I want to say is that I don't feel like enough people were aware of these decisions. I got to work this morning and I talked to a few people in the office, many of them who are not there either because they're on a quarantine or because they are on their Thanksgiving vacation. So when a drastic measure like this is being proposed, like proposing to cut subsidies for retirees, dependents, and trying to take non-Medicare employees out of the benefits that we all work for so many years, it seems to me like there should have been more awareness. It's just part of the democratic process. And I don't feel, and I may be incorrect, but I don't feel like that happened. And a lot of decisions were made today without having everybody's comments. So I just don't feel like that's right. And like many have suggested today, I feel like we are being cheated because a year and a half ago, we were promised a state where there would be focus on family and children. And some of us have children that are young adults and are in college. And like me, I'm about to retire 2 years from now. And I have children in college who are on my benefits. I have 3 chronic medical conditions for which there is no cure, and I have 1 to 5 medical appointments per week. And twice in my career, I was very close to going on disability. And the reason I am not in disability is because I believe that I have decent health care. I have intermittent FMLA with the state and with flex time and the medical appointments and so forth. I've been able to stay on the payroll without having to go on disability, because once you are going on disability, you're not approved to go to work elsewhere part-time or so forth. So it's a huge decision. And my children also have medical conditions. I have ongoing medical appointments. And I'm not sure what final decision was made today, but I would urge you to please reconsider some of those measures and to make sure that more people have the opportunity to provide input. And if this is a decision being made because of the coronavirus emergency, just like some people suggested earlier, maybe this is something that needs to be just temporary, because every single recession, they propose to cut more and more and more from us. And there will be more recessions. I am trained in economics. I know the economy cycles. We already legalized divorce, gambling, prostitution, marijuana, all measures that are compromising values for some of us. And those measures have not raised enough revenue to raise to have more reserves, so that every time that there is a recession, that you guys don't take it on us. I work in less than desirable working conditions, and I've been affected by hiring freezes, and ever since last recession, I've been doing 3 people's jobs. And now because of coronavirus, one of those positions that I got back, that position is on a quarantine. So I'm again doing 3 people's jobs. And not all the agencies are allowing their employees to work from home. I am not being allowed to work from home, although I have a chronic condition. So it is unfair that on top of the furloughs that we're going to have to assume as of next month or a month and a half, then on top of that, we'll have to pay more for insurance. It seems to me like Nevada needs to put more effort into restructuring its economy, diversifying it, so that every time that there is a recession, you don't have to take away from us, from the employees. Recessions are going to continue to happen. The next one is going to be a climate change recession. So what else are you going to take away from us? I know you all work very hard today and you have to make very difficult decisions. I totally understand that, but I feel like it isn't right that all these decisions are being made without sufficient input from the employees and the retirees, and that we were promised a state that was focused on family and children. And we're being told yesterday that an 8-year-old committed suicide because that child can't go to school. Well, so is with college students. College students right now are doing university work from their rooms, and they don't have their parents around to provide some support. And the last thing that they need to hear is that the state might take away their medical benefits. Thank you very much.
Line ending in 338, you have been unmuted.
Good afternoon. I know it's been late. This is Priscilla Maloney again with the AFSCME retirees. Can the board members and Chair Fried hear me?
Yes, we can.
Thank you. I would like to correct some things on the record today that were said specifically on, there was a global generalized discussion under agenda item 8.5 about the Medicare exchange retirees not using a certain proportion, not using their max allotment of the employer contribution to their premium costs on the Medicare exchange. So I'd like to refer you back to agenda item 4 on your April 27th, 2020 meeting, wherein this issue, as Ms. Ms. Rich touched on today, was fixed in the sense that there were caps involved. I'd like to state for the record some facts, because as other public commenters have noted, we've been very hasty on the facts, and in fact, even had to have some corrections from our actuarial aeon in the middle of this meeting, and then have the board members put in the difficult position of voting on issues where the facts were literally moving while they were trying to ascertain what their vote would be. So back to April 27th, 2020. This is at this is agenda item 4, and it's a PowerPoint presentation, and it looks like the pages were not numbered, but at least it's in there. And they talk about how they're going to cap the HRA rollover amounts. We've agreed, and we had discussions during that meeting, that many of the exchange retirees purchase Medicare Advantage plans, and sometimes there is a zero premium. So steps were taken back in April of this year. I would like to put on the record that the amount, and it's on this PowerPoint that's in your archives, the amount of retirees on the exchange is approximately around 11,000. This was 3,178 who were not using their max allotment. That is not a suggestion that this is poor policy to give them the allotment they have. So we've gone down to $13 to $11 now by the vote today. The AFSCME retirees are very disappointed in that, because that may not sound like a lot when you're putting it in the abstract, but these are people on a fixed income. They are already capped at 20 years service. So if there's a 30-year service person on the exchange, it's already in the statute, in your appropriations bill from last session. You can check it. Any funds that are not used by that retiree go back into the fund. They do not go to their HRA account necessarily. So I would just like to clarify that for the record. Again, we are very disappointed, but we do, in the decisions today, we do look forward, though, to working with both the executive and legislative branch in regard to these cuts, and we will hopefully have some productive discussions around this at the interim benefits and retirement benefits committee meeting in December. Thank you.
Clarabelle, your line has been unmuted.
Hi, my name is Clarabelle Zecenia. Last name is spelled Z-E-C-E-N-A. So I have been a state employee now for 9 years, and I'm actually the AFSCME co-chair of the PEB and PERS committee for the AFSCME Local 4041. And first I want to thank everybody for your time. I know you guys had to make some really hard decisions. However, I want to echo my fellow members in describing my frustration with what PEB continues to do. I understand that we have to make sacrifices, but the fact that we keep losing benefits makes it hard to stay in state service. So the state eventually is going to start losing its qualified staff. We're going to leave. If you work for the county covers your premium. They put you in a high deductible plan, but you don't have to pay anything out of to keep in there. They're getting better wages than we are. We're getting worse. We're lower paid. We get ones that continue to suffer during the months of economic hardship. So I understand where it was, but this had the option of postponing to December, the ability to vote and to send a message to say, no, we can't do this. Our employees are, this is asking too much. Can we come back and see, like, and if we have to take a cut, that can we negotiate that? Because we're already facing furloughs. We're already going to face who knows what when it comes to the next budget. But the fact is that you've already are digging more and more into our pockets. That makes it hard to continue to provide a service to this, to our state. We're already sacrificing ourselves because we know what we enjoy, the services that we provide and the services that we help our fellow citizens of Nevada, but we just keep getting hit over and over again. So I really hope that this board can send a message to the governor's office to say really to send its discontent of where we are at. I appreciate that we are in a hardship, but it has to start making other decisions on diversifying this economy, because we can't keep doing this. Not every single recession, we can't keep doing this. So again, thank you for your time, and thank you for everything that you did. It was a long meeting, so I appreciate that. I've been on the other end of these meetings, and so I can see what it takes when they last this long, how it can be a toll on you. So thank you.
Jody, your line has been unmuted. Madam Chair, that seems to be the end of public comment.
Okay, this is Laura Freed. Thank you very much for all of that. All right, so it's good grief. This was a long one, my friends. It is time for adjournment. As a final note, I just want to thank everybody on the board for their spirited discussion. It's been watching the board for a lot of years previous to being on the board, and this is the most engaged I have seen a PEB board in a very long time, and I know I've said that in past meetings, and I mean it. And this is the awful part of being on the PEB board. I hope you're all on the PEB board long enough in the future that we can do fun plan design enrichment in future biennia or future fiscal years. So thank you for your work today. Thank you for managing to surreptitiously eat your lunches while you continue to participate. I know it's no fun to not get a lunch break. So it's 4:52 by my clock, and I think we are adjourned. Thank you, everybody.